start edifying sessions. In Hall A, we have Dr. Nirmala and Dr. Aditi, and in Hall B, we have Dr. Nikita and Yashopurna to take you all through.
Thank you, ma'am. Welcome back, dear delegates, to another fun-filled day of PHONOCON 2022. We had a successful day one of our scientific programs with an exhaustive list of fantastic talks, guest lectures, paper presentations, and informative surgical videos. Today, we have in store for you orations by some of the best in field of laryngology, including eminent international faculties like Dr. Stephen Zietels and Dr. Andreas Muller.
Let us begin with a topic that is of utmost importance to phonosurgeons and that which may often be neglected, voice therapy. We have with us the renowned laryngologist, Dr. Ilter Denizoglu. Sir is the director of the Clinical Vocology Unit at İzmir Ege Santi Health Center in Turkey, with several publications and innovations under his sleeve. Sir has been kind enough to join us live at this early hour in the morning, as it is 5:30 a.m. for him in Turkey right now. Thank you so much for that, sir. Delegates are encouraged to put forth their questions during the talk in the chat box provided, and sir will address them at the end of the session. Over to you, sir.
Dear colleagues, dear friends, I would like to thank you for this opportunity and for your kind invitation. I'd like to speak about voice therapy for phonosurgeons. My conflict of interest. In terms of physics, what is the difference between muscle and flesh? Yes, the answer is muscle moves, the flesh not. Then what is the difference between anatomy of a cadaver and a living human being? I mean, we try to understand anatomy from cadaver studies, right? But it's different. What is difference? What is the difference? Motion. Motion is the main difference when you compare the anatomy of a cadaver to a living human. So here, as we are dealing with living human beings, we need to understand and explain the motion out of what we see at the anatomy. To explain voice therapy in a very short way, we can say form follows function, which means if you can change the function to this, then you can change the form as well. As you can see on the left, the patient with nodules, on the right, the same patient without nodules after voice therapy. But how can we see, how can we explain, assess the function in the structure? First of all, we need to erase, we need to get rid of some details, such as colors, some, lines, and we reach to the mass distribution in this whole subject. Furthermore, it is in fact vector composition of the same anatomy, the same body. The vectors are our guides to understand human anatomy, so to understand surgery and voice therapy of the vocal folds. Where are the vectors in the larynx? Of course, each and every muscle is a vector which has a power and which has a line that he goes through. And also around the larynx, there are various muscles that work as vectors for us to understand. We need to see, we need to know and feel. In other words, we need to understand the language of the tissues. When it comes to vocal folds, we have to look at the air, which we call glottis, the space between two vibrating vocal folds, not only to the tissue, not only to the vocal fold mucosa. So how can we explain voice therapy? What is voice therapy? Voice therapy is the treatment of a voice patient which with a given voice disorder by behavioral methods rather than surgical methods or medications. Voice therapy is the essential treatment modality of voice disorders. It can be the primary modality, which we only use voice therapy to make the treatment. It can be secondary modality, which we can use voice therapy before or after surgery or medication. Of course, voice therapy has various disciplines, and during voice therapy, we use principles and applications of these disciplines. So we have to say that voice therapy is a medical treatment modality of voice disorders. It is the anatomical rehabilitation plus behavioral rehabilitation. Let's give an example from gait analysis. When you walk with a converted foot, let's say your right foot is converted medially 20 degrees, then what happens? There will be a hyperkeratotic lesion at the place that you make a compression mostly, and then there will be a lesion. What will be the treatment? The treatment will be surgery, or the treatment will be the behavioral therapy. If you take the lesion out and if your patient walks with the same faulty behavior, what will happen? Then the lesion will come back. So the main idea is the main treatment lies under behavioral correction of gait. What we need to comprehend out of voice therapy. This is the sacred knowledge in voice therapy. What is the sacred knowledge? First of all, when you see the dynamic anatomy of the glottis, what do you need to see? We need to give some answers to some questions. Which muscle is dominant in which vocal pattern? So which exercise is useful in a specific glottic misuse? And what is correct registration? What is a muscle-specific exercise program? In other words, we have muscles, as we spoke before. These muscles are vectors at the same place. For example, the thyroarytenoid muscle, the vocalis portion, the medial portion of the thyroarytenoid muscle, creates a mass during vibration, especially at the 2/3 of lower parts of membranous portion. On the other hand, the cricothyroid muscle pulls the vocal ligament, which creates adduction and vibration, especially at the 1/3 of the upper part of the membranous portion. So the idea, if you work with falsetto register, if you work with this sound, then you make the cricothyroid muscle contract. If you want to increase the vocalis, then you work with chest register. Hey. And if you want to increase the muscle power of the TA, then you can have some overload, which we take from the sports physiology, the overload principle. If you want to develop a muscle, you carry some, you work out with some dumbbells, and your biceps, let's say, becomes hypertrophied and gets more power. Let's see one example, how we make the voice therapy. So this is a 23-year-old female opera singer. She has vocal fatigue since 2 months, breathiness in voice, weak timbre, pain in the throat, and throat tickling, loss in high pitches, piano pitches, difficult, low pitches are pushy. So let's see what happens. There is a posterior glottic gap. So as you can see, the posterior glottic gap increases the transglottic airflow, and the efficiency of the transformation, energy transformation at the level of the glottis decreases. So what do we need to do now? What do we need to do to create a vocal fold closure like this instead of this? First of all, we need to increase the lateral cricoarytenoid muscle contraction. It provides especially the adduction of the 1/3 of the upper membranous portion and a slight stretching. So what we did, we used SOVT, semi-occluded vocal tract, with high back pressure, and we found out the primal sound. We make a sostenuto exercise in the chest register. This is how we did this exercise. And then we increased the back pressure gradually. The interarytenoid muscle, as you know, the lateralis muscle, lateral cricoarytenoid muscle, closes the vocal processes of the arytenoid cartilages. The interarytenoid muscle closes the posterior glottic trigone. So, and the interarytenoid muscle responds especially to fast orders, which comes from central nervous system. So we use staccato exercise, something like so. This exercise closed the posterior portion of the glottis. The cricothyroid muscle. The cricothyroid is not efficient as well in this situation. So we found the naive falsetto first in this patient. Ooh, And then we added the semi-occluded vocal tract, and then we made a springing on high pitches, like ooh, ooh, ooh. What we did was to increase the contraction and power of CT and the muscularis muscle, the lateral TA muscle. So we, after increasing the power of the CT muscle, we have a glissando to low pitch and sustain at that pitch, like this. The vocalis. In this case, there was a trick. The vocalis muscle needs to be contracted in high back pitches. For increasing the back pressure, you can increase the water level. You can increase the water level while you are bubbling, or you can make an obstruction at the other side, or we use another device. This is a valve, or you can increase the contraction by increasing the valve back pressure. That also provides a powerful contraction in vocalis segment of the TA muscle. The posticus. Posticus, in this case especially in a singer's case, is an important muscle. As you know, the posticus is opening the glotis, but it has vectors, especially which stretches a little bit from back to the other muscles that stretch the vocal folds from front. So we taught a breathe in feeling while phonation. Yeah, I mean, that also increased the skill of using the posticus. What happens next? After voice therapy, this so there are various patients. This patient, as you can see, has vocal nodules, a teacher, pain in the throat, tickling, and she's not able to finish the weekdays properly at school. Let's see. Oh, sorry. And 8 weeks later, you can see there's a better closure and no more nodules without any surgical intervention. And her voice. This is why we need vector analysis. While we are making treatment of our patients who have dysphonia and who has been referred to us as physicians. Diagnosis and treatment are not two different objects. We need to combine diagnosis and treatment. Which exercise is good for which problem? This is what we need to elaborate. In voice therapy, as you can see, we change anatomy. In voice therapy, we change the muscle contraction pattern. I mean, while the vocal folds are working like this, we change the muscle contraction pattern, and here, then, in time, we change the behavior that we call motor learning and neuroplasticity. There are different kinds of voice therapy methods and techniques. There are indirect methods, there are direct techniques. In indirect methods, we do not try to change the muscle composition, muscle contraction organization of the vocal organ. But in direct techniques, we directly try to change the vibratory system in our phonation. The Tactivox voice therapy technique is a holistic approach, which is a direct technique. It is a muscle-specific approach. We have holistic cognitive processes for both of clinician and the patient, and we provide a multi-channel biofeedback. It's based on Seeho's Laxvox tube exercise. What is the strategy in DVT? First of all, when we are in the operating room, we need to have a multidimensional thinking, different dimensions at the same time. The first dimension in our brain is how we are going to make the operation. Let's say we are going to take a cyst out of a vocal fold, and we will make an incision. We free the bindings of the cyst and trying not to make any harm on the vocal ligament. We take the cyst out, and then we can suture the mucosa or whatever. So this is the action plan that we are going to make. The second dimension is we have some instruments, the surgical instruments. These are exercises or instruments in voice therapy. These instruments lie in front of us, and we can use, if there are 50 instruments on the table, we can use maybe 17 of them for a specific patient. For another patient with a cyst, we can use 20 of them or 25 of them, or we can take another instrument from another set of instruments. So this is how we dynamically make decisions during we are making treatments in our patients. And the third dimension is we have a monitor, right? And one of our ears are always at that monitor. Beep, beep, beep. The beep sound tells us many things, and we should be very careful with this monitorization also. So combining these three different dimensions, we are ready for making our surgical treatment. What about our voice therapy behavioral treatment in DVT program, the mind map? So this is the clinician's action plan. We have preset exploration, incision, taking it out, and whatever. Preset exploration, development, adaptation. In the preset, what are our tools, the exercises? So at the preset level, we find we first of all we teach something. We counsel with our patients. We make some relaxation studies. We work with posture and breath support. At the second level, exploration level, we find the primal sound out. Everybody has a primal sound. If there is no problems about anatomy and physiology, such as laryngectomy or unilateral vocal fold paralysis, and so on. The third level is development level. At the development level, we just try to increase the skill level that we found out from the primal sound. The both feet can now step properly. Both vocal folds can vibrate properly. After finding the primal sound, we make the muscles that make this primal sound possible, and we combine some exercises. We increase the difficulty of the tasks, and then we load a linguistic value. I mean, oh, and then 1, 2, 3. So this now means something. At the last level, there's the adaptation level. The adaptation level, we transfer this new vocal skill to a behavior. While we are doing all of these, like in surgery, we have a monitor. Beep, beep monitor is the motor learning phase of our patients. Cognitive, associative, and autonomous phases are important. And in the first phase, our patient tries to understand. The second phase is motor skill acquisition. The last phase is behavior transfer. What do we do very shortly during we are making voice therapy in Dr. Vox's voice therapy program? We give some answers to some questions. A basic knowledge about anatomy of our patient. We determine the problem, vocal hygiene, coping with a professional voice user, coping with musical performance anxiety. And we give a balanced posture. The noble posture is so easy for us to use, and we use low breath for a better phonatory process. Noble posture is very simple: high sternum, relaxed shoulders, and active spine. The second level, I told, primal sound. We find the primal sound. Primal sound, we all have primal sound. While we are coughing, while we are laughing, whatever language we use to communicate, it's always the same. The cough. Can you understand somebody where he comes from his or her cough? Oh, he is Turkish. Oh, he is Indian. He is Russian. You cannot say this because it's a human sound. So we find that human sound, the best sound we can make out of our bodies. And then there are some strategies to find the primal sound. We have some probing maneuvers, or we have some probing therapy techniques to find the primal sound. And then we refine the primal sound with glottal attack and damping, vertical larynx position, supraglottic activity, and focusing. Especially glottic attack is important, and you can see the glottic attack from bubbling, let's say, which means too much breathy attack, or if the sound comes first and then the bubbling, then it is a heart attack. Comfortable low laryngeal position is also good to refine the primal sound and focusing for muscle specific exercise. Basic DVT exercises can be different basic exercises such as sostenuto exercise, glissando exercise, portamento exercise, or portato exercise, or staccato exercise. Each and every basic exercise has a meaning and a target muscle. We also can use loudness-based exercises and combine them in order to make more difficult of the motor tasks. So we can say staccato sostenuto or staccato glissando, and so on. Then we can make some melodies. Until now, as you can imagine, the main sound was schwa, the neutral vowel. We did not mean anything with our sound. Now we are, after mastering the primal sound, we add some linguistic meaning to the primal sound. So there was a missing link with tube phonation. Whatever tube is, no important. But when you want to add articulation with semi-occlusion plus artificial elongation of the vocal tract, then we have a solution. So this is the oral mask that we have developed for this. Happy birthday to you. Happy birthday to you. So we add some articulation to the voice tasks, and then you can play with vowels, you can add some songs, you can add different speech exercises, read aloud books or conversational speech with the mask. This is very important, the behavioral adaptation. Our patient must adapt himself or herself to the new behavior. What are the physiopathologic mechanisms? So as physicians, we need to be aware of different physiopathological mechanisms. There are two main effects of DVT progress. There is a mass of air column by double vibration. One side in our larynges, the other side is the vocal, the bubbling water. You can see here normal vibration and with bubbles. So what we call massage effect is the bubble gets out of the air column, and then the water pushes the air column back. So there's a push and pull effect in the tube. There are different mechanisms that we can say. Very shortly, the inertance of the vocal tract is increased. There's an artificial elongation that we can take advantage. And resonance spaces are also increased, especially with lowered vertical larynx position, with lowering effects physiologically. The abdominal diaphragmatic breathing is easier because of the natural consequence of the relaxation of the secondary breathing muscles, we return to the factory settings, relax, because we have something to be interested. We have the device, we have our exercise in mind. We give biofeedback so much. When you bubble, the bubbling, you feel bubbles in your throat, which shows that it's a correct exercise for you. Auditory masking effect is interesting. The Lombard effect like an effect, and sometimes it increases the possibility of the primal sound. Visual feedback. So when you watch the bubbling, you monitor your breath at the same time. It is your transglottic airflow rate during phonation. And the vocal massage, as I showed you from the vocal fold mucosa, there is a vocal massage effect. The issue mechanism is mainly the mechanotransduction. Cellular mechanotransduction at different levels make the vocal folds disappear. And neuropsychological factors are important because you not only give some vocal exercises to your patient, but you also give orthopedic shoes, let's say, some devices to your patients to work with. And last, the neural changes, neuroplasticity. Last but not least, you can also make vocal humidification, which is also important for our phonetry process. So I would like to show you some patients. In the voice clinic, we have different indications of DVT technique. This I showed you. Unilateral vocal fold paralysis. Very shortly, look, there is an insufficient after voice therapy, the insufficiency is gone. Look, like this, and the voice is there. The sulcus vergature in some patients, as you can see, there are two sulcuses at the both sides, and his voice is weak and thin. After voice therapy, you can see the vibration. And sometimes some vocal polypoid lesions can also change. They can also disappear. In partial laryngectomies, you can also use this. As you can see now, there is a
yüksek sesle konuşursam ve uzun süreli konuşursam
there's a chaotic vibration in the laryngeal portion because right-sided cordectomy has been applied. After voice therapy,
çok daha rahat konuşuyorum. Yandaki odaya da rahatlıkla sesimi duyurabiliyorum. Konuştuğum zaman da yorulmuyorum.
So it can happen. About mutational falsetto. Oh, sorry about this. About a psychogenic
yaşındasınız.
let's say.
3 yaşındayım. Peki ne zamandır var bu problem?
Psychogenic.
Hocam 4-5 senedir bile oluyor.
Peki.
Şimdi bunun içine
As you can see, When you increase the back pressure, the vocalis portion is starts working. The last patient is the mutational falsetto patient. As you can see.
Evet. Ne zamandır var bu?
Bu ergenlik dönemi sürecinde 14-15 yaşlarına itibaren
Bunun içine hu bunun içine üfler gibi ama.
tamam hocam.
Şimdi Şimdi 1, 2, 3, 4
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So we can use it in especially puberphonia, presbyphonia, and so on. So voice therapy techniques. As physicians, we need to know what we do in treatment approaches. But while you're looking at trees, you may not see the forest. You can use the DVT method, the Dr. Vox voice therapy method. For the patient, it's easy to perform at home, easy to teach, easy to learn. But for the clinician, knowledge is power. Thank you for your attention, and goodbye from Turkey.
Thank you for the enlightening talk, sir. Sir, we have some questions for you from the delegates. Sir, is Dr. Vox device available in India? And if so, whom to contact, how to procure?
Yes, I think, and we were in, sorry, I think I can also, yes. So I was in India 2 times before, and I think somebody is taking care of this in India.
Okay, sir. Thank you, sir. So one more question. So you had demonstrated a case of sulcus. In the treatment of that case, was it just a voice therapy, or was it a combination of surgery and voice therapy?
No, it's only voice therapy, but it takes time. Form follows function, and mechanotransduction works. If you apply some mechanical energy to the cell, then the cell changes and the tissue can change. Of course, the sulcus doesn't disappear completely, but you know, the sulcus is a problem under the epithelium. It's an atrophy of the superficial lamina propria and the lamina propria layers. So if you go on applying mechanical effect on the vocal fold mucosa, it can change. It took 3-4 months of voice therapy, but not every day, of course. We just taught how to make the exercises properly to our patient, and he did the exercises. He just spared 20-25 minutes in a day to make the exercise, and we have different samples of patients, and it works, but not with everybody. I sometimes do the surgery myself to my patients, but in this patient, the voice therapy succeeded.
Thank you, sir. So that's all. Thank you very much.
Thank you very much, and goodbye.
Bye. Up next, we have much awaited oration on innovations in laryngeal surgery by none other than Dr. Stephen Zietels. To chair the session, we have Dr. Vijendra sir and Dr. Amitabh Roy Chaudhary sir. Over to you, Dr. Vijendra sir, to introduce the guest faculty.
My dear friends, colleagues, and all the delegates, it's a great pleasure and honor to chair this session on innovations. The speaker is none other than Professor Steve. I sincerely thank the organizing chairman, Professor Jagannath, and organizing secretary, Dr. Sanjay Subaya, for having given me this opportunity to share this session. Professor Steven is got a vast experience of 25 years. As a surgeon, everyone will come across so many problems, but he as a surgeon has innovated so many techniques to solve many problems in phonosurgery. Some of them are the universal module glottoscope with suspensions, use of angiolytic laser on the vocal folds to treat various diseases like including early glottic cancer, Avastin injection for refractory RRP, intra-arytenoid spring to treat glottic stenosis are some of his innovations which he is going to discuss. Finally, he is most known for operating on vocal folds of very famous voice professionals of our time all over the globe. I am sure all of you will enjoy this talk by Professor Stephen. I welcome Professor Stephen to deliver his lecture.
I would like to begin by thanking the Association of Phonosurgeons of India for providing me with the opportunity to present the APSI oration. I'm going to review a range of innovations that we have worked on over the last 25 years. It is not meant to be exhaustive, but more representative. Hopefully one day we'll be able to discuss these initiatives in person when this challenging pandemic is behind us. I would like to begin by indicating that there was some mention that I had created the word phonosurgery, and I want to correct the record. Phonosurgery was created as a term by Hans von Leyden in about 1962. So I want to make sure that people are well aware of this individual, as he was a great mentor to me. All of the research that you will see in this lecture has been funded by nonprofit charities. None of it has been funded or supported by commercial entities. I have an equity interest in two companies. Endocraft LLC has been in existence over 20 years, selling laryngoscopic instrumentation. Innovoice is a new human voice company, of which currently there are no products for sale. As I stated in the last lecture, we moved to the Mass General in 2004, where we had a number of colleagues who we were working with. The group has grown over the years. We have currently 3 staff, including Jim Burns and Tiffany Rohn, and these are the surgeons. We also have a range of PhD and scientists. My partnership with Bob Hillman has reached its 30th anniversary as we started working together in 1991. We have trained over 35 fellows. Currently, we have 3 fellows that are in process of completing this year, and all of them, along with most of the others in the past, have developed academic careers. As I stated in the last lecture, essentially this program evolved in the 1870s under Dr. Knight, and then subsequently Franklin Hooper, who I'm pointing to here, and then Harris Mosher developed the program further as he returned from war. I presented the Jackson Lecture almost 15 years ago for the ABEA, and I looked carefully at innovators in the past in our field. And I think it's clear that Jackson was an immensely creative innovator, but he was very graded, guarded, and balanced in his approach. These quotes from his manuscript Hindsight, which was his presentation to the Women's Medical College of Philadelphia in 1925, are worth repeating. So great and radical are the changes which occur in medicine that we may paraphrase Davy Crockett. Be sure you're right and then look around to see what's wrong. Discussion and difference of opinion means progress, and we must progress. To stand still means retrogression. It is important for surgeons to understand how far thinking into the future Jackson was. He was a great proponent of women in medicine and surgery, and in fact, this is why he took on the role, still in the prime of his career, of being the president of the Women's Medical College of Philadelphia. Innovation is a transgenerational process. In addition to my mentors at Boston University, I also want to acknowledge John Kirshner, who was the chairman at Yale from 1950 to 1980. In the 1990s, he opened up his entire collection of whole mount sections of laryngeal cancer, and it gave me great insights about designing procedures for the future after looking at that collection of resected larynges. The innovators of today should be working to train the innovators of tomorrow. Innovation is a complex process. There are a range of forces at work. Academicians have motivations to enhance and develop their careers. Individuals who have worked in an area are not frequently amenable to change because it may devalue the work that they have done in the past, and which could even influence their financial status. The folks who typically are early adapters and adopters are the younger individuals, because they're not primarily invested in a pathway that already exists. Promoters are very commonly the individual who may have the patients, but there is a somewhat of a conflict that can evolve with certain work for revenue and pathways to enhance revenue. It's clear that for industry and companies, their primary goal is to increase revenue. So we have to be careful, as is always the case with these types of meetings, that the information is balanced. From my perspective, the cleanest form of support comes from patients who have benefited from the procedure. The media can be excellent vectors as well, but again, there can be issues with regard to the agendas of even media-related scenarios, as we're seeing what's going on in social media today, and that influence on the finances of technology companies. It is clear that there is even a term now which had not been typically used years ago, which was individuals involved in this type of work are called influencers. We have greatly benefited from the assistance of our patients. There are individuals in various walks of life. Clearly, those who have a following in the internet, such as performers, can be extremely helpful for moving technologies and processes and interventions forward. Almost 20 years ago, our patients decided to form their own federal nonprofit, and this partnership between the physicians, the scientists, the patients, and the institutions have been an extremely valuable partnership. Our organization that we've been helped by is the Voice Health Institute. This is an example of the work that can be put together. Many of you are familiar with Joe Buck. He had a paralyzed vocal cord several days before opening season years ago between the Yankees and the Red Sox. I managed him through that season, and he got very involved with the patient organization and, in fact, helped put this event together years ago in Los Angeles. But he not only did that, he also brought together the team of individuals who even make videos for the sports broadcasts and had them work with some of the patients we were caring for to build this video to help us raise money for further research.
We have an unbelievable night for you. Here's who's on tap tonight. Tonight, still to come, he's a legendary frontman and multiple Grammy winner. Along with his bandmates, a 2001 Rock and Roll Hall of Fame inductee, the voice of Aerosmith, Steven Tyler. He burst onto the scene with hit machine The Commodores. His 2012 release Tuskegee hit #1 in the U.S. He will forever be known for classics like All Night Long, Truly, and Hello. Lionel Richie. He entered the airwaves with the British Invasion. His range and stage presence is among the greats. Along with his bandmates, a 1990 Rock and Roll Hall of Fame inductee, the voice of The Who, Roger Daltrey.
It's unequivocal that our relationship and bond with our patients has been one of the most valuable aspects of moving innovation forward since they've been involved with the steps, design, and even the discussions through this process over the years. It's important to understand the functionality of vocal folds and how voice is produced. We'll look at the stroboscopy on the top left. One can appreciate the entrained vibration, and as we see on the right, adjacent to it, is what the superficial lamina propria actually looks like. It's this area underneath the membrane. Notice that the membrane is relatively transparent and translucent, and the goal of procedures on the vocal edge is to preserve that layer in its entirety if it can be achieved, if it's a benign lesion, and then to minimize the damage to it if it's a microinvasive carcinoma or dysplasia. The images on the bottom is OCT, so I think it is valuable to understand the mechanics of how vocal folds vibrate. And you can see this, and this view and how that area seems to be sloshing around is probably one of the better sets of images to understand the vibratory pattern of that superficial lamina propria. Again, for the younger surgeons, understanding the biomechanics of this type of entrained vibration and behavior is important because it is key to preserving voice for these lesions by saving that layer. I think many of you know, and I'll mention it a little bit later, Julie Andrews was the classic case in which that layer was removed. The future, of course, and we've been at this work for many years, is to produce a synthetic biomaterial to replace this area if it cannot be achieved by natural cellular constructs. Many years ago, I designed the universal modular glottoscope. It has been used around the world for decades. This instrument was designed to conform to the inside shape of the thyroid lamina so that cancer resections could be done out to the thyroid lamina should it need to happen. Also, to have the vocal edge pathology more centrally located. The slots on the side allow for easy passage of hand instrumentation by the assistant, as well as actually creating range of motion enhancement, since when you have a typical tubular scope, you're limited in that regard by how wide the scope is. As you can see in the image in the center bottom, it's what a typical Dito laryngoscope will achieve unless you're offsetting the microscope, and there's a very different look to this when you place the universal modular glottoscope. A brand new laryngoscope is now available. As I mentioned at the beginning of the lecture, I have an unavoidable conflict since these are produced by the company Endocraft. You judge for yourself whether the value of these instruments are justifiable. They've been developed based on instruments over many, many years' time. And what you're seeing is an evolving shape, but again, the lancet arch gets great exposure of the soft tissues of the glottal introitus. This scope is somewhat narrower in the center and meant to be placed in individuals who are more difficult direct laryngoscopic exposures. The specula come in various sizes to accommodate different size individuals and their differential shapes and conformations of their anatomy. It's important to truly understand the difference between suspension laryngoscopy. This is a movie that I was invited to make for the American College of Surgeons in 2000, and it explains some of the difference in the forces involved between a laryngoscope holder, stabilizer, and the difference with a true suspension gallows, which is how it originally was done by killing, as we mentioned in the last lecture.
This laryngoscope was designed so that it could accommodate European chest support systems, which work by placing a supporting mechanism in here and fulcruming off the chest wall. American tend to use a clamp-on or Louis type holder which clamps on here, and that can be used, or one can use the extension piece which snaps on. This is what we were seeing during the cases today. The patient is actually lifted off the table as opposed to a fulcrum device which pushes and gets anterior commissure exposure by rotation.
The rationale for a suspension gallows is that true suspension in the position that I showed you in the last lecture allows for the largest lumen speculum. The largest lumen speculum will facilitate the most precise surgery because you have a tremendous amount of room to work. The smaller the size of the laryngoscope, the less precision there will be with the intervention. And as I just stated, the suspension will facilitate the forces so that you can get a larger speculum to reach the laryngeal introitus. I'm going to take a few minutes to discuss angiogenesis, since this concept is important to understand and utilize when you're treating various types of lesions in the larynx. Remarkably, Dr. Hooper, who was at MGH, as I told you, in the 19th century, wrote his American laryngological thesis on respiratory papillomatosis, since that's been an omnitemporal problem in the 19th century, the 20th century, and continues into the 21st century. As you see in his quote, he accurately said the vascularity of the growth is perhaps the most important factor in determining the rapidity of its reappearance. Remarkably, almost 100 years later, Judah Folkman developed his concept of neoplastic angiogenesis. What you're seeing on the right is a typical severe RRP case, and when you look at the bottom, you see an organized hypertrophic epithelium with a central vascular core. And what we're doing with our management, which I think you'll anticipate with angiolytic lasers, we're trying to treat the underlying vascularity to in turn treat the patient without burning the superficial lamina propria under that. There are various types of angiogenic lesions. You can see RRP in the top left and bottom left. There are ectasias and varices that become injured vessels from trauma in the center top, and then of course a combination of varices, ectasias, and a polyp in the bottom center. Remarkably, even when there is dysplasia seen in the top right, it is typically accompanied by a network of abnormal vessels at the basement membrane, which are difficult to see if in fact you have keratin on the surface. As you look on the bottom right, it's an area of a T1 cancer, and you can see the looping vessels because there's been what we refer to as an angiogenic switch. When you think of what the microcirculation should look like, it should be arborizing, as you see at the perimeter of the top lesions left and right. And ultimately, when there's an angiogenic switch, then you get a change in the vessel characteristics, which probably contribute to the change in the epithelium, and ultimately you get a wild pattern of vascularity, and that's the angiogenesis that Folkman was talking about. And vocal cords are a tremendously valuable tumor model for understanding these types of vascular changes. In turn, we utilize that dense microcirculation of the tumor to treat cancer. I started working with Rox Anderson in the 1990s. Dr. Anderson is a legendary physician. He described selective photothermolysis in the early 1980s and published it, as you see here. It's a rare situation. He actually came up with a mathematical equation for these lasers before the lasers were made, and then the lasers were made, and they confirmed that he was right. Typically, lasers were cannibalized from another part of industry and then used as a surgical instrument. So Dr. Anderson's contributions in this area, and as director of the Mass General Wellman Laser Research Labs, has had a great influence on how light is utilized to treat human beings. As you see here, 3 wavelengths of light are absorbed by hemoglobin: yellow, green, and blue. We utilized the pulse dye laser first. That was very accessible to us from a company in the Boston area who lent it to us to try out. Then we utilized the green light laser, which was a more stable laser, and after the franchise was purchased multiple times, it ended up with Boston Scientific. Remarkable to that is the fact that Boston Scientific, I think many of you know, has shuttered the sale of this laser, and at this point there are multiple initiatives to create diode blue light lasers. This is a chick chorioallantoic membrane model so that you could practice the microcirculation treatment. As you see, immediately there's vessel wall rupture. This is not advantageous for vocal folds, especially when it's not a rougher lesion that's exophytic. We did not have the control. We then moved to the green light laser, which was solid state, and then one could control the vessel wall rupture by lengthening the pulse width. The dilemma now is that the green light laser that has been used for over 15 years has now been shuttered, and there isn't an accessible one. There is also new initiatives, as you see on the right, to produce blue light lasers. It is less important what the wavelength is in those 3 types of lasers and more in how you control that laser and its delivery system. As you see here, there is a variety of small fibers that can be used, and again in this model you can practice the microcirculatory anatomy that one would encounter in the superficial lamina propria of the vocal fold. These are 3 blue light lasers. The arc laser has gotten approval in the United States, and some surgeons have used them. What we've heard is that it's not overly powerful because even the 10 watts is at peak pulse. It's a 4-watt laser in a continuous wave mode. IPG, which is a very well-known industrial laser company, produced a dental laser that does 7 watts. The company that we've worked with is Innovoice. This laser is not available yet, is expected next year. But again, I have a conflict of interest here, so that will need to be judged by individuals independently, and we will not be doing any specific research with it because of that conflict. As I stated in the last lecture, laryngoscopic procedures were office-based in the 19th century. They moved to the 20th century for the precision potential of working in an operating room and with enhanced anesthesia techniques and increased instruments that were used. I did the first office-based laser procedure in 2001. This is an example of an individual that is receiving anesthesia and undergoing this. This is still an individual whom I see today. There's topical anesthesia. We use 4% lidocaine and nebulize it. Now remember, you're actually doing the procedure off a two-dimensional screen, so you have to watch the reaction to the tissue because you cannot determine what the true fiber-to-tissue distance is. You get used to doing this. And ultimately, the patients who have chronic diseases such as RRP and dysplasia do extremely well because it precludes their need for frequent general anesthetic interventions. We wrote up our early experience with this many years ago, and it is one of the most common procedures we do today. We've likely done between 2,000 and 2,500 office-based laser interventions. RRP has been an omnitemporal problem over the last few centuries. It was clearly observed. This case that you see on the right is an individual who actually died, and they resected the larynx and drew the findings. There's probably approximately 6,000 new cases a year. There's not great epidemiologic information here, and since they don't go away, it's not unreasonable to expect there's approximately 50,000 patients. Clearly, the majority of the pediatric cases are done for airway stabilization, and the majority of the adults are for voice stabilization. In our hands, we do this far more frequently than bringing people to the OR, and utilizing the angiolytic lasers along with other interventions such as Avastin, we've gotten a pretty good control over the disease and salvaged many voices. It's our hope that with the COVID pandemic, there are new platform technologies to produce vaccines that will probably and hopefully end the need for continuous operative interventions to try to control this disease. A number of years ago, we introduced the use of Avastin. I had a meeting with Dr. Folkman shortly before he died, and he indicated to me that I should find a use for Avastin in laryngological problems, and this is what I chose. You can see on the bottom right in the supplement to the annals, there was individuals with massive disease, and although we could remove the disease quite effectively with an angiolytic laser, the disease frequently recurred, as to be expected, very quickly. As we used Avastin, we had much better control over the disease because it's an anti-angiogenesis agent. This is the first patient that we used Avastin on. He had been referred to me by Roy Cassiano in Miami, and Dr. Cassiano indicated within 8 weeks, whenever he would remove the disease, it was right back again. I actually had the exact same experience with this individual who was fairly young, and you can listen to his voice when he developed the exophytic disease, which recurred again every 2 months.
Eat and breathe.
We actually not only removed the disease subsequently and then got permission through the IRB to give him compassionate care and remarkably, after we did serial injections of Avastin, the disease stopped recurring. He has not had an intervention in probably 8 or so years, and despite all the prior procedures by Dr. Cassiano and then myself, the patient's voice recovered. You will look at the stroboscopy on the right is by no means normal, but quite acceptable given where he started.
I'll just breathe.
Here you can listen to his voice prior to the procedure and then subsequent to the laser removal with the KTP and simultaneous injection of Avastin.
Between September of last year and today, I've had 6 surgeries for the removal of vocal cord papillomas.
Obviously, there is no vibratory function. There's only neoplastic papillary growths in the introitus of his glottis. But due to Dr. Cassiano's very careful surgery, he had not actually substantially hurt the underlying superficial lamina propria.
And the interval of good voice between surgeries has been getting smaller and smaller. And the quality of the...
This is how he turned out and is still this way today and has not had a procedure, as I indicated, in a number of years.
Okay, I'm back here today. It's been about 6 weeks since my last procedure or my last injections. I'm doing pretty well. I'm a little nasally because I think I've got a sinus infection, which I get all the time, but my voice has been really good.
I think you can determine here that he has a near normal conversational level voice. This individual in the top left also had a range of difficulties with his voice. Unfortunately, his first vocation was as an opera singer, and then as he developed RRP, it precluded his ability to actually sing any further due to the need for frequent interventions. This is how he presented to me.
Higher pitch now. Okay.
Clearly, as he raises pitch, he stretches what viable superficial lamina propria still exists underneath, and his vocal system is very inefficient. So this individual is the first person to get an Avastin injection that had not had a remarkable number of procedures. So he had remarkably intact underlying superficial lamina propria. You'll see topical anesthesia being dripped. We now just nebulize it. This is all done with 4% plain lidocaine. In this scenario, I did the injection first and then used the laser. For the most part now, what we actually do at this point is do the laser first and then the injection. So after the injection of Avastin, you see the 0.3 millimeter fiber, and with a good patient, you can be quite precise in your removal of the disease. This is on the undersurface of the cord. Then we can get the disease in the internal surface of the left side. And again, especially with a good patient, you can be quite precise. And then one can inject the Avastin. In this situation, we did 5 Avastin injections in total, and after that, again, the disease completely resolved. At this point, we don't see that happen all the time, but there is a general pattern that about 20 to 30% of the Avastin injection patients will essentially go into complete remission. The others, you work out the periodic times in which you re-inject them. This is how he was and is still today, and in fact went back to singing, although his main profession now is as an intercontinental pilot for international flights. He's one of the rare individuals who you can have a telescope in and then actually can do scales while a telescope is in place. You can see by the enhanced vibratory function, the lack of disease, that this individual has done tremendously well. He is now over a decade since he's needed further surgery to correct this problem. The patient preoperatively.
Up to now, I had been working professionally as an opera singer. I'd sung with different companies around the country. Most recently, I kind of stopped doing that full time and taken on a career as a pilot, an airline pilot, but I still perform professionally as an opera singer around the country and as a cantor in New York City. In January, I came down with this condition, which now has been diagnosed as papilloma, and I haven't been singing since January.
After his disease was treated, this is him postoperatively and singing for the first time in a very long while. And one can notice the gratification once he's on camera being able to sing again.
Well, I think I was trying to remember what I did when I had the papillomatosis, and I think I was doing something from Pasquale. So I'll sing just the beginning of that, just so you have a sense of how it compares. Sure. And this is new for me too, because I haven't been singing at all for the last year and a half. All right. Bella siccome un angelo in terra pellegrino, fresca siccome il giglio che s'apre sol mattino, occhio che parla e ride, sguardo che cor conquire, chioma che vince l'ebbanno, sorriso incantator, sorriso incantator.
For us, this was a key case to understand what might be possible even with the treatment of RRP with a professional singer. This next video is an example of how the media can be very helpful for getting the word out. It's a piece on the first child to undergo this comprehensive management for RRP, and by chance, Roger Daltrey was in that day as he was going to be soon closing the London Olympics. So all of this came together in a very constructive piece.
Finally, tonight, you may not think of your voice that often because for most of us, it's always there. But if it's lost, silence can seal you off from the world. Dr. John LaPook found an innovative surgeon who has repaired the voices of children and superstars, and all of them are singing his praises.
I lost my voice when I was 4 years old.
This is Noah Skoll 4 years ago at age 9. He was born with a healthy voice. But a virus caused tiny lesions to grow on his vocal cords. His mother, Lori, was devastated.
I wanted a miracle. I wanted a cure. I wanted to find somebody to help me for him. And that's what brought me to Dr. Zeitels.
Dr. Stephen Zeitels of Massachusetts General Hospital is inventing new techniques in the emerging field of vocal cord treatment.
Good to see you. And I work with mechanical engineers, chemical engineers, tissue engineers, and we use high-speed photography, cameras that can take in, even in a throat, 5,000 frames a second. As the electronics and the imaging improves, so does our understanding of that physiology.
What have you learned about the value of having a normal, healthy voice?
One of the most striking things is how people take it for granted. What if it wasn't there?
Zeitels has helped icons Steven Tyler and Adele Last year, she suffered a vocal cord hemorrhage. His surgery allowed Adele to return to the stage. Roger Daltrey of The Who lost his voice before his 2010 Super Bowl performance.
The way he's got my voice working again now, it's I say, I feel it's easier for me to sing than it was 25 years ago.
Can you sing a little something? I mean, just a cappella?
My voice is huge.
Over 4 years, Zeitel's destroyed Noah Skoll's lesions. He injected them with a cancer drug and zapped them with a laser. Noah used to sound like this.
For my voice to come back.
Here he was in September at his bar mitzvah.
The third fund I've chosen to give tzedakah to is the Massachusetts General Hospital Voice Center.
When I restore the voice of a competent adult professional, no matter what they do, what you're doing is you're restoring their lives. Here, it's creating the future of something that should have happened, but might not have happened, and now will happen.
For Noah Skoll, this means a future with a voice that can finally be heard. Dr. John LaPook, CBS News, Boston.
And that's our voice for tonight, for all of us at CBS News all around the world. Good night.
The importance of angiolytic lasers became very clear when we did this review many years ago. In fact, it was the most common instrument we used, since we used it repeatedly in the operating room to treat a range of problems in the vocal folds under general anesthesia, such as papillomatosis, cancer, and dysplasia. But its purpose in the office was to treat these chronic diseases such as RRP and dysplasia, for which we didn't want to keep using general anesthesia. So it became clear to us that this was the pathway of the future for treating mucosal diseases of the larynx and pharynx. Since then, we've done thousands of procedures, and it still holds true. And as I indicated earlier, in the future, there will be blue light lasers. And again, it's the same principle, just a different delivery system for treating these lesions. As you can see, in the OR, it comprised 46% of the cases, and in the office-based interventions, which include all injections, it was 54%. We've published extensively on this subject. You can review it in the literature for a whole variety of benign and malignant lesions. The treatment of early glottic cancer has been somewhat controversial over many years. Endoscopic or transoral removal goes back to the late 19th century, as I indicated in the history lecture. It has been also utilized throughout the 20th century with direct endoscopy. Today, as we look at this, the key issue is what is the voice outcome, not treatment of the cancer and success of that treatment oncologically. We also want to preserve as many treatment options as possible, and therein goes the issue, should you irradiate, since you're using a single-use cancer treatment for something that has a 90+% chance of endoscopic treatment success, doing it with a whole variety of methods. Clearly, there's an issue of cost, and this is a decision that groups have to actually come to terms with. We have not used upfront radiation for early glottic cancer in over 20 years, and only a minority of these individuals have ever required salvage radiotherapy. Regardless of whether you use radiation, a electrocautery, a laser, cold instruments, the cure rate is somewhere between 90 and 95%, as I mentioned in the last slide. So it's how we preserve vocal function, which is the key metric for success. In the 90s, we moved forward with some of the ideas put forth by Hirano and tried to do very precise cold instrument dissections within the superficial lamina propria, and this was part of my trio thesis in the early 1990s. We adjusted the depth of the resection based upon the depth of the lesion. We didn't take a 1 millimeter perimeter margin and then take out a 5 millimeter deep margin, since we didn't believe that that was necessary. And by removing a lot of muscle, you created substantial deficits in voice by creating aerodynamic incompetence. For over a decade, we've been treating cancers with the KTP laser by involuting the blood supply. This is an approach that we've adopted completely. We've done over 300 cases. This series with reasonable follow-up was reported in 2014 for both T1 and T2 lesions. We have had outstanding voice results, as I will demonstrate representative cases for this. In addition, there have been outstanding oncologic results. Essentially, we are not cutting the cancer out as we would with either a CO2 laser as a scalpel or cold instruments. We are removing it by involuting the blood supply. Since this is integrating Folkman's theories of neoplastic angiogenesis with Rox-Anderson's theory of selective photothermolysis. As you see in the case from the last slide, and you watch the stroboscopy, you can see the impaired vibratory function due to the mass in the left vocal fold, which crosses the midline. This is not a contraindication for us. We will stage the sides of the removal, and we can maintain the anterior commissure architecture while preserving vibratory function wherever it has not been replaced by tumor.
Breathe. Breathe for me. That's fabulous. Again. Higher pitch.
So it's easy to understand the impaired vocal function as you watch the stroboscopy. This patient is approximately 9 years post-op, has never had any further problems with his vocal cords, and this is his vibratory function today and as it was post-operatively.
Higher pitch now.
The patient has a completely normal conversational level voice. It is clear that there is not perfect vibratory function on the left, but it is remarkable how much mucosal wave function was in fact preserved, and there is no issues in the anterior commissure architecture. This is another patient with more extensive disease on the contralateral left vocal fold. Again, he was treated in a staged fashion, preserving and respecting the anterior commissure.
Good. Good.
Okay. And post-operatively? These are routine cases. These are not exceptional cases. This is the commonplace outcome that we expect. The sole case that was referred to me from Wolfgang Steiner in Europe. This gentleman was an economist in his home country in the Middle East, and you can listen to his voice as he presented. He had indicated to Dr. Steiner that he was extremely concerned about his voice, and Dr. Steiner indicated to him that he would cure his cancer, but he would make no promises about his voice, and then subsequently referred him to me.
Well, he explained to me the situation, and that he has, like this kind of laser he's gonna do to remove this tumor and to keep the voice as good as possible.
It's a very low recording because he couldn't produce much sound. And as you see on the right, during his stroboscopy, there's a mass in the anterior commissure which is impairing his vibratory function. Remarkably, the small area that was functional on the left was producing some reasonable vocal function. This is the procedure for him, which was done in the beginning when we use this approach, so it is done fairly slowly because we use it almost completely in a pulsed mode. Today, what we would often do is remove the debulking part more in a continuous wave mode with cooling, and then go to the last aspects of the tumor in a pulsed mode. So you can see the gradual removal of the tumor primarily on the right. We left a small amount of disease on the left and came back approximately 8 weeks later. And this continues till we can actually see the interface. So again, we look for when we're through the tumor because it actually burns differently than when you're using the angiolytic laser on tissues that have less blood supply. You'll see much more carbon when you actually have more blood vessels. So this is how the patient sounded after the procedure, and he's over a decade.
I found my voice very nice. The people now hear me very well. I feel deep. My voice very deep. It's like an opera, like Frank Sinatra. I'm very happy, really.
So again, this is a normal conversational level voice. And what you'll appreciate on the next slides is how little true full mechanical vibratory function he has and how much you need biomechanically to have a normal conversational level voice. Even myself, who cannot sing, can make a variety of sounds if I do this. So you have to understand, to have a normal conversational level voice is a very low bar and probably way less than 10% of your biomechanical capacity. This is the patient postoperatively. As you see during the stroboscopy, there is very limited areas of true normal mucosal wave function, but he actually can achieve a reasonably good conversational level voice quality. You can see there's a mass motion through most of where the tumor is, but there is some mass vibratory function on one side and a little mucosal wave function on the contralateral fold. What's also quite interesting is the high-speed photography of this area, which better defines the aberrations in mucosal wave function and how it actually entrains. And you can see very substantial differences between the right and left fold, but it's quite good enough to create a normal conversational level voice. And it teaches you something about when a person is grossly hoarse, how substantial the deficits may be on the phonatory region of the vocal fold. This patient presented with an extremely large tumor of his right vocal fold extending subglottically deep into the ventricle and out to the thyroid lamina. It also extended just onto the left vocal fold as well at the anterior commissure. His vocal quality was consistent with the mass effect of both the tumor on the right and its impact on the vibratory function of the left.
I saw a specialist who told me I had a lesion, and found out that they wanted to treat me with radiation. And going on the internet, we decided that this was a much better way to treat it, and I ended up in Boston.
Obviously, he was extremely hoarse with a very strained voice. This is his stroboscopy. You can appreciate why he had trouble making sound.
Good. Okay.
This is the procedure. And you can see we start in a continuous wave mode at the edge of the tumor, and as we get to the interface of where we believe the tumor ends, we go into a pulse mode till we can see the muscle fibers, and we do this in a very methodical fashion. and again in a continuous wave to debulk the tumor, and then one has to be very precise with your endoscopic exposure. And you can see here, as you inject saline into the residual normal tissue, you can see very little char in the soft tissues of the vocal fold. Again, because of its extension onto the left vocal fold, that most anterior region was treated in a second stage to maintain the architecture of the anterior commissure. Many years ago, we worked on different methods for reconstructing the glottis to enhance voice. This was from a journal in the laryngoscope 20 years ago. Clearly, when we were using a carbon dioxide laser and doing deeper resections, we had more aerodynamic incompetence. Another problem was that when you took out the anterior commissure tendon, you had a keyhole aperture anteriorly. Ultimately, the way we solved that problem was a thyroid lamina subluxation. And here are examples of this patient's stroboscopy with the medialization, which was an injection of fat. One could also use Gore-Tex. And then ultimately on the right, when we did the subluxation.
And say,
And you can see the aerodynamic incompetence as well as hear it.
and breathe.
Now, if we look on the right, we actually do the subluxation and close down that anterior commissure deficit and keyhole aperture.
Okay, good. Now clear. Good. Again.
So he maintained a normal conversational level voice despite not having any vibratory function on the left, as to be expected. But ultimately, the individual carried on his life quite successfully and had no recurrence of his disease. These procedures were adopted significantly in Europe due to the number of patients who underwent a Steiner-like resection, removing the anterior commissure tendon and Broyles ligament. We first started mentioning the alteration in laryngeal cancer almost 20 years ago, and we were noticing demographic changes where fewer and fewer of our patients were actually smokers. This followed the observations in pharynx cancer, and we came to the conclusion that there was a clear demographic change going on in larynx cancer as well as pharynx cancer, which was much more prominently recognized. So at this point, less than half of our glottic cancer patients have any significant smoking history, if at all. And what we also noticed with this, with a publication that was in the Annals in 2019, that for the first time we had glottic cancer patients that were 30 and under. I had an experience from 1990 to 2004 at the MEI where I did not run into a patient 30 or under who got glottic cancer. And since moving to the Mass General in the same period of time, from 2004 to 2018, we actually had over 10 patients that were under 30 or 30 who got glottic cancer. And I don't know if it's actually changed yet, but when I last looked at the Academy website, it still said that 95% of patients with laryngeal carcinoma are smokers. It may very well have changed at this point, but I think we have to be very aware that when you have a new disease which is papillary and actually resembles RRP at times, we have to be infinitely careful that we're not treating it as a benign disorder. This patient presented at the age of 13 to Children's Hospital. On the bottom left, you can see the stroboscopy that we obtained here after he had been biopsied. There's fibrinous exudate. They determined very quickly at Children's that this child had papillary carcinoma, and at that point, the patient was referred for management to us. I want to reiterate that this patient went to the operating room at Children's to treat RRP, but due to the keen observations of both the clinician and the pathologist, they realized that this was not RRP, but was a malignant disease. Here is that stroboscopy on presentation to us.
That might have just
You can actually see that he's even entraining his false chords so that he can speak. If we look at the top image, what you're seeing is how it looked through the universal modular glottoscope, and the entire superior medial surface of the anterior commissure is basically cancer. If we go in a higher magnification, you can see on the right that it looks very similar to RRP, and how this could be mistaken in the office since the similarities are so great. When I show you his postoperative result, on the right you can see how he has an excellent anterior commissure, and he underwent treatment with the KTP laser, and he's now about 8 or 9 years and just had his own baby, is in the military serving.
Low pitch, E. Okay. Normal pitch, your pitch.
So he's done extremely well with this. Generally speaking, we think that the patients who have papillary carcinoma of the larynx do better than the typical smoking-induced disease that we've seen for a very long period of time. We've also encountered a number of unfortunate scenarios over the last 5 to 10 years. This was a patient who had presented with a papillary lesion and was treated with office-based management without being brought to the operating room for a biopsy. And office-based treatment is not something we would ever adopt for cancer. So after repeated procedures in the office and the assumption that this was a benign RRP lesion, the patient ultimately continued to have worsening of their voice. The clinician then decided to do office-based cidofovir injections, and it's not an issue we'll go through today in the rationale, but regardless if an individual believes that cidofovir isn't a risk for malignant degeneration, it surely is clearly a carcinogen, and in this case, a carcinogen was injected 5 times into a cancer, and then unquestionably the cancer accelerated. And what you're seeing both in the endoscopic view as well as the radiographic imaging, that this tumor grew out through the thyrohyoid space and was attaching itself through the straps to the undersurface of the skin. So regardless if you believe that cidofovir is safe to use, you need to be extremely sure that you're not treating a papillary cancer and that you're not injecting a carcinogen into a cancer. This patient ultimately underwent a near total laryngectomy for the advanced disease that had escaped the larynx and has been stable for a number of years. So in conclusion, we believe glottic cancer is evolving. It is similar to oropharynx cancer, but in fact, it is following in a later pattern over time. It is very similar morphologically to RRP at times, although it's a malignancy, it's not benign. We've had great success with these lesions with the angiolytic lasers because they're so highly vascular. We think that we have to be careful with the use of cidofovir due to the fact we now have a morphologically similar disease that looks potentially benign to a clinician so that they don't have the misstep like you saw in the prior case. Ultimately, we want to continue to look at pathways for preserving XRT, not because it's not the best way to treat it, it's too valuable to waste as a single-use cancer treatment for early glottic cancer. The use of a cryopreserved aortic homograft has been a great asset to us, especially with regard to managing partial laryngectomy defects. We published this a number of years ago. The idea was created with John Wayne, who was at MGH at the time and I believe is at St. E's now. John was familiar with this technique for managing the trachea in Europe, and then we adopted it for use in the larynx and were more successful. Essentially, the area of defect is reconstructed with cryopreserved aorta. The patient does not need any special medications or immunosuppression because they have a proprietary means by which the tissue itself is not going to cause an immune reaction. And this has basically given us great opportunity. What generally we noticed is that there were fewer and fewer open partial laryngectomies for the obvious reasons of chemotherapy and radiation protocols, as well as the effective use of robotic resections. It was a very challenging case. It was a 25-year-old who had a deep ventricular paraglottic space HPV cancer, which had gradually moved the right vocal fold over, and he became extremely hoarse eventually. As we look at the endoscopy, you can see what his functionality is like.
Breathe. Breathe.
You can see the mass effect of the right vocal fold. It was decided through discussion with he and his parents that we should try to avoid radiation since there was no clear endoscopic boundary, and that the tumor on imaging was effacing the thyroid lamina. That would have to be resected. I was trying to maintain an adequate airway for him, and so we reconstructed the right hemilarynx with cryopreserved aorta. To begin, what you're seeing on the upper right is the endoscopy that was done to clear the anterior commissure disease in the infrapedial region in the right anterior commissure and skeletonize and preserving the anterior commissure on the left. This also provided a pathway to bring in a saw to separate the thyroid lamina there. So essentially, a microlaryngoscopic control of the margins was done, and then the tumor was removed with a saw, and a cryopreserved aorta was positioned in its place. The cryopreserved aorta achieves its blood supply from random vascularization from the raw straps, which are affixed to it. When we look at the endoscopy in the office on the bottom left, he is about 10 days post-operatively with a clean airway, and he's been decannulated of the perioperative tracheotomy. And again, this is in the office, and you can see the trach site and his completely open airway. This is how he looks today. He's been over a decade, and you can see on the bottom right the confirmation of his airway where he's fully epithelialized that aorta, which is still in place.
Breathe.
He has unavoidably a somewhat weak voice with a normal airway, and we've planned a new procedure for reconstructing his right vocal fold. He lives in India, and we are waiting his ability to return because this procedure was only developed a few years ago, and I'll share it with you in the future as we have not published this yet. Again, despite having a somewhat weak voice, he's carried on with his life, and he's been quite successful, and we look forward to reconstructing him in the future. He has an excellent and pliable left vocal fold, but we do need to build him a right vocal fold. Is a patient with verrucous keratosis, not cancer, of the glottis, both sides, and what's remarkable is the use of this laser for decoupling the epithelium without resecting the underlying superficial lamina propria, and I'll show you that in the upper right after you watch the stroboscopy. We've been treating dysplasia cancer for many years now, and there are well over 1,000 procedures. So you can see the vibratory function is intact, but there's disruption due to the mass effect of the keratosis. This is the procedure. What you're going to see is a saline injection is done first and then lightly treating the surface. By doing this, we have angiolysis of the microcirculation, and then you can actually decouple the basement membrane from the underlying superficial lamina propria and not resect any of it. You can just as easily vaporize that surface, but this shows how elegantly the laser can be used just to slightly heat the basement membrane zone linking proteins, and then you can decorticate the epithelial flap. It's being held together like an exoskeleton by the keratosis. Now, if we watch the stroboscopy, he did get a small granuloma, which ultimately resolved, but his vibratory pattern is excellent and he had a normal voice. You can see there is a small area of keratosis in the anterior right ventricle, and this could be treated under local anesthesia afterwards. And this is easy to manage in the office under local anesthesia, which was done quite successfully. He again has been done and not required repeated procedures for many years. It's a 0.3 millimeter fiber with the pulse KTP laser. For a change of pace, we're now going to examine the endolaryngeal management and phonomicrosurgical treatment of vocalists and performers. We wrote a paper with objective outcomes on singers approximately 20 years ago. This is probably the first paper that had clear objective acoustic and aerodynamic outcome measures, and it gave us a sense that we would have to be moving forward with these newer techniques to enhance the management. At the time, I had been restoring Julie Andrews, who had undergone a procedure initially in New York, which removed her superficial lamina propria, and subsequently I did 4 procedures to reestablish her voice to the point she could act. But once that superficial lamina propria had been removed, was not able to restore the full vibratory function for her to sing. I mention her here because her case was the catalyst for writing this paper, and she actually reviewed the paper and the discussion with me, so it would effectively reflect what singers think about when they're undergoing surgery. What you're seeing in these images is the chaos that occurs from different types of singing. It's unclear to us why one can have a polyp, as you see on the bottom left, with varices and ectasias, and a fibrous area essentially on the left with the ectasias, and yet on the right, this metal singer actually ended up with multiple mucosal bridges, actually had 3 to 4 of them. Forgive my computer, which sounded off because it's low on battery. This has taken a while. But anyway, you can see, again, with the exposure, what you can visualize and how you want the pathology central to where you're going to be working. Julie Andrews, as I just mentioned, is probably the most well-known singer whose voice has been damaged by a surgeon, and it changed the field for quite a while. I would have to do consents that would last tremendously long periods of time subsequent to her procedure due to the fear that occurred. It's not uncommon in medicine when there are key cases and well-known individuals that if it does not go smoothly, or in contrast, if it goes smoothly, the society follows with regard to its confidence or lack thereof. In this situation, it also was at the beginning of broad use of the internet, so this circulated over the following 5 years quite substantially. I noticed it was difficult from about 2000 to 2010 or 11. I had done a number of well-known celebrities and singers. I had repaired their voices, and they did quite well with these newer techniques. But ultimately, it wasn't until Adele's case that there seemed to be broad acceptance that phonomicrosurgical intervention was a very reliable way to restore a human voice if done properly. And in fact, I think a number of you are aware there have been any number of singers over the years that I've had the pleasure and honor to reconstruct, but they're primarily referring each other. And I think that these techniques are quite reliable as long as they're adhered to. Several months after Adele's surgery, she was at the Grammy Awards where she won multiple awards. It happened to be the time where Whitney Houston died, so the viewership was extremely high. And at that point, she actually talked and mentioned the fact that she had had her voice restored, and this reached a very broad public, and I think was key to gaining confidence for patients all over the world that their voice can be restored.
And the Grammy goes to someone like you, Adele.
Thank you so much. Thank you. I can't believe I'm getting emotional already. Seeing as it's a vocal performance, I need to thank my doctors, I suppose, who brought my voice back. So Stephen Zeitels, Ruth Epstein, Theo Joseph and Paul Ettlinger, thank you very much.
From that performance onward and that show, it got substantially easier to provide confidence to patients that this was a fairly reliable and worthwhile and also safe way to restore a voice if there was a mechanical lesion causing the impairment. As I've mentioned earlier in the lecture, our ability to raise research funds was a partnership with our patients, and we've been very fortunate that the vocalists and celebrity patients have joined with us to raise those research dollars to innovate this field into the future and for the next group of patients. I was asked to actually review the individuals who I'd done microsurgery on who had actually won Grammy Awards in the past, and this is part of a 6-manuscript supplement that was published in the Annals in 2019, just reviewing the demographics and characteristics of the Grammy Award-winning singers who I have worked on. As you can see here, there were 18 individuals who had won 76 awards from 242 nominations. Not surprisingly, given their long history of singing, diminished pliability was the most common finding. You can envision that a ballet dancer would not model sandals due to this severe trauma. So this was very commonplace. Polyps, bleeding varices, nodules, these are all traumatic lesions. But just because they're a singer doesn't mean that that's the only thing that is possible. There were, in fact, 2 individuals who had invasive cancer, 2 individuals who had precancerous dysplasia, as well as only 1 who had a cyst, and 1 of 18 who actually had a granuloma. This is an individual who has sold well over 100 million records, who had actually 2 procedures when he was younger, and then presented with acute bleeding. What you see here in the left upper panel is a polyp that's hemorrhagic, and there's also smaller lesions medially below that.
Breathe. Just breathe now. Breathe.
I placed him on full voice rest, and he returned a few weeks later to have the mass resected. And as you see on stroboscopy, the blood is resorbed. You can't do these procedures with free blood because if you need to use the laser, as I mentioned earlier, you don't want the laser to actually be absorbed by the hemoglobin. And you can also see that he had 2 medial surface lesions, but also had undergone 2 prior procedures earlier in life.
Again. Breathe.
This is his microsurgery. So a subepithelial resection of the left polyp was done. You can see the medial surface, ectasias and fibrous masses. A cephalad edge epithelial chordotomy is performed with a microscissors. As you can see, the minute you make an incision, it bleeds quite substantially, which is what was happening to him on stage. And then you hold the membrane and resect in a subepithelial fashion the vascular mass under it. It's a very meticulous process. You don't want to resect the mass and leave an open raw area because it will then contract. At the cephalad edge, there'll be redundant epithelium at this point because of the mass effect itself, and that can be contoured and tailored so that you have the free edge of that epithelial flap in apposition. What we're now going to see is a saline infusion into the right vocal fold and somewhat hybrid partial subepithelial resection is made on the right mass. It's so fibrous and attached that it can't completely be resected in a subepithelial fashion. So a small area will actually need to be amputated, but you see, you grab it, perform an epithelial chordotomy. Clearly, you need to have some level of ambidexterity because you have to switch instruments for each side of the vocal fold. And as you see, it's then removed so there's a straighter edge, and for some smaller ectasias, one can then bring in the 0.3 millimeter fiber. A similar types of procedure was performed on the left, but there was less of a mass, so this was just treated with the angiolytic green light laser. This is the patient postoperatively, and he has also been fine and touring extensively for the last 10 years, has not either missed a show I'm aware of or had any other bleeding events. It's important to understand that this was his third procedure, so you're not going to see perfect mucosal waves given the amount of phonotrauma and the two procedures that he underwent before he had presented to me. This is another innovation that was described in the 2019 supplement, which came to be very important to us given the COVID pandemic. We had designed a procedure for stenosis where we had an indwelling intra-arytenoid spring which was carved out of silastic rubber. This is not a T-tube because T-tubes in our view can be somewhat problematic, especially if someone presents to an emergency room and the physicians are not familiar with it. We use this device, which I'll show you here, to actually treat patients who have glottic stenosis. This is not for a paralysis patient, but bilateral glottic stenosis from an intubation. It's important to realize the paradox historically. Intubation was formally presented by O'Dwyer in 1886 to treat stenosis. Once we started intubating patients and were kept in intensive care units, it was the intubation that caused the stenosis, unlike the 19th century, which was the infectious diseases that caused the stenosis. This is a key image that comes from Benjamin and Hollinger's textbook, which shows the biology of how a stenosis forms. We actually presented a paradox to that, which was diastasis, which means separation, which happens far less frequently, as you see in the imaging. I think it's important to understand that this then became a key way we could treat these post-COVID pandemic long-term intubation patients, and we had no idea, obviously, in 2019 that this would become so valuable to us in the last 18 months when a whole new group of patients developed laryngeal injuries from prolonged intubations. I would encourage people who are facing these patients now to review that manuscript and look at it, because it's not a particularly difficult procedure to do, and you can preserve the voice substantially better rather than actually trying to resect a vocal cord posteriorly, which is a much easier procedure to do when there's bilateral denervation, not a cicatricial stenosis from endolaryngeal trauma. If you review the manuscript, you'll see there was a very key observation that was made from this anatomical study, which is that endotracheal tubes do not generally or ever impair the cricoarytenoid joint directly. It's the soft tissue stenosis that you saw in Benjamin and Hollinger's diagram. In fact, the facet of the cricoid is not only lateral to where the tube sits, it's actually higher. And so surgeons will actually impair the cricoarytenoid joint. It's not the endotracheal tube. This happens when people actually try to do arytenoidectomies, but in fact these joints are quite intact, which means theoretically the mobility is restorable. This is a typical case that presented to us. This individual had a prolonged intubation from an aortic problem. She had a permanent tracheotomy and did not want to have a chordectomy, which would substantially impair her voice, given the amount of vocal cord that would need to be resected to ensure for the stability of her airway. As you see the endoscopy, you can hear the air escape from the tracheotomy.
Yep, as long as you can.
There was very little aperture here. Now you're looking at a retrograde view through the tracheotomy site to the undersurface of the vocal folds in the glottis. She also had remarkably a cyst in her subglottic that was a benign cyst that also needed to be resected. This is the intra-arytenoid spring which has been placed. I would encourage you to read the manuscript for the technique. You get very substantial granulation until that stent is removed. And again, we modify and show it very clearly how we take a T-tube, which is in just about any hospital, without having a special device. So it's economical as a procedure as well. This is afterwards.
Again, normal.
And you can see she does not have normal mobility, but she's got restored mobility enough for decannulation, and she's quite stable. Her voice has been preserved. So this clearly shows the restoration of arytenoid mobility without performing a procedure that is on the cricoarytenoid joints. With that device in place, the posterior cricoarytenoid muscle can actually pull on the arytenoid, and ultimately you'll end up with a better result than you would have in any other of the conventional procedures, even placing a cartilage graft between the cricoid facets. Here she is after her decannulation. She still has a small stoma, so she's holding it closed so she can describe what this was like for her.
I had an aortic dissection in 2009 that froze the vocal cords and compromised my voice quality and breathing every time I open my mouth. And when I realize I'm breathing on my own, it's very, very exciting. And the frustration with the trach and the maintenance. When you're an extrovert, which I am, it's very frustrating. And, you know, to have the voice back, to have the breathing, to have my life back is just hands down the most exciting thing that can happen. It's just flawless. It's wonderful.
I hope you've enjoyed some of the innovations that we have been working on through the last few decades. I want to do a special thanks to Larry Page, who has been funding my work for a number of years to try to create the procedures of the future, as well as the laryngeal surgery fellows of the future. Without him, a range of things you've seen today would not have been possible. Again, thank you for your attention.
today, both offline.
Thank you, Dr. Zeitels, for that mind-blowing oration. I think thank you very much for taking us through the innovations that has happened, which you have seen through your eyes with your hands. And it is not only the innovations in treatment, but starting from the clinic setting, from imaging, evaluation of diseases, as you said, creating a partnership with the clients or our patients who deserve to get a good voice at the end of the day, and also to let them contribute to the research and development of the newer technologies, newer method of treatment. So that was excellent. We all enjoyed. I, on behalf of the Association of Phonosurgeons of India, would like to really thank you for joining us today. And most important message that we got from your talk on innovation today is that it is not only about curing our patients when it comes to voice, because many of these patients have a livelihood with their voice. So these patients, we not only cure them, but it is all about restoring, as you said, restoration of their life and restoration of their livelihood, and also giving them a reason to live again in life, to do something what they would like to do. So that is the most important thing for us, laryngologists and phonosurgeons, to impart to our patients, in addition to giving them the justice of having good treatment for all these things. Thank you very much again on behalf of the Association of Phonosurgeons of India for joining us and giving this oration today. Also, it is customary for our association to invite you into our honorary life membership for giving this EPSI oration every year, whoever does it. So I declare that you are invited and admitted as an honorary life member, Dr. Stephen R. Zeitels, of the Association of Phonosurgeons of India from this date today. And we would like to interact with you in future. Thank you very much again for the lovely oration. Thank you. Over to the Master of Ceremonies.
That was indeed an illuminating session with the stalwarts of otolaryngology. Thank you, Dr. Stephen Zeitels, sir, for the mesmerizing talk. We also thank Dr. Vijendra, sir, and Dr. Amitabh Roy Chaudhary, sir, for chairing this session. And now we have a keynote address on laryngeal pacing in bilateral vocal fold paralysis by a man who no one needs to introduce, that is Dr. Andres Muller. Chairing the session, we have with us Dr. Deepak Haldipur, sir, and Dr. Gautam Khaunt, sir. Over to you, Dr. Deepak Haldipur, sir, to introduce our guest faculty.
It's a pleasure and an honor for me to introduce Professor Andreas H. Muller. And I would like to personally thank Sanjay Subaya for all the organization that he has been doing. And Professor Andreas Muller completed his specialist training in otolaryngology at the University of Jena, and where he stayed there as a consultant till 2004. Since 2005 until now, he is the head of the Department of Otolaryngology Plastic Surgery, SRH Wald Klinikum Gera, Germany. Professor Muller is a specialist for benign laryngotracheal stenosis, laryngology, and rhinology. His main research interests are neurolaryngology, LEMG, vocal cord paralysis, reinnervation, and laryngeal pacing. In fact, the topic he is talking today is so relevant because we have all been doing something for the vocal cord paralysis, especially the bilateral abductor paralysis. But whatever treatments we are doing so far are mechanical. And invariably, a portion of voice as well as swallowing is compromised in our treatments. How much ever we claim and convince the patients, it's not so. I think if we can really reach the full potential in laryngeal pacing or laryngeal pacemaker and get the necessary approvals, I think it should be a remarkable surgery going a long way in helping the patients in regaining their voice. According to me, it would be something like the next cochlear implantation in the field of laryngology. Over to Dr. Andreas H. Muller.
Dear colleagues, dear Sanyo, thank you for inviting me to this wonderful conference. It's a great honor for me to be your keynote speaker today. I will be happy to give you an overview on history, current status and future of the laryngeal pacemaker, because this is my favorite topic. If you are wondering how I came to this topic, in short my answer, I was moved by the patient's fates. When a secretary can no longer work after thyroid surgery, a woman gives up having children because she no longer has enough air to breathe, or a teacher can no longer speak properly. And on the other hand, the long-term results of standard laser glottic enlargement have not convinced me in total. I have no conflict of interest with the content presented. This is a scheme that I came up with to determine the right timing for therapy with my colleagues. Clinical symptoms appear rapidly after the onset of the bilateral paralysis. Some of the patients need temporary therapy in the short term. The crucial period is between 4 and 6 months. With functional renovation, the movement returns sometimes, at least at one side. If synkinesia or insufficient renovation occur, respiratory problems increase and most patients require permanent therapy at latest after 12 months. Muscle atrophy makes the difference between denervation and synkinetic renovation, as you can see in hypoglossal nerve paralysis on the left slide. In the absence of vocal fold atrophy that you can see on the right video, synkinetic renovation should always be considered in persistent immobility. This is the pathophysiological situation in laryngeal synkinesia causing immobility. The green-marked adductor and the blue-marked abductor fibers of the recurrent laryngeal nerve are co-activated at the same time. You can imagine the situation like in a tug of war. So what is the clinical significance of laryngeal synkinesia? Synkinetic renovation is in our experience the rule rather than the exception. Its presence in laryngeal EMG makes the return of mobility unlikely. But laryngeal synkinesis preserves muscle fiber and contractility, and therefore synkinesia is a useful condition for laryngeal pacing. We all know the limitations of the standard laser glottic enlargement. Either the breathing improves and the voice becomes bad, or if the voice remains acceptable, multiple surgeries are required and the patients are still not satisfied. On the other side of the coin, we know patients who can cope without therapy because they have retained minimal residual mobility on one side. Residual or restored mobility to adapt to different demands of breathing and voice production makes a critical difference. I call therapeutic strategies for at least partial remobilization of one or better both vocal folds dynamic. These include the principles listed above to some extent, but include selective renovation and laryngeal pacing to be presented today in its true sense. From what did the idea of laryngeal pacing originate? The birth of electrical neuromodulation in human medicine was the first cardiac pacemaker implantation in 1958. Another milestone was the first spinal cord stimulation for pain treatment in 1967. As otolaryngologists and phoniatricians, we first got direct contact with electrical neurostimulation in the late 1970s with the introduction of the cochlear implant. For almost 30 years, a small number of researchers worldwide have attempted to introduce functional electrical stimulation of the larynx into the treatment of bilateral vocal fold paralysis. We consider my colleagues David Seeler in Nashville and Klaus Bergmann in Berlin to be the pioneers of laryngeal pacing, who set the milestones from the very beginning. In 2003, David Seeler published the first clinical trial on 7 patients using a pain therapy impulse generator eTRL-2. Unfortunately, these studies could not be continued. In personal communication, David reported that the system was not an ideal fit for application to the larynx and required open surgery to expose the backside of the larynx for electrode insertion. My team started in 2004 with a German Innovation Award and 2 grants to develop a new concept for laryngeal pacemaker adapted to the bilateral vocal fold paralysis condition. At the same time, the Med-El company also started working on a non-cochlear implant product, such as a laryngeal pacemaker. Since 2004, we have been cooperating with Med-El and the University ENT departments in Innsbruck with Klaus Potocznik and in Würzburg with Rudolf Hagen on the development of the laryngeal pacemaker as it stands today. In the following, I would like to present you the current status of the LP project. The LP system from Med-El reminds of a cochlear implant. The power supply and the control electronics are external. This is beneficial in a development project as it allows changes to the system without the need for another surgery. Only the electrodes and a transducer system are implanted. This graph gives an overview of the development steps. Our goal was to develop a minimal invasive surgery for reversible insertion of the stimulation electrodes into the larynx and a pulse generator specifically adapted to the larynx. 2012 was then the time we started clinical trials of the LP system in Gera, Innsbruck and Würzburg. Unfortunately, a few years have passed since this very successful study, which we have used intensively for further develop the system. The components of the Med-El laryngeal pacemaker development project consisting of the insertion tool, 1 or 2 microelectrodes for electrical stimulation of the posterior cricoarytenoid muscle, the LP implant with inductive transmission coil and connectors, as well as the external ILP processor with control unit and battery. The operating principle of the pacemaker is based on the selective terminal stimulation of nerve fibers of the recurrent laryngeal nerve in the target muscle, the PCA. These endings are present in the synkinetical renovated muscles despite paralysis, and the muscle fibers innervated by them are able to contract. Keeping in mind the basic principle of the pacemaker, it becomes clear that an innovation, even if it is a synkinetic one, has to be required. This is easy to prove with the laryngeal EMG. Of course, the vocal folds must be mobile in the joints. The most reliable method of determining suitability of a patient for LP is electrical test stimulation of the PCA muscle. In this video you can see the procedure of such a test stimulation under video endoscopic control in a short laryngeal mask anesthesia without muscular relaxation. First, an EMG Botox needle is inserted transluminally over the ligamentum conicum and pushed through the cricoid plate into the right PCA muscle with a gentle drilling motion. If the patient is suitable, a so-called hold spot is found in the muscle where the correct nerve endings are stimulated and abduction of the vocal fold can be observed endoscopically. A second needle can be used to stimulate the opposite vocal fold and both sides. This is a case suitable for bilateral laryngeal pacing. The actual electrode implantation is performed similarly to the test stimulation. An electrically stimulatable hollow needle with a stylet is used as the insertion tool. The tool is guided strictly submucosally along the inner surface of the cricoid cartilage arch to the cricoid plate. If necessary, the needle position in the PCA is corrected in the cranial caudal or medial lateral directions until the pure abduction movement is seen. After removing the stylet, the 3 French electrode is advanced over the cannula to the PCA muscle and anchored there with its spiral tip with 3 clockwise turns. The cannula of the insertion tool is then withdrawn and a test abduction stimulation is performed using the electrode in place. In our study, this was the workflow from screening a candidate to activation of the LP system 2 weeks after surgery and final fitting of the stimulation parameters after 1 month. With this clip of a real LP system implantation, I would like to demonstrate the steps of cricoid plate drilling with the insertion tool and the search for the hotspot once again. You can see in this video that you have to take your time not to stick the needle too deep in direction to the pharynx. The black line marks on the tool, here you can see, help with depth orientation. On the video monitor you can see the abduction of the right vocal fold when the tool is placed in the hotspot. Now you take the sterile electrode, remove the stylet of the insertion tool, now the soft electrode is inserted via the insertion tool and screwed into the PCA muscle. This blue stylet of the electrode is removed. Then the insertion tool can be removed and the electrode is connected to the stimulation device. After control stimulation via the electrode, the attachment of the electrode to the cricoid cartilage arch with a dislocation protection is the next and very important step. The results of our first-in-human study with the LP system can be found in the laryngoscope publications listed here. In brief, we saw high patient safety, immediate onset of action after activation, and a long-lasting effect in the 7 patients we followed up. We did not see pain or unintended stimulation of other muscles. The patients adapted excellently to the stimulation rhythm with their breathing. The voice and the swallowing were not negatively affected. This was our first study patient. She had a 16-year lasting bilateral vocal fold palsy with dyspnea and minimal physical exercise tolerance. She showed an increased need for sleep, was socially isolated and unable to work. Another problem for the family and for travel was her extreme snoring at night. On the left video you can see the initial situation. On the right, the clear abduction on the vocal fold after 12 months. Here you can see. Long-term follow-up at 18 months and 24 months shows an increase in LP-induced abduction rather than a decrease in effect.
So, mal Luft holen und dann ein Hieb. So, mal Luft holen und dann ein Hieb.
What happens during voluntary phonation and swallowing? On the video on the left side, you can see the simulated abduction without voluntary activity of the patient. You can see the right-sided abduction. On the right side, the patient speaks and overrides the activity of the pacemaker without affecting her voice. This slide here gives an overview of the main results of our previous studies on the LP system. By the primary endpoint of the study at 6 months, peak expiratory flow, maximum phonation time, sound pressure level range, and exercise capacity improved as measured by the 6-minute walk test. Quality of life, inspiratory breathing, and tone holding time continued to improve in the long-term follow-up at 12 and 24 months, while swallowing function and subjective voice perception remained unaffected. The long-term stability of the electrodes proved to be an unexpected problem. The upward and downward movements of the larynx resulted in interaction and buckling movement on the electrodes and later to ruptures, as you can see here in the X-ray. 3 electrodes broke within 2 years, the red ones, and 2 in the 5th year here. The 2 remaining electrodes are still functional. These are the current assumed contraindications for the LP system. the fixation of the vocal fold in the joint, but also due to scars after previous glottic enlargement or after surgery and radiation of head and neck cancers, impede abduction. Although the principle should be likewise applicable in children, there will be initially no LP approval for this age group and also for neurodegenerative diseases. Here's an example of bilateral vocal fold immobility. What is your opinion on suitability of the patient for laryngeal pacing? For me, the case is not suitable because of the abduction incapacity due to scarring of the posterior commissure. And here is a recent COVID-19 case, right-sided lateral fixation by colleagues at another hospital only resulted in a notching of the vocal fold and worsening of the voice because of the joint was fixed by scarring. We performed a partial laser arytenoidectomy on the right, reconstruction of the right, and mobilization of the left vocal fold by synechial transection. So what steps are in the pipeline? The electrode design has been completely revised. The new electrodes have significantly higher long-term stability and lower spring force. Other innovations include shortening surgery time with smart tools, better electrode and implant fixation with strain relief, and bilateral electrode implantation is possible in the next study if the patient is suitable. After a long wait, new studies have been announced this year. These should involve up to 10 centers in Austria and Germany and help to gain approval for the LP system in future. In perspective, adduction stimulation for unilateral paralysis in patients with high voice demands is also considered. These are my take-home messages for you. Even if the laryngeal pacemaker is not yet available to you, think now about preventing complete denervation and irreversible scar fixation of the vocal folds. This will give your patients the chance to benefit from dynamic therapeutic strategies such as selective renovation and laryngeal pacing in future. So there would be time for questions and answers, but unfortunately I'm not able to answer to your questions right now. But I want to give you some answers to frequently asked questions. Does the LP stimulation affect the voice or swallowing? No. The opening stimulation is less powerful than the voluntary closure during phonation and swallowing. Minimal pitch fluctuations can only be noticed during singing. Is the LP stimulation synchronized with breathing? Not yet in the current status of the LP development. At the moment, the patient can select preset programs for sleep, normal activity, and sport that are tailored to him. Will the MED-EL system become available in your country? If the approval study in Germany and Austria is successful, MED-EL representatives told me the aim is to obtain worldwide approval. India will play an important role in this. At the moment, it does not make sense to contact your national MED-EL representative. The company will actively contact centers in India in future.
Dear colleagues, so I come to the end, and I very much regret that I could not talk to you in person and not being able to be online today to answer your questions live. Hopefully you got something out of my talk for your work. Don't be hesitant to contact me if you have any further questions. I would like to invite you to one of our next neurolaryngology workshops in Germany, maybe online or in present in future. I wish you a successful Congress today and many new impressions. Yours, Andreas.
Thank you, Professor Muller, for your excellent deliberations. On behalf of the Association of Phonosurgeons of India and the organizing committee, and also my co-chairman, Dr. Deepak Haldipur, I'd like to thank you for sharing your profound knowledge with us and delivering the keynote address. Sir, the ending comments of the take-home messages and the FAQs would be very useful for most of us. It will actually stimulate us to start taking up doing non-selective reinnervation surgeries in the patients of vocal fold paralysis, so that we can actually think about the future if the laryngeal pacing is available in our country. Thank you again. We are unfortunate that we cannot have you in person. And thank you once again from all of us here.
Thank you for that wonderful and highly informative session, Dr. Muller, sir. We also thank Dr. Deepak Haldipur, sir, and Dr. Gautam Khan, sir, for sparing their precious time to chair the session.
We would now like to introduce Dr. Tanya Mayer, ma'am. She had her wonderful talk yesterday and on our day one, that was evaluation of and management of laryngeal dystonia and tremor. Now, ma'am wants to be live and she wants to answer our questions. Ma'am, we have some few questions for you, ma'am, based on your talk. Question first one, what is the difference between spasmodic dysphonia or muscle tension dysphonia except the voice perceptual assessment?
So I think they have a very different, well, first of all, thank you for the opportunity to answer these questions live today. I very much appreciate it. It's a fantastic conference and I was enjoying listening to the previous presentation. And thank you for allowing me the opportunity to give my talk. I think in my perception, muscle tension dysphonia and spasmodic dysphonia have a different biologic basis. I think spasmodic dysphonia is a neurologic disease that's centrally mediated. Muscle tension dysphonia is probably a group of disorders and is more of a diagnosis of exclusion. So you have, and probably different clinicians might diagnose it a little differently. So you might have, you know, somebody that has a post URI or a post sort of vocal overuse where they have just started to use their larynx in a abnormal manner, and then they have persistent hoarseness. But the idea is that it's not necessarily a a permanent neurologic deficit. It's more as if they have a motor, the way they're using their voice or their laryngeal posture is abnormal, but it could be fixed fairly quickly with speech language pathology in a willing patient. There's a lot of, in some individuals, there's some psychiatric overtones. So we can use Botox to fix muscle tension dysphonia in certain individuals. And theoretically, once the Botox wears off, perhaps their speaking pattern would normalize. But certainly, speech pathology is the mainstay of therapy for muscle tension dysphonia, as opposed to spasmodic dysphonia, where you can certainly utilize speech language intervention for spasmodic dysphonia, and it might assist in understanding the disease process, or with tremor, it can help the patient learn how to speak around their tremor, but it won't stop the spasms, and you'll have this really dramatic, in the individuals that do respond to Botox, you'll have a fairly dramatic normalization of the voice, and they won't ever need speech pathology again for voice therapy.
Thank you, ma'am. Ma'am, another question is, what dose of botulinum injection you give in spasmodic dysphonia, and at the starting, and in what frequency do you give?
That's a great question, because I think different people really start with different doses. I happen to always start with fairly low doses, and I have patients that have doses as low as 0.1 units. And then, up to 5, 6, 7 units for the thyroretinoid, much higher units, much higher for the false vocal fold or for the posterior cricoretinoid. But certainly I see patients that have been referred to me where typical starting doses might be 2.5 units. I would be afraid if I gave my patient 2.5 units that they wouldn't swallow for, 6 weeks. So I think in different hands, and I don't fully understand that, in different hands, the dosages can be very, very different. But for me, if it's the typical adductor spasmodic dysphonia, it depends a little bit on the robustness of the patient's ability to compensate if they have dysphagia. So if I have a very old, frail woman, I'll definitely start a little bit lower, because if she has already some underlying age-related trouble with her swallowing, I don't want to really knock it out with a higher dose of botulinum toxin. And then I might start with a 1/2 unit or a 1/4 unit, and maybe even just on one side. But it's very standard for me to start with a 1/2 or a 1/4 unit and then titrate up from there. And then some of it depends on how close the patient is. I have a referral area that might be where they have to fly in to see me, and I might start a little bit higher with education on them, just because it's too hard. If they live 20 minutes away, then I can start fairly low and then boost them if it's too low. And then the typical interval is 3 months, but many of my patients are more around 10 to 11 weeks.
Thank you, ma'am. Thank you for this clarification. And thank you for coming on live and giving us this opportunity to get you answers. Thank you, madam.
Absolutely. Thank you. And certainly if anybody wants to email additional questions, I'm available for that.
Thank you, ma'am. We now have our first set of presentations by young and budding ENT surgeons for the Rising Star Award.
Hello everyone. In this presentation, I would like to share my initial experience and management protocol in treating early glottic cancers using transoral laser microsurgery. This work has been done between 2 cancer centers in Bangalore, that is HCG Cancer Center, as well as SiteCare Cancer Hospital, where I'm currently working. I would like to acknowledge the support and mentorship of my senior colleague, Dr. Vishal Rao, during this journey. Just a bit of background. As we all know, vocal cord is a very sensitive site, and any changes of this region would result in a change in voice. The most common malignant pathology in this region is a squamous cell carcinoma, Fortunately, this anatomical site has a very sparse lymphatics, and the treatment includes only treatment of the primary, that is the vocal cord, without the need of addressing the lymphatics in the neck. In terms of treatment options, there are two major treatment options available, that is external beam radiotherapy as well as transoral laser microsurgery, the carbon dioxide being the preferred laser. So when you have two treatment options available, the decision of choosing one over the other in oncology is primarily based on cancer control outcomes in terms of local control as well as overall survival. In addition, when both have a similar oncological outcomes, the other important determinants are the functional preservation in terms of voice outcomes as well as long-term larynx preservation rates. And of course, in Indian scenario, cost is a significant determinant of choosing one over the other. There have been numerous studies done over the last 3 decades to show that in terms of oncological efficacy, transoral laser surgery is equivalent, if not better than radiotherapy. There are reports suggesting that organ preservation rates are better than that of radiotherapy. And in terms of cost of treatment, the transoral laser surgery is significantly cheaper compared to that of radiotherapy. The other advantages of transoral laser surgery over radiotherapy are, since this is a very precise cutting tool, there is minimal collateral damage. As a result, the morbidity is very less, the functional recovery is very fast, and these patients stay in the hospital for a very short time. When we do transoral laser surgery, we take out tissue for pathological analysis, and the follow-ups of these patients can be done very easily using endoscopes in the clinic. And we can always keep radiotherapy as a backup if at all there is a second primary. To run a successful endoscopic laser service, there is a need of close collaboration between multiple teams. We need to have a support from the institution to provide the infrastructure and instruments. We need to have a good training. There is a need of a close collaboration between the anesthesia team, where we share the airway, and the pathologic team who analyzes these tiny specimens. We need to have a good nursing team and a good rehab team to get the best voice outcomes. In terms of case selection, the best ideal cases for transoral laser surgery in the beginning of the career are superficial lesions which are limited to the anterior two-thirds and lesions which are just going to the anterior commissure without significant subglottic extension or extension in the posterior two-thirds, that is towards the arytenoid. There are certain intraoperative determinants before deciding for transoral laser surgery with curative intent for vocal cord cancers. That is the good laryngeal exposure under anesthesia in suspension laryngoscopy, what amount of anterior commissure is visualized, especially when you're dealing with lesions which are extending to the anterior commissure. We can also use some blunt instruments as well as suction tips to ascertain what is the depth of infiltration, which can be doubly made sure by using saline injection to ascertain whether it's involving the ligament or not, and plan the extent of resection preoperatively based on this. In addition to the above mentioned factors, another important treatment decision making is a discussion with the patient, understand the voice expectation and the profession before embarking on transoral laser surgery. The importance of pathology participation is very important. So to get the best pathological analysis, once we resect these specimens, we need to orient this properly. So our practice is to pin the specimens on a pictorially represented vocal cord on a paraffin block. We also ink the margin in addition to pinning it so that the orientation is proper and the analysis is proper as well. So in terms of results of our series, so I've I have operated on about 58 cases of early glottic cancers, T1, T2, between the period of February 2019 to December 2021. In terms of the analysis, male population predominated the series with about 85% of the cases, with a median age of about 60 years. In terms of case distribution, T1A was the most common clinical stage which was operated, which contributed to about 57%, and T2 contributed to only about 5% in our series. In terms of number of patients who underwent a second look laser, that is a patient who had a granulation tissue or a suspicious lesion on follow-up at about 3 to 4 months' time, went back to the operating room and got this lesion excised. Out of the 12 patients out of the 58 who needed a second look laser, 5 had residual disease, and rest of the 7 were basically had some granulation tissue which didn't have any cancer. Out of the 5, 2 patients had a positive margin for which they needed an adjuvant therapy, and these 2 patients who had a residual disease needing adjuvant therapy ended up having a total laryngectomy. So in our series of 58 patients, the larynx preservation rate was about 97%. To conclude, transoral laser surgery based on the initial data and the available data suggests that it's an effective alternative to radiotherapy in early glottic cancers. However, case selection is very important to achieve the best outcomes. It's very important we audit our cases in terms of oncological outcomes, voice, and larynx preservation rates. Thank you.
Greetings to one and all. I am Dr. Asitama Sarkar, and I shall be speaking about correlation of narrowband imaging findings using knee and European Laryngeal Society classification systems during office flexible laryngoscopy with histopathology. What is narrowband imaging? When white light passes through an optical filter, the blue and green light are allowed to pass through, whereas the red light is filtered out. The blue light and green light have a wavelength of 415 nanometer and 540 nanometer respectively, which allows variable penetration, and we can see the superficial and the deeper mucosal blood vessels. Under the blue light, we see them as brown colored blood vessels, whereas under the green light, we see them as cyan or blue colored blood vessels. These blood vessels form a pattern which are known as intraepithelial papillary capillary loop patterns, or IPCLs. These IPCLs have been classified by Nie et al., and they have revised their classification in 2018 to have 6 type of IPCL patterns. In type 1 pattern, we find the leukoplakic patch as well as branching or obliquely present blood vessels around that leukoplakic patch. In type 2 pattern, the leukoplakia is present, but we will not find any IPCL nor any branching patterns. In type 3, there are regularly placed brown dots, which are these IPCLs, and they do not have any particular boundary, and they are identified only in places where there is no leukoplakia. In type 4, the IPCLs are embedded on the leukoplakic lesion. In type 5, we see the leukoplakia surrounding which the IPCL patterns can be identified, and there is no particular boundary around it. In type 6 pattern, they form a squiggly earthworm-like pattern, brown dots, these IPCLs, and Nie et al. Have classified that type 1, type 2, and type 3 are expected to be around benign lesions, whereas type 4, type 5, and type 6 pattern, if they are present, the lesion is most likely malignant. The European Laryngeal Society have also classified their IPCL patterns, and their classification is much simpler. According to them, if there's a longitudinal blood vessel pattern, it is likely to be benign, whereas if there is a vertical blood vessel pattern, or as seen as dots over here, it is likely to be malignant. What is the objective of our study? To correlate the NBI findings with the histopathology of vocal fold lesions and to investigate effectiveness of both these classifications in differentiating between benign, dysplastic, and malignant pathology. This is a retrospective observational study wherein from our archives of the NBI findings, we pulled out representative photos and classified the data using the NE and ELS classification. The histopathology reports were divided into 4 categories. The benign categories were non-dysplastic and low-grade dysplasia, whereas malignant categories were high-grade dysplasia and invasive cancer. These NBI findings were then correlated and analyzed with the histopathological findings. Our results, we had a total sample size of 25 with the mean age of 62.24 years. Now, using the European Laryngeal Society classification, we found that 28% of the patients had a longitudinal pattern blood vessel, whereas 72% had perpendicular. Now, the longitudinal is expected to be a benign lesion, whereas 72% who had perpendicular pattern blood vessels are expected to have malignant lesion. Using the knee 2018 classification, we found 4% to have type 1 knee pattern. We did not find any patients with type 2 or type 3 knee pattern. We found 8% patients to have type 4 knee pattern. Type 5 was seen in 64% of the patients, and type 6 knee pattern was seen in 24% of the patients. When we actually, after the surgery, did the histopathology, we found that 8% of the patients had non-dysplastic lesions, 16% had mild to moderate dysplasia. Both of these were considered benign. 8% of patients had severe dysplasia or carcinoma in situ, and 68% had invasive carcinoma. When correlating using the European Laryngeal Society classification, it correlated with histopathology findings 64% of the times. We had 4 false positive cases. That is, 4 patients showed vertical pattern of blood vessels, but they did not have malignancy, and 5 false negative cases wherein the patient had malignancy, but it was not detected. Using the NE 2018 classification, it correlated 80% of the times. 5 such patients who were expected to have malignancy did not actually have malignancy on histopathology. Further discussing these lesions, the 2 patients with non-dysplastic lesion, both of them were vocal fold polyps. Using ELS as expected, both patients had longitudinal blood vessels, which is benign. And using the knee classification, 1 patient had type 1 pattern, whereas the other had a type 6 pattern vascular change. Now for low to moderate grade dysplasia patients, using ELS, all 4 had perpendicular vascular pattern, and using knee, 2 had type 4 and 2 had type 5. Now the perpendicular as well as type 4 and type 5, all of them are expected to be malignant. So this was in complete discordance. In this video, we can see on the left vocal fold a polypoidal lesion and on the right vocal fold a leukoplakic lesion. On histopathology, the left vocal fold had a polyp, and on the right, there was a low to moderate grade dysplasia. Using the NBI, however, we can see the vertical blood vessel or the perpendicular blood vessel as a dot, and this again is in discordance to what we expect. Severe dysplasia was seen in 2 patients. This was carcinoma in situ. One of them had perpendicular blood vessel with type 5 vascularity, and the other patient had longitudinal blood vessel with type 6 knee classification vascularity. We can see this perpendicular blood vessel over here in this patient, and his histopathology was carcinoma in situ. Invasive carcinoma was seen in 17 patients. Out of them, 13 had perpendicular blood vessel pattern, which was in accordance. And using the knee classification, 13 patients had type 5 vascular pattern and 4 had type 6 vascular pattern. Again, 5 and 6 are expected to be malignant, which is in accordance. In this video, we can see the leukoplakic lesion on the anterior commissure, and on NBI, we can see the IPCL loop patterns on both the right and the left vocal folds. How is this clinically relevant? The prominent vascular changes play an important role in identifying the nature of the lesion. In our study, though knee classification had better correlation with histopathology, we found that ELS was also a simple way to identify the blood vessel pattern. Mainly the discrepancy that were noted were in the cases of recurrent respiratory papilloma. We also noted that the earthworm pattern, that is type 6, is often confusing to identify as perpendicular or longitudinal. And we suggest that using both these classification systems, an office-based optical biopsy of clinically suspicious laryngeal lesion would help in planning an early as well as an adequate management. William Shakespeare says the eye sees all, but the mind shows us what we want to see. But for laryngologists, the eye does see all. NBI shows us what we want to see. Thank you.
Hello everyone. This is Dr. Deepa Shivnani from Children's Airway and Swallowing Center, Manipal Hospital, Bangalore. First of all, I thank Team PHONOCON for giving me this opportunity to present our work about point-of-care ultrasound, an alternate to rescue laryngoscopy in evaluation of pediatric airway. We have nothing to disclose. Pediatric airway evaluation is critical for safe and effective management of airway lesions that present with stridor or hoarseness. In this age group, preliminary diagnosis and post-operative surveillance are difficult too. The gold standard modality is laryngoscopic examination and to a certain extent, computed tomographic imaging, which is time-consuming and comes with the added risk of anesthesia and radiation exposure respectively. In COVID times, this becomes more challenging. So we came up with the hypothesis of using point-of-care ultrasound in upper airway evaluation, especially in resource-limited setting. POCUS involves the bedside use of ultrasound to answer specific diagnostic questions and to assess real-time physiological responses to treatment. It is a safe and validated tool. It has been well established in emergency medicine and intensive care unit. Our objective was to evaluate the ultrasonographic appearance of laryngeal pathologies in pediatric cases and compare the finding with laryngoscopy. It was a prospective study from June 2019 to June 2020. Children who needed endoscopic airway evaluation and examination were taken up for ultrasound examination prior to the procedure. We used linear probe. The patient was placed supine with neck extended. The thyroid cartilage was identified by palpation. The probe was moved superiorly and inferiorly till different laryngeal structures were visualized. The images and videos were taken during the ultrasound, documented, and compared with laryngoscopic findings. The sensitivity and specificity was then calculated. Total number of cases were 32. The procedure was easy to perform, took less than 10 minutes in most of the cases, and allowed for easy photo documentation. While comparing the findings with gold standard laryngoscopy, we found the sensitivity of ultrasound was 96% and the specificity was 75%. So why are we looking for the another screening modality when we already have laryngoscopy as a gold standard? Because ultrasound is non-invasive as compared to flexible laryngoscopic examination. It is simple and easy to perform. It is widely available even in secondary or tertiary care hospital as compared to pediatric flexible scope. Ultrasound is pain-free and a safe procedure. It gives real-time dynamic images which can help us in identifying dynamic airway lesions, and it can be accurate in experienced hand. As you can see, the use of ultrasound has been well established and evolving in various airway pathologies and applications like surgical decision-making, emergency airway management, vocal cord mobility, dynamic assessment of airway, vocal cord lesions, or even in tracheal diameter assessment. But for accurate diagnosis, it is important to understand the sonoanatomy, the artifacts, and the pathological presentation. So let's have a look on some of the conditions and POCUS applications. Here we have a radiological finding of upper airway collapse, which was diagnosed as a case of laryngomalacia and was confirmed with the endoscopy. As here you can see the upper airway collapse with this hyperechoic part of the epiglottis, which is resembling and showing in the endoscopic as well. Another case of vocal cord palsy with both the vocal cords in median position and was confirmed with endoscopy. A case of supraglottic stenosis with multiple hyperechoic lesions. A case of subglottic stenosis with airway narrowing. Vocal cord nodules as hyperechoic lesions at the junction of anterior 1/3 and posterior 2/3 of the vocal cords. A polypoidal hyperechoic lesion post-intubation suggestive of granuloma. The hyperechoic multiple lesion suggestive of laryngeal papilloma with patent airway, and here with some of the airway compromise. Similar papillomatous hyperechoic lesions were found in the subglottis, and the ultrasound diagnosis of subglottic papilloma was established by the endoscopic confirmation. So here comes the application of this point of care ultrasound in rescue laryngoscopy. If we see the ultrasound image with the patent airway, we can wait and watch with that child, the known case of laryngeal papilloma. And if we see the airway compromise has already happened, then it is time to take the child for endoscopic evaluation. And another application for assessment of surgical field, where we wanted to perform the tracheostomy and wanted to check the surgical field for the bleeding and some blood vessels in and around the surgical site. We confirm with the ultrasound probe and perform the surgery safely. Another application of tracheal diameter assessment, here where we usually do the endoscopic examination and check the peritubal space, whether to upsize the tube or no. Similar was done with the tracheal diameter assessment by ultrasound probe, and it was analyzed that ultrasound can be safely used for tracheal diameter assessment. Like any other modality, this modality also comes with a limitation, like there is a long learning curve and you can have inter-observer bias as well. Some of these small lesions on the mucosa we might miss on the ultrasound evaluation. So to conclude, although direct laryngoscopy is the criteria standard, laryngeal ultrasound may have a role in the early diagnosis of, surveillance of, and operative planning for pediatric airway lesions, with the advantages of simple, highly accurate, no radiation exposure, non-invasive, painless, and less expensive than other techniques. It can be helpful to avoid laryngoscopy under anesthesia to a certain extent. At the end, I thank to my pediatric emergency and ICU team, all the patients and their parents for taking part in this study. The kids feel happy when they are listening to their heartbeats, but they are more fascinated while looking into the voice box. Here are some of the references for details. I'm sure one day this will become the new generation stethoscope. Once again, thank you all for patient listening.
Good morning, everyone. We are here presenting before you our experience in managing laryngeal trauma during the COVID times. Our main objective was to measure the outcome of these patients who are managed during the period, but we are also want to highlight the management strategies which we are forced to incorporate, and also the financial burden faced by these subjects due to the trauma during the COVID times. It's a retrospective study done over a period of the 1.5 year pandemic, and majority of our subjects were male, were more than 50 years of age. They predominantly arrived from the district around us, and 14 of them received primary care near the nearby site before being referred to a hospital. And 90% of them reach the hospital within 24 hours of the injury. When you look into the type and the mode of injury, predominantly it's a blunt injury. Though it is COVID and it is due to trauma, still the road traffic accident contributed to the blunt injury. And the penetrating injury is predominantly due to bull gore and also due to deliberate self-harm. And 63% of the injuries happened in the zone 2. And we found 27% of them have closed neck injuries. Though they don't have any obvious external injury, they have prominent findings during the surgery. The presenting symptoms predominantly of the laryngeal function in the form of change in voice or airway compromise, but they also have multiple localized symptoms like pain in the neck, loss of consciousness, they had difficulty in swallowing, they presented with air under the skin and also bleeding through the neck wound. Look at the clinical findings. Here is a picture where we want to highlight the closed neck. There is no obvious injury. We can see minimal erythema in the neck. And patients had loss of contour, their tenderness, and also some have surgical emphysema and air leak through the wound. This is an important thing. Actually, half of our patients had concomitant injuries. This highlights the need for secondary survey, as even airway injuries can be picked up later during the secondary survey. And we found that these patients, out of the patients who are presented to us, the airway was found to be stable only in 2 out of the 19 subjects, which needs to be secured in 10 in the form of tracheostomy, which is again a major challenge as it's an aerosol generating procedure. And in spite of it, 1 was done in the emergency room itself. And 15 of the 19 subjects, almost 75% of need surgical intervention, as majority of them fell within the grade 3, 4, 5 of the Schaefer's grading. They were evaluated in the casualty based on the feasibility in the form of flexible nasopharyngoscopy. Though it is an aerosol generating procedure, it is done with minimal modification. And also 17 of them, almost predominant 95% of them had a contrast NLCT of the neck. With all these evaluations, COVID status, we can't wait for the COVID status when it comes to managing the airway. It is an emergency. So all the patients were considered as COVID positive and they were managed accordingly. They were taken up to COVID high-risk status, and all the personal protective equipments were owned by the surgeons and the assisting people during the evaluation and also during the follow-up. Since COVID result takes almost 24 hours to come, we took them as everyone as COVID positive. And here we want to just highlight the modification which we were forced to incorporate during our tracheostomy. The intubated patients, the intubation tube was pushed beyond the patient place where we make the window, and nice oxygenation was given. When the window was being made, we maintained apneic ventilation. We were able to insert the tracheostomy tube and it was connected to a closed circuit so that the least amount of aerosols generated while doing these airway procedures. And we want to highlight the injuries which happened over here. And the epiglottic injury was found in 9 of the 15 subjects who were operated. It's a very important injury, as if not properly identified, since it's not easy to pick up by radiology, and also if it is not fixed properly, post-op, we may need to take them up again, as it can compromise both the airway and also interferes with the swallowing. They had cricoid fractures, we had thyroid cartilage fractures, even trachea was injury among our patients. We measure outcome in the form of airway, swallowing, and the voice. We had 1 patient who died due to hypoxic injury, and airway, in the form of, we were able to decannulate 90% of our subjects. 1 having a hypoxic ischemic injury, we were not able to decannulate till date. And among the swallowing, we were able to remove the NG and able to make our patients eat normally, other than the 1 hypoxic injury patients. The voice being assessed over the last 1 year, it's found to be good in 15 of the 19 subjects, which amounts to around 75% of people. When it comes to complications, we have a few complications as directly related to ENT and also few other complications because of the prolonged stay in the ward. And this few of the complications in the form of peristoma and suprastomal granulations and also that esophageal web, actually these patients need a intervention. The rest of them were managed conservatively. When it comes to the socioeconomic status of our people, predominantly more than 70% of them fell in the lower socioeconomic status group. These subjects, in addition to this lower income, due to the COVID, that also being stopped, few of them even lost their job and they attempted deliberate self-harm, and none of them had mental health issues. The hospital stay was 60% of them had less than a week. In spite of that, only few of them were able to settle their entire hospital bill. Almost 70% of them required support in some form of the other financially. Hence, in spite of the trying times due to COVID, our laryngeal trauma subjects with little extra precautions in the form of ventilation had a very good functional outcome. It's not only the expertise, but also the teamwork and excellent institutional support system that enable these subjects with laryngeal trauma to get back to their society as before with a good outcome. Thank you.
I am Dr. Laya Manasa Shrira, and I'm present about outcomes of endoscopic management of acquired subglottic stenosis in a tertiary care children's hospital. The objective of my study was to determine the effectiveness of endoscopic surgical management in pediatric subglottic stenosis. This was a prospective review of single surgeon case files from 2014 until present. Our inclusion criteria was subglottic stenosis and laryngeal web with subglottic stenosis. Exclusion criteria was isolated laryngeal web with no subglottic component, isolated posterior glottosubglottic stenosis or tracheal stenosis. We used the Meyer-Cotton grading system to grade our patients. And this was the statistical information, statistical software, and the tests that we used. We divided our patients into two subgroups, Group A and Group B. Group A comprised of patients who had grade 1 or grade 2 subglottic stenosis. Primarily, they underwent an endoscopic dilatation. If the procedure was successful, this group of patients was observed. If the procedure was not successful, this group of patients went in for an LTR along with the patients from grade 3 and grade 4 subglottic stenosis. When LTR was successful, these patients were not included in our study subsequently. But if LTR was not successful and the patients had residual subglottic stenosis, then they were classified as Group B, and then they went in for a endoscopic dilatation. So endoscopic surgical techniques, the goal was to achieve a normal airway or asymptomatic grade 1 subglottic stenosis. We used cold steel cuts with Mercedes-Benz cuts and scar divisions. Dilatations were done using balloons, bougies, and angioplasty balloons and metic airway balloons. Granulation tissue removal was done using cold steel methods, coblator or laser. Variably, adjuvant treatments like Kinocort injections, Neosporin H ointment, and mitomycin C injections were used. This is a video of the endoscopic management. We see a thin membranous scar here, subglottic stenosis, and the Kinocort injection is being given here. Injected into the membrane, and we can see the Kinocort coming out. Then, using a cold steel sickle knife, triradiate cuts or Mercedes-Benz cuts are given at 12 o'clock, 4 o'clock, and 7 o'clock positions, following which a balloon is introduced. This is still the cuts being given. Next step is balloon dilatation, where a metic airway balloon is being introduced in this patient. and the balloon is inflated and kept in place for 2 minutes. And if the patient develops desaturation before that, then again the balloon is removed. So we can see the airway improved, the stenosis improved after just this one dilatation. So then the group of patients who underwent LTR or PCTR, the surgical steps, I'm just skipping through because these were just textbook steps we followed. After the LTR, 4 weeks post LTR, patients underwent endoscopic evaluation. If the airway was adequate, then the patients were just observed. If the airway was compromised by stenosis or scarring or granulation, these went into our group B criteria, and we graded the stenosis and treated these patients also endoscopically. How we defined outcomes for group A was success was defined as adequate airway with no respiratory distress. Failure was defined as failure to improve by endoscopic treatment requiring LTR or PCTR. In our group B patients, success was defined as an adequate grade 1 airway for single stage cases and successful decannulation for double stage cases. Failure to decannulate needing revision LTR or PCTR was our definition of failure. So for the average of 39 patients, the average age was 49 months, ranging from 0 to 169 months. 69% of the population was male and 31 was female. For the group A, we had grade 1, 2, and 3 patients. Grade 1, there were 2 symptomatic patients, and they required an average of 1 procedure per patient, endoscopic procedure, and 100% of them were treated successfully. Grade 2, there were 15 patients. They required slightly more number of procedures, 1.6 procedures, and 93.3% of the patients were successful. 1 patient was lost to follow-up, and hence it was considered a failure. Grade 3, there were 9 patients, and these required a much higher number of procedures, 2.4 in average, and only 44.4% of these patients improved. And the rest went in for an LTR or a PCTR. But in these 44.4% of patients, we were able to avoid this LTR or PCTR procedure. Group B is post-LTR endoscopic treatment. There were some patients who had just a small granulation or they were asymptomatic in grade 1. So no endoscopic procedures was done in these patients. Symptomatic grade 1 patients, there were 2 patients and they required an average of 1 procedure per patient and were treated 100% successfully. There were actually 4 patients in grade 2, 3 of which straightforward. They had 2.66 procedures and 100% improvement. 1 patient is still ongoing endoscopic treatment. So coming to the success rates, in general, literature says that 40 to 94% of the patients are successful, depending on the severity of stenosis. The literature shows that success rates for endoscopic procedures in grade 3 subglottic stenosis were not as encouraging as grade 1 or grade 2. But we almost always tried endoscopic treatments, especially in membranous stenosis, before planning open procedures for these patients. Different techniques have been described for managing cicatricial and non-cicatricial subglottic stenosis, like cold steel instruments, lasers, balloon dilatations, and bougie dilatations. We are more in favor of cold steel instruments, and we have shifted from bougies to balloons because we suspect there is a shearing effect caused by bougies, which may injure the delicate mucosa. So for grade 1 and 2 discussion, we follow the Monier et al. Algorithm for endoscopic interventions when the patient is having grade 1 or 2, or in some grade 3 patients where the length of the stenosis is less than 1.5 centimeters and the stenosis is membranous in nature. Of those with grade 2 stenosis, 93.3% of the patients improved, and that is average of 1.6 procedures. And in group B, 100% of the patients improved with an average of 2.6 procedures with endoscopic management. So the average number of dilatations undergone by grade 3 patients before we deemed them as endoscopic procedure failures was 2.4 procedures. In our study, 44.4% of grade 3 patients recovered with endoscopic management and were able to avoid open surgery as mentioned earlier. So it is worthwhile to attempt endoscopic methods in grade 3 subglottic stenosis before taking them up for open procedures. I conclude with the following points. Endoscopic treatments are successful for varying grades of subglottic stenosis. Better results are seen in lower grade thin membranous stenosis, and endoscopic treatments are successful in treating re-stenosis following LTR and PCTR, hence avoiding a second open surgery. These are my references. Thank you.
Good morning, everyone. Today, my topic is novel approaches in management of esophageal foreign bodies. I am Dr. Manjunath K, Department of ENT, Head and Neck Surgery. Abstract aims. The purpose of this study is to present our experience of the removal of foreign bodies by novel approaches in children and adults using rigid esophagoscope under general anesthesia. Study design. It was a retrospective study on 40 patients with history of ingested foreign body in the esophagus. Place and duration of the study. Study was done in the Department of ENT over 8 months between March 2019 to October 2019. Introduction. The patients with esophageal foreign bodies require prompt diagnosis and therapy. The first tasks are to determine the types of object and the time since ingestion, the location of the object, and associated complications. Over the past decade, the flexible fiber optic endoscope or esophagoscope has gained great popularity, mainly owing to its safety, and this was the ideal choice for both diagnostic and therapeutic purposes in the management of esophageal foreign bodies with a success rate of over 95% and with minimal complications. However, the rigid endoscope is equally safe and effective in the hands of experienced ENT surgeon. Its advantages include the ability to perform the procedure with a high degree of success in controlled environment. The most commonly used method in our hospital for removal of esophageal foreign bodies is rigid esophagoscopy, which is a novel approach. Its wide lumen is of great help in manipulating and extracting the most foreign bodies and removing it in one setting and without withdrawing the endoscope. The purpose of this study is to present our experience of the removal of esophageal foreign bodies by novel approaches in children and adults using rigid esophagoscope under general anesthesia, the review of pertinent literature. Coming to the methodology, a total of 40 patients with a history of ingested foreign body in the esophagus were admitted and treated in our hospital between March 2019 and October 2019, of whom 30 children and 10 adults. There were 26 male and 14 female patients between 6 months and 60 years of age. All patients except one had a clear history and symptoms of foreign body ingestion. The main symptoms were difficulty in swallowing, acute onset of pain, dysphagia, choking, and excessive salivation, that is drooling. History of ingestion with vomiting, vague sensation of foreign body, and odynophagia were main diagnostic criteria. A lateral neck plane radiograph and posterior anterior view that included the oropharynx, neck, chest, and abdomen were made routinely before esophagoscopic examination. All patients were managed on ENT OPD service, including children who were boarded on the pediatric OPD service under the responsibility of ENT surgeon. The duration of foreign bodies ingestion to the time of endoscopic removal was less than 6 hours of 10 patients, 6 to 10 hours of 20 patients, 24 hours of 25 patients, 1 to 3 days of 4 patients, and in one patient, the duration of impaction was unknown of our 40 patient study. Foreign bodies were most commonly identified in cervical esophagus immediately below the cricopharynx of 24 children. Remaining foreign bodies were as follows: 6, 3 children, 3 were adults. Foreign bodies were lodged in mid esophagus and 10 all were adults in the distal esophagus. All foreign bodies were removed under general anesthesia by novel approach, that is rigid esophagoscope. All impactions were accidental and endoscopic procedures were performed in operating room under general anesthesia. The extraction of foreign bodies was undertaken after a fasting period of at least 5 hours in some patients who underwent procedure immediately following admission. A rigid esophagoscope, that is Karl Storz, to Tlingen, Germany, was used to remove them. For the dilute procedures, more than 10 minutes, we used to manage by giving methylprednisolone to prevent soft tissue edema. Coins were the most common foreign bodies removed from the esophagus, occurring in 24 children. Other foreign bodies were bones mixed with piece of meat, button battery, staples, safety pins, chicken bones, fish bones, toothpicks, medicine tin foil pack, dentures, cotton balls, razor blades were in 10 adults and 6 children. The esophagoscope, the esophagus upper part and mid esophagus was the most common lodgement site of ingested foreign bodies rather than stomach, pharynx, and duodenum. 30 patients were discharged on the day of procedure after 6 to 8 hours of observation. 9 patients were kept for observation for 24 hours. The remaining one was a 60-year-old woman and discharged after 7 days due to mucosal bleeding and erosion. There were no deaths, no perforations, no cases of mediastinitis, and actually no complications secondary to insertion of esophagoscope and removal of foreign body. Rigid esophagoscopy remains as safe method of esophageal foreign body removal. The timely diagnosis and endoscopic removal should be performed to prevent serious life-threatening complications. Follow-up is available in the majority of our patients within a period of 6 months to 3 years. There were no complications. These are our results. Foreign body coin in the chest X-ray radiograph in the cricopharynx, and in another one is a fish bone in the oropharynx. These are the table which foreign bodies we got to remove. Coming to the discussion, retention leads to perforation, which is only a matter of time. Therefore, all foreign bodies retained in the esophagus should be removed as soon as diagnosed. Other alternative methods for removal of foreign bodies have been described in the literature, such as dislodgement of a Polish catheter, advancement with bougie, papain or carbonated fluid treatment, glucagon therapy, balloon extraction during fluoroscopy, removal using magnets. Besides history and physical examination, radiological examination is very important diagnostic tool to identify the foreign body in its location. First anterior lateral cervical and chest radiographs are basic radiological methods of foreign body identification. Sharp esophageal foreign bodies like needles, pins, and hair clips can perforate the esophagus and lead to pneumomediastinum, and they must be removed under emergency setup. Smooth objects like coin may become sagittally oriented and can encroach on the trachea, causing biphasic trigger and also an emergency removal. Patients who are symptomatic often complain of pain, difficulty breathing or swallowing, agitated should undergo immediate removal. Esophageal button batteries, although similar in shape and size to coins, require emergency endoscopic removal in all cases. An impacted button battery may cause mucosal injury as in little as 4 hours. Injury can extend transmurally within 6 hours, creating the potential for perforation and possible fatal outcome. So when removing sharp or pointed foreign bodies, Chevalier-Jackson's axiom should be adhered to: advancing object puncture, trailing object do not. The endoscopic protector hood reportedly permits easy and safe removal of sharp or pointed foreign bodies. However, the foreign bodies must be moved to the stomach to flip the protector's hood back to its original shape for withdrawal through the lower esophageal sphincter. In our study, endoscopic protector has not been used. So coming to the conclusion, rigid esophagoscopy remains an easy and safe method for esophageal foreign body removal in trained ENT surgeons. In symptomatic patients, timely diagnosis and endoscopic removal should be performed to prevent serious life-threatening complications, as was done in our study. Based on our experience, skills, and that of other authors, ENT surgeons in trained should be taught rigid endoscopy, which is novel approach in our field. So coming to the keywords, esophagoscopy, foreign body. So these are my reference. Thank you.
Good day, respected judges, my friends, and my colleague. Myself, Dr. Meena Kale, going to present the inter-rater study of reliability of stroboscopic evaluation variables (SEV) in benign vocal fold lesion. As we know, stroboscopy is a fruitful means to investigate human phonation. It depicts the images of the vocal fold during phonation and the different phases of the cycles of vocal fold vibration. It reveals the small structural changes which may impair the normal functioning of the vocal fold, which helps in the accuracy in the diagnosis. Total 17 SEV out of 15 SEV are the time interval score parameter and 2 are the numerical score parameter. Stroboscopy gives accurate interpretation of many variables, but each and every material is having their own merits and demerits. The same way stroboscopy gives some uninterpreted complex images, which needs to be adequately quantified for the clarification. As we are studying the different raters observation, hence the different raters might differ from each other with respect to their evaluation and their observation and features of variable. So this deviation play a very different role in the further processing and the management. What is the reliability of variable? It is the extent to which different raters judge the same stroboscopy video. SEV can only be valid for the management if it is reliable. The aims and objective of our study to study the inter-rater reliability of SEV and their validation for the management of glottic lesion, and to register the SEV systematically, which are important for the voice production. Also to apply SEV for perioperative assessment. This is our stroboscopic performer, which we have studied since 2 years from March 20 to 2022. This in a single tertiary care center. We have studied in 55 patients. Thus, 15 SEV were evaluated and compared separately and independently by 2 laryngology experts. Out of this 15 SEV, we are going to study. Those are the time interval score parameter like vocal fold age, vocal fold mobility, amplitude, mucosal wave, etc. And 2 other numerical score parameter. We have done the open discussion for the familiarizing the expert with SEV. And finally, integrated reliability was compared and analyzed. In method, we have used Olympus stroboscope, which is a 70-degree rigid laryngoscope with the Panasonic camera and the computer-based database system. The stroboscopic requirements were there, which gives the good illumination of the glottis and the good image. The visibility of whole length of the vocal fold should be there, and to allow for the registration of a sustained phonation. At least one cycle of vibration should be completed. Patients were included those who are having the voice change with diagnosis as a vocal fold lesion, like vocal fold polyp, vocal fold cyst, vocal fold palsy, etc. Any age group were included. We had mostly 14 to 17 years of either sex. Patients with malignant glottic lesion were excluded. In result, we have used the standard statistic, that is the mean and standard deviation applied for both the expert and both all the SAV with the help of coefficient variation and the coefficient of courtesy, which has applied to all SAV. To enable a better comparison and their reliability, p-values were calculated by means of student t-test. And finally, an estimate average values of all SAV were considered for their reliability. In result, as you know that when comparison, whatever you and me will see are not the same. So we have calculated the p-value. So we are going to see the 15 SCV. Out of that, vocal fold age is the first SCV, which shows the p-value is less than 0.05, which is a significant. That means there is a significant difference between the two experts' observation for the vocal fold age. For the vocal fold mobility, p-value is more than 0.05. That is, there is not significant difference between the two experts for the vocal fold mobility observation. In the same way, amplitude and mucosal wave, the p-values are more than 0.05, which are the non-significant. For the glottic configuration and phase symmetry, p-value is not significant. For phase closure, p-value is 0.001, which is highly significant. There is highly difference between the two experts. And for the vertical level, p-value is equal to or less than 0.05, which is a significant. There is a significant difference between the two experts' observation for the vertical level. For non-vibrating area, p-value is less than 0.01, which is more significant. And for regulatory in vibratory cycle, p-value is not significant. Arytenoid symmetry, arytenoid mobility, p-value is not significant. For the ventricles, proglottic valve activity, p-value is not significant. And finally, for the piriform fossa sinus, the p-value is also not significant. When we have calculated p-value of all SCV, we have found out the reliability. The low reliable variables are the vocal fold age and vertical level. It is maybe because of the presence of the organic lesion, or vertical level is difficult to correlate. And the lowest reliability is for the phase closure and the non-vibrating area. That's the same because of the presence of organic lesion. In discussion, all the ACVs are having their own importance, like vocal fold age. Any deviation in the smoothness and straightness may lead towards the diagnosis of organic lesion. Disruption of the mucosal wave will lead to the change in voice. The extent of vibrating portion may lead to the detection of the glottic cancer. All the SCV except 4 has good reliability. Those 4s are the vocal fold age, phase symmetry, phase closure, vertical level, non-vibrating area are having significant p-value. Those are low reliability. The lowest reliability was seen in phase closure. Hence, the stroboscopy only gives the average movement of the vocal fold by merging the consecutive cycles. But the short-term changes of movement cannot be determined by stroboscopy. For that, it will require the higher evaluation, that is high-speed videography or the microlaryngoscopy. High-speed videography is not easily available and affordable, but it gives detection of real cycle-to-cycle changes, while microscopy gives some SCV evaluation, that is the abnormality of mucosa, arytenoid symmetry, ventricle, piriform sinus, but the demerit is it requires the general anesthesia. Hence, finally, we concluded that the average of evaluation from 2 experts possesses the adequate and the quite good reliability of parameter. The 11 SCVs are having the high reliability gives the more informative value than the low SCV. Those low SCV will require the higher evaluation like high-speed videography and the suspension laryngoscopy. These SCVs, those who are the highly reliable, helps in evaluation for the perioperative assessment. These are my references. Thank you.
Good morning, judges at the dais and my dear colleagues. I am Dr. Yushurin Bose from Kolkata. Voice is one of the most personal attributes of a human being. It makes us identifiable and recognizable. To revisit this entity, let us have an insight into voice acceptance of male to female transgender based on pitch and prosody of speech. Acquiring a sex-appropriate voice is a fundamental part of gaining acceptance as in a new gender. Since time immemorial, since Ishiki described the cricothyroid approximation surgery, which is a simple procedure to approximate the cricoid with the thyroid cartilage, thus aiming at elevating the pitch. We as phonosurgeons have always focused on pitch in case of gender reassignment. But it is not only the pitch which labels the voice as a male or female, but it is the other parameters of speech which constitute the prosody, like the juncture, the intonation, stress, loudness, and timbre quality of voice, which dictates whether the voice is male or female. For example, let us listen to this voice, where this is a
So this is how I sound in the morning,
voice, when you
which is my biggest fear.
And this is a voice where after surgery the pitch has been taken care of, but the you cannot definitely say whether it is a female or a male voice. But when you listen to this conversation,
मेरे को सर्दी होके रखी है नहीं सर्दी एक्चुअली नहीं है मतलब ना मैं सिर्फ गले से बात करने में ना मुझे तकलीफ हो रही है.
So with this intonation, we definitely feel that this is a female voice. With this background, we conducted a study to analyze the prosodic parameters of speech before and after gender reassignment voice surgery in male to female transgenders. Also, we evaluated the patient perception on long-term voice outcome after tension laryngoplasty. And most importantly, we found out whether the prosodic parameter as a whole or isolated pitch is important in defining a gender-specific voice. It was a prospective double-blinded study where 4 samples were provided, 2 vowel samples pre-op and post-op, and 2 speech samples of Bengali dialect, since Bengali dialect does not have a grammatically gender bias. It was conducted in 8 transgender male to female individuals who underwent tensioning laryngoplasty and obtained a voice training for optimization up to 30 months. For data analysis, there were 2 groups of listeners. The first group was 30 educated listeners with normal hearing, and they had to rate the score whether it is feminine or masculine, where -5 was masculine and +5 was feminine. The second group were the more experienced one, the speech language pathologists, who were provided with a questionnaire which was validated by 10 laryngologists. Also, a subjective evaluation was done by the 8 patients on a basis of Likert scale. This is the question which was provided to the SLP, and this invited questions like whether the patient has masculine or feminine voice, how long are the duration of vowels, what is the expression, and other prosodical parameters like stress, pause amidst the sentence, and variation in loudness. The minimum score was 6 and the maximum score was 30. On patient perception of voice, the subjective score, we found that 63% of the patients were happy and 25% of the patients were very happy. When we assessed the vowel samples by the 30 educated listeners, we found that they perceived the post-operative vowel samples as fairly strong, fairly feminine voice, which was statistically significant. When we overall observe this, the preoperative voice sample was said to be masculine by 84% of the educated listeners, and the postoperative voice samples were around 93% feminine by the educated listeners. Most of the postoperative speech samples were strongly feminine, which denotes that speech is very much more reliable with intonation than only vowels, where we can just take care of the pitch, or we can just assess the pitch. In this graph, we have depicted the assessment of the prosodical parameters based on the SLP questionnaire, where in the postoperative period, majority of the SLPs, they perceived the postoperative voice as strongly feminine. The duration of length of the vowel was perceived more or less similar in the pre and postoperative samples. This is acceptable because the duration of length of vowel, it depends on the dialect and language. The expression was rated higher in case of postoperative samples. Among this stress in specific words, it was again rated higher in the postoperative samples, denoting feminine character. Whether there was adequate pause or not, most of the SLPs, they said that the postoperative speech samples had a higher pause. And in terms of loudness, it was more or less similar. This data was statistically significant. In 2012, Purnett and Bellini, they said that not only pitch predicts gender, but gender can be predicted by timbre alone, which was seconded by Titz and Rendall et al. There was a last meta-analysis by Leung et al., which said that pitch contributes to only 41.6% of the gender identification. In our study, we obtained that long-term post-op voice was perceived as strongly feminine by common listeners with high patient satisfaction score, which denotes that the patient is very well socially accepted. Not the least, there was tremendous amount of statistically significant transformation of prosody towards the femininity with tension laryngoplasty and voice therapy. Our study, however, is unique in terms of detailed analysis of each of the prosodical parameters and the change in the prosodical parameters after a pitch raising voice surgery, which has not been done in the past. Thus, to conclude, there is a distinct shift of prosodical parameters to the feminine nature after pitch raising surgery, and with majority of our patients very happy with the newly obtained voice. Last but not the least, the prosodical parameters of speech dictate the feminine character of male to female transgender reassigned voice surgery much beyond a simple elevation of pitch. Thus, I would like to say that speech and gender identifiable voice is not only pitch but way beyond that, and this knowledge can be used to train for vocal training in case of transgender individuals when we are working in future. And there's also a scope of future research which is aimed at developing a valid standardized audio perceptual scale of rating the gender. So these are some of my references. So let us create that one voice at the right pitch and the right prosody so that it is identifiable by all. Thank you.
Wishes to all. I am sharing our experience in the management of post-intubation tracheal stenosis, which is one of the less common but more challenging condition in ENT. This is a case series of 13 patients who were diagnosed to have post-intubation cervical tracheal stenosis over a period of 6 years. The average age of our patients was around 30 years. 11 of our patients were males and 2 were females. The average number of days of intubation was around 9 days. And the most common cause for intubation was OPC poisoning. 9 of our patients were found to have tracheal stenosis on evaluating for stoma closure. 4 presented with stridor after tracheostomy closure. 3 of our patients were having comorbidities like hemiplegia, obesity, and hypothyroidism. To begin the evaluation, X-ray soft tissue neck lateral view and CT neck were done in all our patients to assess the site of the stenosis and the length of the stenotic segment. It was followed by fibroptic bronchoscopy, and on the basis of fibroptic bronchoscopy, the stenosis were typed into granulation type or cicatricial type. Cicatricial type were further classified into circumferential single stenosis or circumferential cicatricial multiple stenosis. On the basis of Meyer-Cotton grading system, 9 of our patients were having grade 3 stenosis, 3 were having grade 2, and 1 was having grade 1 stenosis. Then the treatment modality will be decided by the type of lesion. First, in one of our patients who was having granulation type of stenosis, we proceeded with endoscopic excision. In other patients with the cicatricial stenosis, we decided to go for resection and anastomosis or dilatation and stenting. This will be decided based upon the operability of the patient. In elderly patients with a lot of comorbidities and those patients with re-stenosis after surgery, endoscopic coblation assisted dilatation and stenting was done. In young patients without comorbidities, surgical resection was done. In the group of patients who were planned for dilatation and stenting, the approach was decided based upon the length of the stenosis. In those who were having short segment stenosis, an endoscopic coblation assisted dilatation followed by Montgomery tube fixation was done. This is the post-operative picture showing the Montgomery tube in situ. In those patients who were having a long segment stenosis, an external approach was planned and a suprastromal tracheotomy was done. And through this, the fibrous tissue in the lumen were excised and Montgomery tube was fixed. And in the other group where resection and anastomosis was planned, the first decision what we have to take is whether we are going to include the stoma or not. This will be decided based upon the distance between the stenotic segment and the stoma. That must be more than 2 centimeters to preserve the stoma site. All these patients were done under general anesthesia through an entry tube that was inserted through the pre-existing stoma. A midline vertical incision was made below the stoma, and a low tracheotomy was done, and the endotracheal tube was inserted through that and fixed over the chest. A horizontal neck collar incision was made at the level of stoma, and subplatysmal flaps were elevated. Thyroid isthmosotomy was done, and thyroid lobes were dissected off the trachea, and it was completely skeletonized. Then a tracheoesophageal separation was done. Then the stenosis segment was resected by making a cut at the superior and inferior ends. The resection is continued along the posterior wall of the trachea. This is after completing the resection of the stenosis segment. At this juncture, we have to decide whether we are going to do a release procedure or not. This is based upon the length of the stenotic segment that we have excised. If it is more than 2.5 centimeters, always we used to go for a suprahead or infrahead release procedure. Then we used to do a relaxation suture between the cricoid cartilage and the periosteum of the medial end of the clavicle to bring closer the cut ends of the trachea. In the posterior wall of the trachea is sutured. Here the suturing of the posterior wall is completed. Now the endotracheal tube is transferred from the tracheotomy site to the nose, and nasotracheal intubation was done. Over the endotracheal tube, the anterior wall of trachea will be closed from the lateral to the midline. Now the anterior wall is completely sutured. After completing the anastomosis, we have to check for any anastomotic leak. If it is there, we have to repair it, and we have to confirm that there is no leak. After confirming that there is no leak, we have to close the wound in layers, and Grullo stitch will be applied between the chin and the chest. This is the resected segment in one of our patients. In the post-operative period, all the patients were shifted to the ICU and extubated after 24 hours. Orals will be started on the 10th post-operative day. Grullo stitch will be removed on the 21st day. X-ray sternal and bronchoscopy will be done on the 21st and 60th post-operative days, and if necessary in between if the patient develop any symptoms. These are some of the X-ray sternal and bronchoscopic picture of patients with a good lumen after surgery. The tracheal lumen is good. This is in another patient. Coming to the results. The average length of the resected segment in our patients was around 2.5 centimeters, and the number of tracheal rings was around 4. We have an anastomotic success rate of around 70%. That is, 7 of our patients were successfully decannulated, and else of the patients having restenosis were underwent endoscopic dilatation and stenting. And trial stent removal were done after 6 months. 1 of our patients was successfully decannulated. 2 are remaining with the Montgomery tube. In overall 13 patients, we have decannulated successfully 9 patients. That is 69% of our patients. 4 are remaining with the stent. These are some of the complications in our patients, among which common is the granulations and restenosis. Coming to the discussion, Careful preoperative evaluation is more important for taking the decision regarding the treatment. A tracheal stenting can be preferred in poor candidates for surgery. Resection and anastomosis remains the definitive treatment with a high success rate of around 71 to 95%. In our series, it is 70%. This is a large series with a huge number of samples by Grillo et al. 279 patients with post-intubation tracheal stenosis were operated, and it has got a high success rate of around 83%. Before going for discussing the causes for or factors causing successful anastomosis, we have to insist more on the causes for failed anastomosis. This is in one of our patients who was having an extensive granulation as the anastomotic site after 21st day of surgery. But the patient refused to go for further procedures since he was asymptomatic at that time. And after 73 days, he landed up with stridor with a grade 3 stenosis. Here we have to learn that always we have to insist the patient before the surgery itself that they may need 3 or 4 procedures after the surgery. And they must be prepared for that. This is the number 2 case where the surgery was done on the 4th day after the emergency tracheostomy. But when the trachea was opened, we were able to see an unhealthy mucosa in the posterior wall of the trachea, where we had difficulty in going for anastomosis. So in this, we have learned 2 things. One is we have to delay the procedure after any procedure like tracheostomy to make for the tracheal mucosa to become healthy. And also the second thing is before surgery, always we have to do an endoscopic examination through the stoma and confirm that the mucosa is healthy. These are some of the factors which are important for successful anastomosis, like patient selection, timing of surgery, tension-free anastomosis, maintaining the vascularity of the trachea, and a good post-operative follow-up. With our experience, we have included an important thing in our protocol, that is endoscopy through the stoma. We have to examine the suprastomal lumen, intrastomal lumen, and we have to confirm that the mucosa is healthy before going for surgery. To conclude, always individualize the treatment, prepare the surgical steps, and modify the steps if necessary. With this experience, we can make the speechless to speak, let the lungs to get a cool air. These are some of the smiling faces. And this is our surgical team. These are my references. Thank you.
Hello everyone. The topic for my presentation today is aggressive recurrent respiratory papillomatosis, risk factors and strategies for management. It is a rare disease caused by low-risk human papillomavirus HPV type and 6 are associated with respiratory illness. Incidence of juvenile onset RRP is 0.17 per 1 lakh per year and adult onset RRP is 0.54 per 1 lakh per year. Although it is a rare condition, frequent recurrences and multiple surgical treatments potentially lead to devastating and costly to patients, families, societies in general. This highlights its surgical relevance. It has a recurrent and unpredictable character. There is no definitive curative management, but debulking of the papilloma to secure a stable airway while preserving underlying laryngeal tissues is the current standard choice of management. We conducted a small study over a population of 11 such patients. The aims and objectives were to study the epidemiology and risk factors for aggressiveness of RRP cases and to analyze the advantages of multimodality techniques and adjuvant medical approaches in the treatment of respiratory papillomatosis. It was a descriptive study with retrospective data over a period of 6 years, included the population of age 2 years to 65 years. The patients proven histologically with respiratory papillomatosis were included in our study. Here I am sharing with you the observation and results. 36% of the patients were female and 64% were male. 4 of the 11 were of juvenile RRP, while 7 were adult onset RRP. The 10% of the patients were born by LSCS route, while 90% were born by vaginal route, and 5 of these vaginal route were first-born children. So this signifies the triad of that it is more prevalent in first-born babies born through vaginal deliveries in young females. HPV 6 were 4%, while HPV-11 were HPV-6 were 40%, while HPV-11 were 60%. The HPV-6 patients underwent on an average 6.5 surgical procedures, while HPV-11 underwent 12 surgical procedures. So this signifies more aggressive nature of HPV-11 as compared to HPV-6. 7 patients required tracheostomy, and out of these 7, 1 had tracheal involvement. So tracheostomy should be the last resort because it provides another area for rapid colonization of HPV virus, and also it leads to conduit of spread of disease to tracheobronchial tree. So this should probably be avoided. Rather, patient can be taken for emergency endoscopic debridement of the lesion, papilloma lesion. 50% patients were given adjuvant medical management and 50% were treated with only multimodality management. This is the graph showing pre and post Durkee's total score. Patients of Durkee's score after multimodality or multimodality plus medical adjuvant management showed significant decline in the post-Durkee score. This is statistically significant. And once we compare the remission period between single and multimodalities, we saw that the remission period of single modality is significantly very less as compared to the remission period of multimodality. So this suggests that multimodality and adjuvant medical management helps in prolonging the disease-free intervals, and hence it reduces the tumor burden. Let's have a quick discussion about RRP. RRP presents as a progressive hoarseness and airway obstruction. A deficient host immune system inability to produce an effective HPV-specific T-cell response is responsible for RRP. Often there is delay in diagnosing RRP. Many patients are initially assumed to have a more common respiratory problem such as croup, asthma, bronchitis. It has got a variable course that certain percentage of people show aggressive illness requiring frequent debridements, while certain people show progressive and sometimes spontaneous remission. Overall, it is a challenge to treat because there is high recurrence rate, risk of local airway involvement, and significant reduction in quality of life. So current standard for management is we do debulking of goals of the treatment. We do measured rather than aggressive debulking via microscopic or endoscopic rigid laryngoscopy. And we have to maintain a stable balance between securing a stable airway to increase the length of time between operations, minimizing the recurrence, and to preserve the underlying laryngeal tissues and to preserve the adequate voice quality. Surgical options are laser, microdebrider, and cold steel. Cold steel was used in older ages, but it has got an advantage that it has lowest risk for scar formation, so preferred in the lesions at anterior commissure. Microdebrider is gaining quick popularity these days, and there is quick debulking, improved voice quality because residual laryngeal tissue has got less damage, less mucosal injury. It is cost benefit and better for trachea and subglottis. Laser also has got precision and minimal bleeding, but has got disadvantages of laser fire, misfire, laser plumes. RRP is a viral condition, so it is logical to think that treatment should be medical. So following are different treatment methods. HPV vaccine, it could be used as prevention as well as a treatment. It can be given for general population over a period of 9 to 45 years. Children who get vaccine before 14 years, 9 to 14 years, should be given 2 doses 6 months apart, while patients people above 15 years of age and who are immunocompromised should be given 3 doses of vaccines. It also can be used as treatment, provided the hypothesis behind it that vaccine-mediated humoral response inhibits the latent HPV infection near or within the surgical site and decreases the risk and rate of recurrence. US Census data has shown that post-vaccination era, there is significant decline in incidence of RRP over a period of time. Cidofovir is an antiviral drug that inhibits viral DNA polymerase, and it is promising as an adjuvant agent. And intralesional therapy shows partial to complete regression of papilloma and decrease in the frequency of debulking surgeries. It should be administered systemic when there is lung involvement. It has got severe side effects as malignant transformation and nephrotoxicity. Bevacizumab is a monoclonal antibody. It is a targeted therapy, prevents interaction of vascular endothelial growth factor with receptors. Decreased disease severity and improvement in voice-related quality outcomes of life are seen. But pseudofovir and bevacizumab are quite costly and difficult to access in developing countries. Interferon, indole-3, carbinol, heat shock protein, mumps vaccine, and anti-reflux are also other management options for RRP. Interferon is not used by children, the pediatricians, as it has got serious side effects like neurological disorders, leukopenia, thrombocytopenia. In conclusion, HPV is associated with aggressive course of the disease. Multimodality approaches have definite advantages over single modalities in terms of increased emission and reduced Durkee score at the time of subsequent requirement. Adjuvant medical therapy further helps in reducing disease burden. HPV vaccination is a new and feasible way of controlling RRP. We had 3 patients cured out of 11 when we treated them with multimodality and medical management. Thank you.
Good morning, everyone. I'm Dr. Priyanshi Gupta, and I'm presenting my paper in the category of Rising Stars. My topic is microlaryngeal interarytenoid muscle sectioning, which is a new surgical approach to the management of bilateral vocal fold paralysis. Benninger estimated that bilateral vocal fold paralysis has maximum contribution from surgical trauma, which is approximately 44%, and the rest, like malignancies, endotracheal intubation, neurologic causes, and idiopathic, holds roughly about equal contribution. We know that bilateral injury to recurrent laryngeal nerve is the underlying cause, which causes airway obstruction. So the severity of dyspnea then depends upon the position of the vocal folds. After paralysis, it depends upon the laryngeal nerve injury, cricothyroid muscle function, fibrosis of the denervated muscle structures, the degree of ankylosis in the joint, and anastomosis of various neural branches. So the functional treatment was historically introduced in 1922 by Sheller Jackson, who described ventriculocordectomy, in which we remove the ventricle and the cord. This led to the breathy voice, however, the airway was excellent. Since then, a lot of surgeries have been developed, such as external techniques like arytenoidopexy, arytenoidectomy, or endoscopic techniques, including arytenoidectomy combined with electrocoagulation or submucous cordectomy. There is excision of vocalis muscle, which could be achieved via laser posterior cordectomy or cordotomy. Each of these procedures has its own merits and demerits. So true paralysis is a misconception because it has complex neural network. The term synkinesis is more appropriate, which means the abnormal laryngeal innervation, which may occur following injury to the recurrent laryngeal nerve. This is primary cause of intrinsic laryngeal muscular tonus rather than muscular atony after nerve injury. So the principle of posterior glottoplasty was initially introduced by Ismail Denizoglu and Enzin Bazer from Turkey in 2020. In this, they alter the laryngeal muscular vectors which are affecting the body of arytenoid for a better laryngeal functioning. We keep in mind that synkinesis and collateral reinnervation affect post-paralysis laryngeal posture, the bodies, and reposition by decreasing the adductor muscular tonus of the interarytenoid muscle. The procedure is simply the sectioning of interarytenoid muscle, in which case that the vector of IA muscle is gone and then the abductor vector of the PCA muscle remains. So this is how we do it. In this, the interarytenoid muscle is seen, and in this, we are cutting the interarytenoid muscle till the cricoid cartilage is visible. This diagram is just showing the area where we will be operating, which is the interarytenoid area. The fundamental vision is to preserve phonation and to obtain a sufficient airway. And in this paper, we describe the technique and we try to perform bilateral vocal fold paralysis to optimize phonation and achieve a good respiratory function. We took 4 patients, 3 females and 1 male. Of the 4, 2 female and 1 male had developed bilateral vocal fold paralysis following total thyroidectomy, and 1 was idiopathic. All of them underwent posterior glottoplasty between 2020 and 2021. Preoperatively, we did a thorough ENT examination, endolaryngeal examination, and laryngeal EMG to confirm that there is paralysis of the vocal cords. So suspension laryngoscopy was done under general anesthesia. Intubation was done with number 5 spiral endotracheal tube, which was retracted anteriorly to gain access to the interarytenoid region. We then cut the muscle until the cricoid cartilage is visible. Then we check the mobility of cricoarytenoid joint, and if it is found immobile, the mobility is achieved. Then the incision line is horizontally sutured with Vicryl 80. So post-operatively, initial 6 hours are very crucial to look for respiratory distress, and we kept as precaution intubation and tracheostomy trolley ready. All of them were put on steroids, antibiotics, anti-inflammatory, hydration, and voice rest for 1 week. Then we did a weekly laryngeal examination to look for post-operative outcomes and certain complications. Pre-operative and post-operative evaluation was done on the basis of aspiration swallowing using Pearson scale, respiration, subjective evaluation was done using exercise tolerance test, and objective evaluation was done using pulmonary function test. Phonation, we used voice handicap index. So this is the voice handicap index questionnaire that we had used. We asked the patients certain questions, and on the basis of severity, they were asked to grade from 0 to 4. Then a total cumulative score was calculated, ranging on that mild, moderate, and severe disease was asserted. Our results were such that the 4 cases, mean age was about 42 years. They had mean duration of dyspnea of 45.4 months, and they were all followed up for 12 months. All of them had post-operative interarytenoid edema, which gradually resolved in 2 or 3 weeks. So our results, aspiration swallowing, none of our patients complained. On the basis of respiration subjective outcome, 2 had very good response and 2 had good response. On phonation, we had been calculated the pre and post-operative VHI values. Our p-value was statistically significant. Laryngeal examination showed that all had improved glottic space. So this is the pre-operative and the post-operative post-glottic area space, so we can see. Now, surgical treatment is a challenge as numerous factors are involved in the final outcome. Extralaryngeal framework procedures had manipulation difficulties, which gave then advances to the endolaryngeal approaches. In endolaryngeal approaches, a laser chordectomy or chordotomy, which is quick, easy, and has lower complications, but also has propensity to form granulation tissue and fibrosis, necessitating revision surgeries or aggressive management in future. So through this mechanism of posterior glottoplasty, we may be differentiated from passive mass elimination effect, which is provided by arytenoidectomy, and thus may be regarded as active or functional intervention. The adductive synkinesis effect of our lateral cricoarytenoid and thyroarytenoid muscles on vocal process remains, so the phonatory contribution of the membranous glottis is less affected. These are the muscle vectors. The first is the PCA muscle, in which the abduction is happening of the vocal cords in membranous and the cartilaginous part. In this, the LCA muscle is involving the membranous part and the IA muscle is involving the cartilaginous part. Finally, we know that there can be a scope for spontaneous recovery of neuronal tissue. So our technique should be one which has minimal morbidity and preserves the anatomical and physiological features of larynx. And in posterior glottoplasty, it aims to do all of that along with maintaining the integrity of cricoarytenoid joint. The limitation of my paper is that there is a small sample size of 4. We have a limited follow-up of 12 months, and we did not do a detailed acoustic analysis, including fundamental frequency, jitter, shimmer, and harmonic to noise ratios. Finally, interarytenoid muscle sectioning is an endolaryngeal minimally invasive technique with fewer complications, which preserves the phonation and allows improved airway by redirecting the synkinetic muscle vectors. Also, it prevents granuloma formation, necessitating revision procedures, and it enables spontaneous recovery of neuronal tissue because it preserves the integrity of cricoarytenoid joints. Thank you.
Hello, I'm Dr. Raghavi, and I'm going to be presenting on false buccal fold adduction, the harsh truth. The term muscle tension dysphonia was coined by Morrison way back in 1983. It is defined as an increase in tension of the intrinsic and extrinsic muscles of the larynx that result in a pathological disturbance of the voice. My aims are to study the commonest type of muscle tension dysphonia and to study the ventricular band dysphonia in terms of demographic parameters and endoscopic findings. This is a retrospective descriptive study over a period of 5 years, including all the patients who presented to us with muscle tension dysphonia. Commonest type of muscle tension dysphonia was identified using Kaufman's classification and analyzed in terms of demographic data and endoscopic findings. This is Kaufman's classification. Type 1, open posterior commissure, laryngeal isometric. Type 2, false vocal cord approximation or ventricular band adduction. Type 3, partial anteroposterior collapse. And type 4, complete supraglottic closure or sphincteric larynx. In our study, there were a total of 1,022 patients. 405 were type 1, 550 were type 2, 63 were type 3, and 4 were type 4. Clearly, more than 50% of all the muscle tension dysphonia patients were type 2. So we studied type 2, the ventricular band approximation, in detail. Criteria for the same included obliteration of more than 50% of the width of the true vocal fold and sustained adduction during phonation, not just at the start alone, similar to what that is seen in this video. There are two types. The primary, where there is an overactivity of the false vocal fold, that is, there is no underlying pathology in the true vocal fold, and secondary, where there is an underactivity of the true vocal fold, that is, there is an underlying true vocal cord pathology. Of our 550 cases, 91 were primary and all other 459 had some associated pathology, that is secondary. This is a disease of the middle age with no one less than the age of 25 years in our study. Age distribution in both primary and secondary were similar to the overall numbers. A significant male majority was present in the study, as 422 out of 550 were males. Clinical and statistical significantly male predominance was present in both primary and secondary, with a percentage exceeding a whopping 85% in the primary type. There wasn't a significant number of professional voice users. Only 26 of 91 were professional voice users. A point to be noted is that this is the only muscle tension dysphonia that can present unilaterally. So while analyzing the laterality, we found clinically significant left predominance. 44 out of 91 of the primarily presented on the left side. This was even more than the bilateral presentation, as you can see. These are the primary ventricular band dysphonia videos. In the first video, you can see a unilateral left ventricular band dysphonia. Only sustained ventricular band adduction during phonation is taken into consideration. In the second one, there is a unilateral right ventricular band dysphonia. You can notice that there isn't any underlying true vocal cord pathology in this case as well. This third video shows us bilateral primary ventricular band dysphonia. If you observe closely, you can see the mucosal waves in the ventricular bands, which are also vibrating in this video. In the secondary, though the overall unilateral was more frequent presentation, unlike the primary, the bilateral was more than the left side. But talking about laterality would be better with respect to specific pathologies. The most common associated pathology was sulcus vocalis. 141 out of 459 patients had sulcus. This was followed by unilateral vocal fold immobility in 78 patients. The silver shows unilateral and the brown bilateral. This is a case of bilateral VBD with sulcus vocalis, which you can notice during the time of abduction. In sulcus and presbyphonia, bilateral is more significant, more common. This is a video of right vocal cord cyst. It is more common to see unilateral ventricular band adduction on the opposite side of the cyst. Unilateral presentation is more common in unilateral vocal fold immobility, cyst in nodules. You can clearly see a right vocal cord polyp with left ventricular band adduction here. Belowski in a paper says muscle tension dysphonia is a common phenomena in patients with glottal insufficiency, probably due to the larynx trying to compensate and close the gap. This is a video of right vocal cord growth with ventricular band adduction. Unilateral vocal fold immobility, mostly presented with unilateral ventricular band adduction opposite the side of the lesion, similar to this video. This was previously considered to be diagnostic. But in our presentation and Derurkar paper on unilateral vocal fold immobility and ventricular adduction, even though opposite side VBD was the commonest Same side and bilateral were also present in small numbers. Here there is a restricted abduction of the left vocal cord with same side unilateral ventricular band adduction. And in this video, there is bilateral ventricular adduction with left vocal cord paresis, as you can see now. So the previous concept of VBD, always opposite the side of palsy, is now revised. Sir Markin in 1860 for the first time observed this as a pathological phenomena. It is one of the first clinical descriptions after the introduction of laryngoscope. Jackson in his landmark paper in 1935 named it as dysphonia plica ventricularis. As per these papers, prevalence is 4 to 6% in general population. This is that common. Previously, this was considered as a functional disorder, and since functional disorders were way commoner in women, this condition was thought to be more common in women. Our study and Belawski's study, among others, proves that's not the case. These are the papers I had described previously, Peter Belawski's and Nupur Leruska's paper. Conclusion. Ventricular band dysphonia is the most common type of muscle tension dysphonia. Males are predominantly affected. This is the only muscle tension dysphonia that can present unilaterally. Here we had a significant left preponderance, but the reason was unknown. Primary ventricular band dysphonia was a minority and it was associated with left predominance. The majority of the cases manifested secondary to another condition, the most prevalent of which was sulcus vocalis. Secondary VBD mostly presented bilaterally. However, in unilateral vocal fold immobility, unilateral VBD presentation most likely to occur on the opposite side of the lesion. Same side and bilateral are also present, albeit in fewer numbers. Before I finish my presentation, this is the harsh voice of the false vocal folds used voluntarily for two-one singing. These are my references. Thank you.
Thank you to all the budding stars for their participation. Up next, we have a series of talks on airway disorders and approaches by eminent faculty who are experts in the field. Delegates are requested to post their questions in the chat box for clarification, which will be addressed via email to them individually.
Good afternoon, ladies and gentlemen. Thank you very much to the organizing team of PHONOCON 2022 for giving this opportunity to present this talk before you. I bring you greetings from Guwahati, which was known as Pragjyotispura, the city of the Eastern Light. I shall be talking on challenges and pitfalls in airway assessment. When we talk about pitfalls and challenges in airway assessment, it could be at different levels during history taking, during inspection, during examination, endoscopic assessment, as well as during investigations. Stern and Cotton statement that any pathological sound in an infant needs immediate attention and it should be carefully evaluated. During the assessment of the presenting symptoms, we look at the rate of respiration, the workup reading, stridor, whether it's inspiratory, expiratory, or biphasic. We try to differentiate starter, stridor, and the wheeze. This diagram from Professor Minier's book is very good. In fact, it shows you basically that this blue area is the area for the starter, this is the area for stridor, and this is the area from which wheeze can occur, but there could be a substantial overlap in all of these. So whatever be the presenting sound, if the child is in a crisis, we need to immediately establish an airway. We need to stabilize the child, or if the child is more or less stable, we try to assess the site and cause and go about with the treatment part. Professor Monier's comment that once the degree of respiratory difficulty stress has been evaluated, proper management must be applied before the child becomes exhausted is very important. This is a famous mnemonic of L.D. Hollinger. SPECS, S is for the severity, P is for the progression of disease, E is for eating difficulties, C is for cyanosis, and S is for sleep disturbance. So when we grade the respiratory obstruction, it could be 1, 2, or 3. Grade 1 is noisy breathing with mild to moderate dyspnea and chest retractions, no anxiety and restlessness in the child, normal intake of food and drink, and interest in playing. Grade 2 would be a child with severe dyspnea, chest restrictions, there is anxiety and restlessness, refusal of food and drink, and there is no interest in playing. And grade 3 is the exhausted child with decreased stridor and intercostal muscle retraction, slowing down of the respiratory rate and heart rate, ash gray color, perspiration, and spells of somnolence. Well, this is a child in grade 1 with difficulty. You can see it's noisy breathing, but there's not much of distress. Then this is a child in grade 2. You can see there's enjoyment of the muscles. Then this is another one. And this is another child in grade 3 respiratory difficulty. And this is a child who is actually gradually losing the fight. You can see the strain of the muscles, but the child has become listless. We should assess the laryngeal functions, and in assessing the laryngeal functions during inspection, by looking at the cry, by hearing the cry rather, we can get a gross idea about the laryngeal problem that might exist. During physical examination, these are 5 points which should be always borne in mind that children are often agitated by the presence of strangers, and agitation will make the respiratory distress worse. So physical examination of the distressed child should be limited to the essentials. One should not just go about and take the child from the mother's lap and put it on the bed. And we should always look before touching. We can get a lot of information by just observing the child. Let us come to radiology. Well, X-rays, CT scans can give us a lot of information when you have a foreign body, a radiopaque foreign body. If it is not a radiopaque foreign body, virtual bronchoscopy can also be very useful for different masses, and one atresia, CT scan is useful for knowing about the chest conditions, but sometimes they can confuse you. Like this child that I showed you with a grade 1 respiratory difficulty, he had gone to some doctor, a CT scan was done, and it showed that the thymus was pushing the trachea to one side, and it was thought by the doctor that it is a thymus which is causing this problem, and he was advised to go to a cardiothoracic surgeon for surgery. They came to us, and when we did a TNFL, we found that the adenoids were quite hypertrophied. A simple adenoidectomy actually cured the child. This is about 5-7 years back, and the child had no problems after that. Similarly, this is a patient who had history of intubation following head injury, had respiratory difficulty, and was ultimately tracheostomized. This is tracheostomy in position. CT scan was done, and it commented as complete glottic and subglottic stenosis, and was referred to us. But when we did an endoscopy, we found that it was intubation granuloma. This is in the surgery, actually, this video. But I'll show you just a little of it. You can see the huge arytenoid granuloma starting here, extending into the subglotti, which is a small web which is inconsequential. So these are sometimes situations where you have to not only use your clinical acumen, your endoscopic findings to correlate with whatever the CT scan, etc. might tell you. Endoscopic examination could be done by rigid scopes, by using the telescope, the MLS system, and by the flexible scope. It is not that one is better than the other. All of them have their good and bad points. It could be sometimes a combination of examinations that you might need to do to get a proper clinical diagnosis. Of course, flexible scopes are less traumatic and easier to perform than rigid scopes. But flexible scopes are costly, very delicate. Usually it's better to be a single user. Your technician should be a person who's sincere about maintaining the scope, because once you lose fibers, your scope is gone. And sterilization and maintenance is very important. This is a picture of a TNFL where you put in the scope and you see an obvious pathology. But there would be a tendency to stop there itself. Please don't do that. One should go ahead and go along the whole length of the tracheobronchial tree and come on, because there could be some other pathology also lower down in the neck, in the airway. We use a lot of different concentrations of xylocaine nowadays, 10%, 2%, 4% and whatnot. So one should be aware about the toxicity levels. Your juniors and assistants should be advised to use xylocaine with caution. Suspension microlaryngoscopy is very important when you are trying to differentiate a bilateral abductor palsy from a posterior-glottic stenosis, to know about epicarotenoid joint fixation and about laryngeal clefts. Sometimes when you have done an examination under anesthesia, during the reversal, it might be very useful to ask the anesthetist to give you a little bit of time. It's just a question of a few seconds. When he takes out the tube, you go in with a telescope and you come out, only taking care that you don't injure the mucosa, do not cause an unnecessary injury, unnecessary bleed, and unnecessary respiratory spasm in the child. Retrograde telescopy, especially tracheoscopy, especially in a patient who has been put up for LTS, very important to know the condition of the mucosa. We can do it with a 70-degree scope or a flexible scope. So in an airway center, we not only need equipments, a lot of them in fact, but we need a dedicated team not only of doctors and nurses, but also of technicians who would be tuned to your needs and wants, so that we have a good airway team in place, and then we can work much more comfortably. Recording and reviewing your video is very important. Sometimes during a quick examination, you might miss something which you can review and detect something else. Also, when you record it and keep it with you, you can share it with your friends and seniors to have opinions on a difficult case. Always remember to get the best recording equipment and the best lighting and camera that you can afford, because doing with compromised lighting and compromised camera will actually not solve your problems. When you're doing an examination under anesthesia, this is the table setup we usually use. Please do not forget the tracheostomy trolley, which is very important. You never know when you'll need it. When you're talking about anesthesia, this is from Dr. Sandhu's deliberations actually. In cases of foreign body bronchus, if the child is adequately fasting and stable, you can do a weight and planned removal. If the child is adequately fasting but unstable with respiratory difficulty, we need urgent action. Inadequate fasting, we can stabilize the child, but if it is unstable with respiratory difficulty, we need again urgent action. So, laryngomalacia, Dr. Soumitra, I think, will be talking after me. Not all laryngomalacia will need a supraglotticplasty, but we have to know about the complaints of the child and the failure to try, which will actually indicate whether the child will need surgery or not. Then valvular cyst is one situation where actually during the assessment, it's better to have the anesthetist with you, because he's the person who's going to face the first challenge of intubating. And we should always keep in mind that there could be an existent laryngomalacia, which is not evident when you do a TNFL also. Webs can be of various types. A small web, we can leave it alone until the child is 4 years. It will only affect the voice. But when the web is large and thick, initially people do not realize when they're doing it that this chunk of cartilage is very difficult to remove. It takes time. So one should be prepared when we are doing a thick, longer web, that it will be much more thicker. Laryngeal clefts, as we had mentioned earlier, the only way is to, if you suspect laryngeal clefts, you are not finding any other cause, you have to take the child under anesthesia and palpate. That is the only way you will be able to detect a laryngeal web. We had cases of tracheal mass. We did not have ECMO in our city at that time. So, and as children, adult as well as children, we devised this method of doing a tracheostomy and doing a single lung intubation and doing then to removing the mass. And this was published in our journal a couple of issues ago. Let's have a few points about LTS. These are the points we all know one should remember when you are assessing a patient for LTS. We should remember all these points, and only then when we do a systematic sort of examination, then we will be able to do a proper assessment and planning for the surgery. And we also need to know which cases we can prudently go for endoscopy, and which are the cases which will need an external or open procedure where no amount of endoscopy is going to help. So, if we can segregate these two properly, then our planning of the surgery will be much easier, and the patient will be much happier because they do not have to undergo too many procedures. But sometimes there are situations like this child, 3-year-old with an immunocompromised problem, was having respiratory distress. Our pediatricians told us to do a track. We said we'll examine first. And when we examined, we found there was a lot of invasive fungus. So actually, it's always good to know why we are doing it. And this is something for which should not happen to anyone. Luckily, even though it looked like a cannot intubate, cannot ventilate sort of situation, luckily the child did not need a tracheostomy to be brought back before that. And thank you all for listening to this talk. And I'd like to thank the different institutes that I go to, and also my colleague, Dr. Biswajit Gogoi, for all his help. Thank you very much.
A very good afternoon to all of you. At the outset, I would like to congratulate Team PHONOCON 2022 for organizing this fabulous conference. I'd be sharing with you my experience about laryngomalacia and how I manage it. Laryngomalacia per se is the commonest pediatric airway disorders seen in newborn babies, followed by vocal fold paralysis, subglottal stenosis, waves and atrachas, hemangiomas, cysts and laryngocele, and clefts. For each patient, we have to go through a fixed protocol, which starts with a meticulous airway assessment, followed by counseling the parents about what we have found out, and then fixing up a protocol, a line of management for each and every patient, be it surgery or conservative management. To start with, all of our patients with congenital disorders undergo a airway assessment, which starts with transnasal fiberoptic laryngoscopy, which can be AVIC or ASLIP. It has been done to assess the dynamic airway, how it is collapsing in each respiration, both during inspiration and expiration, followed by a direct laryngotracheoscopy. We may always miss out a second pathology, so you have to go down to the carina. We go in with a rigid scope, and we see what is going wrong deep down there, if there is any congenital anomaly, a second pathology, followed by a suspension microlaryngoscopy, which helps us to differentiate between vocal fold paralysis and arytenoid fixation, and finally, last but not the least, bronchoesophagoscopy to rule out any gastroesophageal reflux or hiatus hernias. Laryngomalacia is the commonest congenital laryngeal source of stridor, which occurs due to inward collapse of the supraglottic structures. It's a self-limiting condition which starts around 2 to 4 weeks of age, progresses for about 6 to 8 weeks thereafter, and finally most of these patients have a complete resolution by 1 to 2 years of age. There is always a male preponderance, and about 80% of these patients are associated with gastroesophageal reflux disorders. We can categorize it into different types. In type 1, there is inward collapse of the arytenoids and there is a short aryepiglottic fold. Most of these patients recover spontaneously and usually they do not require any surgical intervention. If they do at all, they may require just a resection of the aryepiglottic folds. In type 2 laryngomalacia, there is a omega-shaped epiglottis along with shortened aryepiglottic fold. A subset of these patients require surgical intervention in the form of a supraglottoplasty. In type 3 laryngomalacia, there is inward collapse of the epiglottis into the laryngeal inlet during inspiration, and all of these patients require surgical intervention in the form of supraglottoplasty and epiglottopexy. So, to summarize, type 1 and type 2 laryngomalacia patients usually recover spontaneously. Only a certain subset of type 2 laryngomalacia patients require surgery. Patients with associated congenital cardiac conditions where anesthesia is hazardous cannot be operated. So when do we operate? We operate in patients of laryngomalacia who have got severe stridor with compromised airway, feeding difficulties, failure to thrive, and obstructive sleep apnea. Immediate intervention is called for those patients who have persistent dyspnea, suprasternal retractions, hypoxemia, and hypercapnia. Supraglottoplasty, the main surgical technique for managing laryngomalacia, is basically a subset of surgeries of which arytenoidoplasty is nothing but excision of the supraerytenoidal mucosa. Aryepiglotoplasty is a technique where we excise the mucosa of the aryepiglottic folds. Epiglottoplasty is excision of the posterior edges of the epiglottis. Epiglottopexy is de-epithelialization of the lingual surface of epiglottis and fixing it with the tongue base with sutures. We can do this either with cold steel or with laser. Personally, I would prefer carbon dioxide laser over cold steel in terms of precision and less bleeding. I would say no bleeding at all. Basically, surgery for laryngomalacia is a no-tube technique where person's laryngoscope is something of indispensable, I would say, for this technique because it has got a slot and you can always take out the tube, operate again when the saturation falls below 90, put in the tube, hyperventilate, and proceed with your surgery. The working distance for carbon dioxide laser is around 400 millimeters. The preferred spot size is 250 microns. We prefer an ultra pulse mode and the power setting is at the range of 125 microjoules per centimeter square with a repetition rate of 10 Hertz. This is a highly edited video of the surgery for a type 2 laryngomalacia. After fixing the laryngoscope, we start with vaporizing one half of the epiglottis, rather one edge of the epiglottis. When the settings are good, you don't see much of carbon formation as you can see here. After you finish off one side, vaporizing one edge of the epiglottis, you move on to the other side. From time to time, you have to be careful to remove the eshers which are being formed. Otherwise, if you leave back the carbon and the eshers there, then they may give rise to postoperative synechia or bands and adhesions. So after we finish off with the right side, we go to the left side and symmetrically we reduce the lateral edge of the epiglottis, the omega-shaped epiglottis. After we finish off reducing the epiglottis, we next go to the aryepiglottic folds. Few things that we have to keep in mind is you should not touch the pharyngoepiglottic fold, otherwise it may give rise to dysphagia. You should not touch the interarytenoid region. After you finish off with the epiglottis, you start with the aryepiglottic folds. And as you work on with the aryepiglottic folds on either side, it opens up the epiglottis or the laryngeal inlet opens up like a book. One small thing I would like to mention is here we would like to keep a little island of mucosa so that it may prevent future stenosis or this is the area where I was talking about. This is the end result of the surgery, but you can see the larynx has opened up nicely. So this is the same patient preoperatively, where you can see there's a lot of chest indrawing and suprasternal indrawing, and the patient could not survive without life support. The same larynx of the same patient, where it's a patient surgery of this patient only I showed you, where there's a type 2 laryngomalacia with a short and airy epiglotic fold and the omega-shaped epiglottis, and there is complete collapse of the airway during inspiration. The same patient on table immediately after we extubated. There is no chest indrawing, 100% saturation on table, no suprasternal indrawing, and there's a good cry. The patient recovered very nicely. This is the same patient at 1 day in the ward, sleeping nicely, only a nasogastric tube, no respiratory support, no chest indrawing. That's the magic that a good surgery can do, immediate relief of these patients. 3 months down the lane, the patient has gained subsequent weight and a healthy child. Again, no respiratory distress. And this is the endoscopy of the same patient after 3 months, where you can see that larynx has opened up nicely. This patient is breathing spontaneously. You should also, while you operate, you should also keep in mind to vaporize the chronic fluid in the cuneiform cartilages. Otherwise, the opening of the larynx may not be adequate. Follow-up after the surgery, we give antibiotics. Usually coamoxiclav is our drug of choice, adequate analgesia, steroids in the form of inhalational steroids. Oral feeding is started on nasogastric tubes the next day only. Respiratory support is usually not required in them, and we discharge the patients after a couple of days of surgery. Definitely, there are complications of this surgery as in all other surgeries. Those standard surgical complications of laser fire always looms over your mind, so you have to be careful. There can be in supraglottic stenosis is in a good number of patients. So what I already mentioned, we always leave behind a small mucosal island on either side so that it prevents supraglottic stenosis or falling back of the epiglottis and synechia in the postoperative period. And obviously superinfection, for which we routinely put them under coverage of antibiotics. And as I already mentioned, 80% of these patients are associated with GERD. So usually we start off with twice daily proton pump inhibitors before the surgery and continue it for at least 6 weeks after surgery in all of these airway patients. So how to avoid complications? You should have a dedicated team who are trained together and they know what is what. This team starts off with the otolaryngologists, pediatricians, anesthetists, intensivists, pulmonologists, thoracic surgeons if required, paramedics, and finally the parents whom you have to motivate. Stick to the parameters, never deviate from them, otherwise things may go wrong. Avoid excessive mucosal removal to avoid complications like synechia and postoperative stenosis. So that's how I do laryngomalacia, and I would say again, around 80% of my patients whom I do diagnostics fall in category type 1 and type 2, and usually most of them do not require surgical intervention. Only a small subset who are symptomatic require surgical intervention. And if you are focused and targeted, you can give a good result in all of these patients. Thank you very much for your patience.
Good afternoon. everyone. I'm Dr. Suhail. I'll be talking on endoscopic management of laryngotracheal stenosis. To go over a few overview slides in the beginning. When we want to use endoscopic management as an option, I think there are a few determinants and selection criteria which are important we keep in mind. The length or the diameter of the stenosis, the superior, inferior, the length. Usually we don't attempt if it's, a little larger segment, maybe 1 to 1.2 centimeters. What is important is to note the character of the stenosis, whether it's, just granulation tissue, infection, polyps, or whether it's a membranous one, which would be better amenable to endoscopic procedures, or is it a very mature, firm stenosis, which would lead again to further scarring. And if it is anyway a mature, firm stenosis, if you want to select an endoscopic route, it should be probably just a very short segment. Also very important is the state of the cartilaginous framework. If our cartilaginous framework itself is deformed, then we are not going to be able to get a good result with any endoscopic work, because it is anyway deformed from the start, and we are not going to be able to change the dynamics of the cartilaginous framework. So that's a very important point. Of course, if the patient is tracheostomized or not, it gives us some options, a bit of safety net. If you are planning to do some endoscopic work above the tracheostomy, whether we can then stent it, or so it gives us few more options. And obviously we need to know what is the vocal cord status. We do not want to cause any further trauma to the other cord or a lot of edema, which would then, if the patient is not tracheostomized, would lead to an airway compromise and problems. And of course, also important is when we time this endoscopic procedure. Timing is important because we don't want to go ahead with the procedure when it's very inflamed and there's infection. We don't want to do any instrumentation at that time. Of course, we would like to preoperatively evaluate these patients with an endoscopic evaluation, whether in the outpatients we do a video laryngoscopy or a fiber optic laryngotracheoscopy. But sometimes it is useful to do an evaluation under GA, because if you have some distal lesions which you really cannot see, and through the outpatient endoscopy, that would be a good time to assess it, see whether there are any glottic scars wherever they are, or there's any arytenoid fixation, and we could also palpate the stenosis, which is a very good tactile feedback we can get. Of course, imaging is always a help, and we can know where exactly the stenosis, how thick it is, what's the diameter. Yes, but we don't get to see character of the stenosis on CTs. There's a lot of virtual endoscopy and things we can get done these days for our benefit. And before procedure, yes, we would to be no reflux at that time. We can put the patients on anti-reflux medication and a tracheostomy culture. If there's a tracheostomy that's applicable, we don't want that wound area to be infected. And also as a routine, do a chest and cervical spine evaluation. Now we can work up and plan what endoscopic procedure we are doing, of course, discuss with the anesthetist, because they are important partners in this whole procedure, what we are planning to do and what kind of anesthesia they would like to assist us with, whether it's an intermittent anesthesia, whether they can pass an LMA and then we can do a scopy through that, or whether it is high flow oxygen or Thrive, which is an excellent technique now, which is being used, or in some cases we'd like to do some jet ventilation. So the procedure you are most comfortable, and with the anesthetist in particular situations, we can decide on that. Submucosal steroid injections, what we are going to inject, whether you're going to use a laser or cautery use, and the precautions and a type of laser. Are we going to do a balloon dilatation in this patient's post, a laser or cautery used? Then what would be the choice of stent, and also a workup and plan whether we use one or two modalities for this treatment. Now, say if you have like this an anterior glottic web or a stenosis, assessment, of course, we can see, but it would be great to palpate, and what kind of division, whether you use laser or cold knife, is up to our choice. And what we would like to, stent this kind of a lesion with, we place a keel and prevent further adhesions. In this case, actually, we had used a bit of Gore-Tex and anchored it in the usual way, and tied it out on the neck, and of course buried the suture. And we usually keep these for about 3 weeks. This is post removal around 3 months, but we'd at least like to keep that stent in there for 3 weeks minimum, or a month. I'm just put this slide to show an laryngotracheal mold for glottic, but this is usually, I'm not going to be discussing so much on glottic stenosis because we don't have very good stents, to stent this area. We have tried with T-tubes, which are closed off at the upper end, and we try to project those above the cords, but any stenting which is going to put pressure on the posterior commissure, or cause and a little more trauma, we'd like to avoid. This is one of the best stents, but yes, sometimes we use this with an open procedure, and these stents of Dr. Monia or this LT mold is not available to us. I just showed this slide because this is a very good stent to stent glottic lesions. Now, the special considerations are we going to do a dilatation? How many sittings will be involved, and what kind of stent, if at all, we are going to use. This will involve whether the incising and how we anchor these stents. Of course, we need to control infection and LPR. We should avoid excessive use of laser. It's counterproductive. CHAR leads to, in fact, much more firm stenosis, and we should try to preserve as much mucosa as possible. Of course, comorbidities, we should keep in account. Severe diabetes, uncontrolled, these may influence the outcome. And cost is a very practical matter to be discussed if you have to do multiple sittings of any endoscopic procedure in our hands. You can start off with the simplest intralesional steroid injections for some granulation tissue in the subglottic region. They do well. In this, you may require multiple treatments, which they do very well. And if there's a sufficient airway, I think this is easily done. It can be done actually as an outpatient procedure too, or you could do it under GA. And this is also very common problem we have is suprastomal granulation tissues, those patients who are tracheostomized. The intralesional steroids or triamcinolone would be a good option to see if you can shrink these off, because being more vigorous and trying to excise these may defeat the purpose. They come back a little more firmly then. So a couple of sittings of suprastomal triamcinolone injection is a good idea. Similar, you could have a suprastomal polyp, which can, sometimes it is pedunculated, which can be excised even with cold instruments or laser, whatever we would feel like. Now, this is the same patient who had this suprastomal polyp and granulation, and also had a tracheostomy which had caused a lower infrastomal or infratracheal polyp and a little stenosis. You can see this is the same patient with quite inflamed mucosa. So in these cases, yes, we had to deal with the lower bit and the upper bit, and then the lower one was quite tight, so we have actually had to stent this off with a T-tube. So you can excise that, inject steroids, dilate it if you wish with a balloon, and place, in this case, place a T-tube for a few weeks, which would help the mucosa, and that healed around it. And you should see that this, whatever stent you're putting, the T-tube goes beyond the lesion well enough onto normal mucosa, because you don't want it cutting at the edges and leading to further granulation tissue. And this is another view from the subglottis. Many a times we see these kind of suprastomal stenosis. They are smaller stenosis. It's a shelf, but it's quite narrow. Sometimes you're not able to decannulate these people. Similar things can be done if you, but this is a little older stenosis, maybe a few months or even longer. So this you would have to excise and balloon and see if possible, if you can get away with providing an enough airway. Sometimes with larger, suprastomal granulation, which cause quite a collapse, we can use laser. Now we have the CO2 laser, which can be delivered and that area opened up. If you'd like not to stent, see how they do, or if necessary, if you feel there is a fair amount of narrowing happen there, we could use a T-tube, or if not, just a single segment of even a cut T-tube if you want to keep the tracheostomy, just to keep that region open. There many a time just ablating this and opening up the airway and reducing the infection sometimes settles the issue. Imaging, of course, is a great tool. You get to see and you can clearly demarcate how big is the lesion. Is it a small enough one? Where exactly is the situation? How much below the cord level it is, and how best we could try and tackle this. If it's a small segment stenosis and at a little lower point, then it's a good option to try and do something endoscopically, which could give a right answer instead of planning something open and a larger, bigger procedure. And this way we can get various cuts down to whichever level and see how much is the narrowing. A virtual endoscopy is also pretty easy. Most of the radiologists do this today and can give us a fairly good idea. Now, if you're using a balloon dilatation, we use it TAR setup with the flexible bronchoscope. I'm just showing this that it can be passed through an LMA so that you have no issues. You don't have to have either an apneic one. You can keep the LMA and pass this down. They have two channels. One can be used for the balloon and the other can be used for suctioning. And this balloon channel admits most of the regular balloons, and we can open this up at whichever level we want. So these balloons are, of course, easily available now. It's attached to a pressure gauge, and you can build up the pressure to the number of atmospheres you need. And in fact, these balloons have this mentioned on it, like 3 and 4, 3 atmospheres, 5 atmospheres, and this is the pressure in kilopascals. And this is to what size the balloon would dilate to. So to 10 millimeter, 11, 12, because we need to choose a balloon which does the adequate job, the adequate fit, dilates. We don't want to have a larger balloon which will cause more trauma and problems. So we size this balloon correctly to the amount of dilatation we expect to have with these kind of pressures, and is mentioned here. This is a guide on the balloon, so you could go up to 3 atmospheres here, 4, 5. We don't go to very high atmospheric. It becomes like a hard bit of a stent, this balloon. But of course, when you deflate it, is fine. You can see the amount of measure you've got. So we can pass this needle cautery through the bronchoscope in this way, and we can also use an cautery too. At times, we used to earlier do balloon dilatation through a rigid ventilating bronchoscope, but nowadays we don't do it. We can, you can size a Dumont stent, which we used to do earlier, to place it in the tracheal lumen. Now, this is a narrow 5 millimeter diameter shell. Now, this is a very small stenosis, but we can see that it's a small shell which can be opened up fairly well and should give a good result with an endoscopic route. You can see this through a rigid bronchoscope while being ventilated. And this is, of course, a deflated balloon. You pass through the stenotic lesion, inflate it up to the level you want to, deflate the balloon, and then take it out. And you can, this was an earlier like a Dumont stent place. This patient is not tracheostomized, but you can place it There, the problem with Dumont stents is they are a bit difficult to retrieve and pull out because of these studs which get into the wall. See, now this was a narrow concentric grade 2-3 stenosis. It looks fairly, but it was more shelf-like. So we thought we would, and there was a little granulation and stenosis at various levels. So this was the post-dilatation result we got in this patient. This was just with one sitting, which is fairly good. And you can see that there were these there's a lower shelf, and this shelf is quite nicely opened up. Same thing we can use to these concentric stenotic bands, which can be, just divided. This is actually a cautery needle passed through the bronchoscope. They have the very fine ones, and just do a balloon dilatation to give you a fairly good result. This is another short segment stenosis. This was a patient tracheostomized and then had a lot of scar tissue, but we felt it was a short segment, and we had made, the Mercedes-Benz or three incision marks on that and dilated it, and we got this kind of a lumen, which was fairly good. We had to do 2 sittings in him, but we avoided doing a tracheostomy, and he did sufficiently well for all his normal activities. He had no airway compromise. And this is his post-op. I think this is much about 3-4 months post-procedure. So quickly, to just summarize a bit of do's and don'ts, the thin membranous stenosis, which have short segment, are ideal for endoscopic procedures. Polyps or granulation, which are eccentric and not circumferential, we can attend with endoscopic views with maneuvers. We should try and preserve the maximum normal mucosa present and use laser or cautery sparingly. You should never char circumferentially around, make cuts, and leave intervening good mucosa. Steroid injections, whether we do those or laser, dilatation or stent, we have a couple of options. And we shouldn't be, that let's do all. You need to do what is the right thing for that particular kind of stenosis and the lesion, and choose what is the ideal. And you don't want to do thick scarred stenosis, because they will rescar badly. We don't want to do an endoscopic procedure where there's a cartilage and framework deformity, or a firm cricoid stenosis close to the glottis. It's not going to give us great results, or a very malachic trachea. This is again a problem. We are not going to get good results. And we don't want to do it in presence of active infection and LPR. Better to wait and let things settle down. And definitely we should not expose luminal cartilage extensively inside, because this will lead to perichondritis, further problems, scarring, and then you again get a deformed trachea. So to stick to the rules of where mucosal sparing, try and select 1 or 2 endoscopic procedures which are most amenable to the lesion, whether you use a balloon or you use sparingly laser to incise and then balloon dilate. And yes, you may require 1 or 2 sittings, and especially with the mucosal steroidal injections, you may require a few sittings, but you can get good gratifying results in this particular set of patients. And selection is important, obviously. These are some of the don'ts I mentioned. Obviously, we don't want to attempt something like this with deformed tracheal cartilages or a very severe glottic stenosis, and definitely not on these sort of glottic lesions which have posterior glottic stenosis. And we shouldn't attempt anything on that posterior glottis when we know this will definitely need an open procedure. And just a word about acute post-intubation edema, granulation. These should be left alone and not to be meddled with as much as possible, because they do all resolve fairly well with standard medication and treatment, and we can just observe and see how they do. Yes, we always strive for perfection. It's a good habit to keep, but we should know our limitations with endoscopic procedures, what can be done, and have a plan and go according to that. Yes, sometimes you will land up in a situation where you've tried to do an endoscopic procedure, it's failed. So more important is to know that when to stop and not keep persisting, and that this patient probably requires an open procedure. Thank you very much for your attention and time. The way this is, it's recorded, so I'll be happy, and later we get on to the real conference to answer any questions or queries. Thank you.
Good evening, all. As we discussed today, open procedures for laryngotracheal stenosis, let me say that this talk may seem a bit dated. And the reason for that, obviously, is that much of the data in the papers that this talk refers to have been published a fair while ago. We basically faced major problems with this situation a couple of decades ago, but over the years, we have sorted many of these issues. And this talk is really a synopsis of lessons that we have learned in our own experience as we have progressed. So this is about 2011, and what it basically says is that the commonest cause of laryngotracheal stenosis or chronic laryngotracheal stenosis in our situation was endotracheal intubation, as it is, and also a fair amount of blunt neck injury and strangulation. Up to 40% of patients are caused by this. Most patients have grade 2 to grade 4 stenosis, and resection and anastomosis of the tracheal stenosis has been by far the commonest operation that we have been undertaking for this, with generally very good results. As you see here, that in the trachea, we decannulated some 95% of our patients even in 2011. At that moment in time, we weren't quite doing so well with the larynx and glottis and subglottis, but over time, even that has improved. And this was in 2014, wherein you see that we did decannulate 97% of a patient with subglottic stenosis. The only problem being that we had to do a fair number of procedures, so an average of 2.2 procedures per patient decannulated. And I would say that by this time, we had come to a situation wherein we have a decannulation rate upward of 95%, 97% for all kinds of laryngotracheal stenosis. So this paper that I was referring to you about, which is the paper on subglottic stenosis, as I said, 2.2 procedures per patient. And what we did then was to look at each and every procedure and how much it helped the patient in his or her journey towards decannulation and restoration of airway. And what that indicates here is that in terms of subglottic stenosis, endoscopic procedures, only 10 out of 31 procedures actually resulted in substantial gain. The star indicates that in many of these situations, it wasn't quite the isolated progress by the endoscopic procedure. Rather, the endoscopic procedure was part of a follow-up to an external procedure which was undertaken previously and which resulted in the substantial gain to the patient. It was only in 2 situations wherein the endoscopic procedure alone led to substantial gain and to decannulation. And let us now look at open situations or open operations. In terms of open operations, you find that 27 out of 34 operations resulted in substantial gain leading to decannulation. And again, if you look at it a little bit more closely, then cricotracheal dissection and anastomosis was very effective. Anterior cricoid split with a costal cartilage graft effective, and anterior and posterior cricoid split both taken together, again, very effective. What was not effective was just doing a laryngeal fissure or a tracheal fissure, coring out the stenosis and grafting or stenting. That didn't seem to work so well in our practice. Of course, you also need to look at what these operations were done for, the nature of the stenosis, and looking at this, this is what we came up with on this paper. If a stenosis is short, less than a centimeter, if a stenosis is also grade 1 or grade 2 and no worse, and is soft or mucosal and recent. So all 4, if they're all if they're all included, then certainly patients with this characteristic of stenosis do well by endoscopic procedures. And in endoscopic procedures, our general thought is that we should be doing stenting for these patients, because without stents, they don't quite do as well. Sometimes it's difficult to do stenting, particularly in pediatric patients. And in those situations, we tend to repeat the dilatation on a sequential basis on 3-weekly or 2-weekly basis. But in the large majority, we tend to do one endoscopic procedure and stent. But that is only for these very limited indications. In situations wherein these limited indications are not met, that is, the stenosis is more than a centimeter and grade 2 or more, or a hard cartilaginous stenosis, we look at open procedures. Of course, a hard cartilaginous stenosis, making a judgment as to whether a stenosis is soft or hard, or mucosal or cartilaginous, can be difficult, but this is a multifactorial assessment which depends on the injury mechanism, depends on looking at the radiology, the CT scan, looking at the time since onset, because certainly if a stenosis has been around for 4 to 6 months, you can expect some degree of fibrosis, and also depends a little bit on the endoscopic findings. And these are the indications wherein we do open procedures. when you expand on this from the subglottis to the trachea, you do realize that the trachea is a little bit more forgiving than the subglottis. And for tracheal lesions, you can be a little bit more adventurous with regard to endoscopic procedures or with regard to indications for endoscopic procedures. They are a little bit more likely to succeed. And as I have said, this is really the synopsis of what we learned by undertaking so many procedures, which were often successful but often not successful. And as they say, that wisdom that you sort of learn on your own is really the most useful for your situation. So what open procedure and when? Basically, it's only 2 open procedures that we do. We showed you the data wherein we showed that these were the 2 open procedures which worked. So it could be laryngotracheal reconstruction, which is really getting a costal cartilage graft and using the costal cartilage graft to expand the cricoid. You cut the cricoid anteriorly or posteriorly and wedge in a piece of cartilage, which then gets incorporated into that ring and opens up the cricoid ring. So for lesser degrees of stenosis, which basically means grade 1 or 2 subglottic stenosis, we use an anterior costal graft. If it's a grade 1 or 2 lower subglottic stenosis, this is our preferred way of doing things. If it's a grade 3 or 4 stenosis or a very high stenosis or a stenosis which is reaching as high as to involve the posterior glottis, then again, we don't quite set store on a anterior cricoid graft alone, but we do both an anterior and posterior cricoid graft. So we split the cricoid posteriorly and wedge in the cartilage graft posteriorly, and then we use another cartilage graft to wedge it anteriorly, suture it in place, usually with PDS. We often use a T-tube in place for about 2 months to support this assembly. And the tube comes out in about a couple of months, and that is it. What about resection and anastomosis? Again, some small variations. It could be a resection of the tracheal stenosis alone. It could be trachea plus the cricoid arch or the lower part of the cricoid. Not the lamina, but the cricoid arch can be excised along with trachea. So a cricotracheal resection. And very occasionally, it might be that you need to do a cricotracheal resection and further augment the higher subglottis with a posterior cricoid split and costal cartilage graft. Some cautions. This is generally applicable to most of our patients, this scheme of things. But you have to be a little bit careful in situations which may not be otherwise appropriate for removal of tracheostomy. There would be some patients who have been to the ITU, haven't quite recovered completely from the illness that took them to the ITU, continue to have significant ventilatory issues or significant consciousness issues, which in any case require a tracheostomy. And in that situation, it would be inappropriate to get very adventurous with removing the tracheostomy tube only from the stenotic point of view, because there are other indications for the trachea. Also, you have to be a little bit more careful with situations with very long stenosis of the trachea, wherein the tracheal resection and anastomosis may lead to undue tension. As a general rule, more than 6 centimeters or more than 40-45% of tracheal length becomes a contraindication. And similarly, very low stenosis, which is close to the carina, can be very challenging, primarily because of the difficulties that you get with maintaining anesthesia in these patients. So coming on to how we do the resection and anastomosis, it's quite straightforward to understand. You resect the stenotic part, which, as I said, can be up to 6 centimeters and generally not more than that. And once the bit is resected, and the 2 good ends are anastomosed to each other. And that essentially is the operation. Now, this is how we do it. We start with an endoscopy, recheck that the suprastromal area is healthy, check the point of how far it is from the vocal folds that you need to take a resection cut. And then we pass a Foley's catheter, which is passed through the nose and stationed in the subglottis or trachea. And why we do that, you'll come in a moment. The incision is horizontal, slightly curvilinear. We need to have access right from the sternal notch inferiorly till about the hyoid superiorly. Once that access is done by raising skin flaps, we cut the thyroid in the midline and dissect along the trachea, especially along the stenotic segment, to release the trachea along the stenotic segment from the sides. Once this is done, we explore the stenotic area, and this is best done by just incising on it. You incise on it and slowly move superiorly till you come to normal trachea. That is where you take your superior resection cut once you've identified normal trachea. You then raise the trachea. You can hold it with an Alice forceps or a Babcock's forceps, because you know you're going to excise this stenotic segment anyway. And then you mobilize the trachea by dissecting it off from the esophagus posteriorly by digital dissection. And similarly, anteriorly, you hug the trachea and dissect between the aortic arch and the trachea right down to the carina and the 2 bronchi, so that you can release the trachea both anteriorly and posteriorly and mobilize it so that you can pull it up to anastomose it to the upper segment. Laterally, you tend to not dissect too much because the blood supply to the trachea comes from the lateral pedicles, which come along the inferior thyroid artery and other vessels. So dissection is superiorly or anteriorly and posteriorly, and the trachea is so mobilized. Occasionally, you can do a laryngeal drop, which also is another way of mobilizing the upper segment. But this is not quite my preference, because doing a laryngeal drop lowers the larynx physiologically, which is a risk for aspiration, and also it lowers the anastomotic site in the final anastomosis, and that can lead to needless technical difficulties. So this is a mobilized trachea. You can see how much of it has been pulled up by digital blunt dissection along its anterior and posterior walls. Once that is done, the dissection is undertaken. So the dissection includes the stenotic segment, the stoma, and at least one tracheal ring below it, and a nice clean horizontal section is done. You can see that, and the stenotic segment is removed. Once that is done, you make a tracheostoma, a couple of tracheal rings below the site for the potential anastomosis, and secure the airway through it. Now you're ready to anastomose. First, we anastomose the posterior part of the trachea. So the posterior tracheal wall is anastomosed, and we typically take 5 sutures, occasionally 7 sutures, 1 in the center and 2 or 3 on each side. We also take 2 sutures of nylon on the side of the trachea, which an assistant holds and pulls up to avoid traction on the suture. And once all 7 sutures are taken up and traction is applied by these 2 traction sutures by the assistant, then you just do the posterior anastomosis. That is it. Posterior anastomosis being done, you pass in the Montgomery tube or the T-tube through the tracheostoma and plug the upper end of the T-tube by passing the Foley's into it and inflating the balloon of the Foley's. Once that is done, you have a circuit wherein through the neck you can ventilate the lungs, and there is not going to be any air leak superiorly because it's been plugged up by the Foley's, and you are now again with safe closed anesthesia. So now is a good time to do the anterior anastomosis, and if that's it, it completes the anastomosis. Once the anastomosis is completed, we also take 2 supporting sutures on each side from the thyroid lamina to the trachea on each side. And once the supporting sutures are in place, we take out these traction sutures which we're using to hold the trachea up. That essentially is the operation. And the patient generally has the Montgomery T-tube blocked on day 1. And once that is done, then the patient is back on nasal respiration. But we don't quite remove the Montgomery T-tube till about 10 to 12 weeks. And when we remove the T-tube, we then replace it with a small tracheostomy tube and observe for another month, just to make sure that the patient's airway remains stable. Once that is also confirmed, then we decannulate. And all of this is done in the outpatient. So there is really no significant inpatient input for these patients then. Very frequently, and especially in patients who have had strangulation injury or blunt neck injury, very frequently you'll find that they also have bilateral cord fixation. And if they have bilateral cord fixation, then we would do a laser kashima. And after the laser kashima is done, then this patient is fit for decannulation. So you expand the glottis by doing a slight laser kashima operation. And that essentially is the scheme for our patients with laryngotracheal stenosis. I'm often asked as to why do we choose to use a Montgomery T-tube rather than to do a single stage end-to-end anastomosis without a tracheostoma. And this can be done. We do it for patients wherein we are doing resection anastomosis for malignancy or in patients who have very minor degrees of tracheal stenosis. But as a general rule, patients often have pre-surgical cord fixation. I told you, we do know that there can be injury to the rectomeningeal nerve at surgery. We do know that excessive tension on the suture line can sometimes lead to healing difficulties. And we don't quite see the point on taking all these risks. So we believe in keeping a Montgomery T-tube in place post-op for a few weeks. This minimizes ITU care, or rather totally takes away the requirement for ITU care. There are no post-surgical airway emergencies, as you can anticipate in situations wherein the airway is only dependent on that anastomosis with nothing to safeguard it. So this is how we tend to do it. This facilitates early discharge for our patients. They can go home to their distant homes away from the city of Delhi, and works exceedingly well for us with minimal requirement on complex hospital procedures or the need for emergency care. So to summarize, this is where we are currently. We are at 95-97% decannulation rates for almost all our situations of laryngotracheal stenosis. Much of what I've told you today is also synopsized in this chapter we wrote in the textbook of laryngology a few years ago. This synopsizes what we do. It's the same slide as was brought out a few slides ago. So thank you.
Good afternoon, everyone. At the outset, I thank Sanjay Subaya and his team for inviting me to PHONOCON 2022 to share my experience on coblation in laryngology. The term coblation is derived from the word controlled ablation. It was first invented by Philip Eggers and Ira V. Tapilial, who patented their electrosurgical ablation probe on May 11, 1999. It's a combination of radiofrequency energy with natural normal saline solution. This technology uses the principle that an electric current is passed through a conducting fluid. A charged layer of particles known as plasma is released. Let's see what are the characters of coblation. It's a bipolar configuration. The radio frequency current flows in the saline conductive medium and it creates a plasma field in sodium chloride and free sodium ions are released. These charged sodium ions then breaks the intercellular molecular bonds and causes disintegration of the cells and volumetric reduction of the tissue happens. So, in brief, the advantages of coblation are because of the low frequency and surface temperature of 40 to 70 degree, decreased tissue penetration, minimal collateral tissue damage, shorter current path, control of energy delivery, and volumetric tissue removal. Let's compare with the electrocautery. Coblation as simultaneous cutting and coagulation facility and minimal tissue damage and less laterally, and that's why minimal scarring. Whereas with electrocautery, it requires different mode for different application, more tissue damage, more lateral heat, and then gross fiber scarring and fibrosis happens. With coblation, faster healing and less slough, minimal infection. Whereas with electrocautery, more slough and more chances of infection. And when you compare coblation with laser, with coblation, you have a precise cutting and coagulation. Both facilities are there at self-controlled coagulation depth and less lateral heat damage. Whereas laser, it's precise, but it has less control, especially because in laryngology, we use carbon dioxide, the coagulation is not there and more lateral heat damage is there. Let's see how the literature supports the use of coblation in laryngology. Wang et al., they published their experience of with 85 patients of benign vocal cord tumor, and they opined that the advantages of coblation are minimal trauma, minimal bleeding, eye safety, and few complications. And Timms et al., they published their experience with the coblation in laryngeal papillomas. And whereas Gong et al. And Carney et al. Are the one who published their experience of coblation in head and neck malignancies, and then they proposed that it is a good tool in head and neck malignancy. The assistance of coblation in arytenoidectomy for vocal cord paralysis was published by Jung et al. In Actal Otolaryngology. Now, what are the applications of coblation in ENT? It's used in OSA surgeries, tonsillectomies, adenoidectomies, hypertrophied inferior turbinates, microlaryngeal surgeries, stenosis, cordectomies, arytenoidectomies, and skull-based surgeries and tumors. Now, where all are used coblation in laryngology? Let's see. First, in supraglottic pathology, polyclasis, epiglottic cyst, OSA surgery, and in glottic pathology, vocal cord nodule, polyp, papilloma, early carcinomas, antiglottic webs, posterior cordectomy, and in subglottic and tracheal pathology, subglottic stenosis, tracheal stenosis, and suprastomal granulations. I'll be playing some of the videos. This is the first video of use of coblation in vocal cord mucus polyp. You can see it's on the vibratory surface of the mid-third of the vocal cord. We use laryngeal vands, LW or MLW, depending on the type of lesion we come across, and volumetric reduction you can see now. The squamous epithelium is not damaged because less laterally it is there. This is the stroboscopy picture and use of This is for the case of papilloma larynx. With the endotracheal tube in place, and we don't protect the airway except for the cuff is there. And this is in case of juvenile respiratory papilloma. You can see an extensive lesion, antecommissure, vocal cord, false cord, ventricle, then antisurface of the arytenoid, interarytenoid region. You assess the lesion. Slowly you ablate the tissue. And we remove the endotracheal tube, and in the entire arytenoid region, in the apneic episode, we removed the papillomas. That was on the laryngeal surface of the epiglottis. This is at the end of the 1 week. You can see how beautifully the vocal cords are there, except for the edema. This is the glottic pathology. This is the adult acquired glottic web. This is the pediatric congenital glottic web. Balloon dilatation was done here. The patient had tracheostomy. This is how we could, at the end of the dilatation, we will show you. And then we stented it with a silastic sheet. And a good vocal cords were there at the end of removal. This is a child. They were not agreeing for any stent. So at the end of second week, again, we went and looked for a dilatation, and repeat procedure was done. This is the posterior chordectomy where coblation assisted modified Dennis Cassius procedure was done. You can see first we'll make a cut at the junction of mid-third and the posterior third horizontal cut, and then you make another cut at the anterior end of the vocal process, and then volumetric reduction is carried laterally up to 4 millimeter, the otopocalis muscle and the thyroid muscle, up to the inner perichondrium of the thyroid cartilage. When we go there, then we encounter the bleeding. That's by the branch of the suprapharyngeal vessel. There's no need to worry because it has a coagulation facility. You can just coagulate the vessel and then you can carry on with your procedure. See how well the lateral thing, and later on it heals with fibrosis so that a posterior glottis airway is established with and there should be a balance between the phonation and the sphincteric action and the airway establishment. This is a papilloma on both the sides with superficial keratosis. You can see coblation assisted removal we did. This is the vocal cord look like. And this is a child with was brought 28 days old child was brought with the history of failure to thrive, and then noisy breathing, and then we did the endoscopy. You can see there was a cyst which was occupying from the epiglottis onto the oropharynx. Child was taken up for surgery. You can see how the xiphisternal and suprasternal recessions were there. the cyst was aspirated and then intubation was done. The cyst was held and then slowly volumetric reduction of the cyst wall was done with the coblation. You can see here this is the base of the cyst. See how well the child is sleeping. No recessions here. This is another interesting case of 52-year-old male who presented with hoarseness and then a stridor, and then he had a lesion in the arytenoid and then extending up to the paraglottic space. And this is an interesting case of lipoma of the paraglottic space. Incision was made with the coblation, LW1, and then the mucosal flaps were elevated. You can see how yellowish looking mass underneath, and then it was slowly excised up to the level of the vocal cords. You can see here. Then the flap was put back. You can see this is the arytenoid, this is the piriform fossa, this is the lateral surface of the arytenoid. And the same patient at the end of 1 week, you can see except for the restricted mobility, there is no mass. There was some edema of the paraglottic space was there. Now, this is a child with laryngomalacia, severe laryngomalacia, wherein the child had posterior collapse of the epiglottis, taken for epiglotectomy along with the release of the AE folds. You can see how the AE folds are released from the epiglottis. This is on the left side. And then the margin of the epiglottis was excised. So depending upon severity, our treatment varies. Now coming to the subglottic pathology. This is the subglottic stenosis in a 4.5-year child who was intubated for 4 days. This is a soft stenosis. Radial incision was made with the MLW1, and then balloon dilatation was done. This lumen which was established on table. All these patients will be put up on PPI and for 1 month post-operatively. You can see at the end of, when we did for the repeat balloon dilatation, this is how the lumen looked like. So only 2 dilatations were enough for this child. This is another adult patient. You can see here, but it was sort of, the cartilage was maintained. So I thought, okay, we can go ahead again with the coblation. And then balloon dilatation was done. You can see the endotracheal tube here. Then the tube was passed. Now you can see the lumen. She underwent 5 dilatations and it was normal. There's another patient with, the patient had tracheostomy and supratracheostomal granulations were there. Tried to do from above, but somehow could not achieve. Then through the tracheostomy, Yes, our evac van was passed, and then all the granulations were removed. One sitting, the patient improved. So why coblation would attract a surgeon? Because of the low temperature, no risk of myoglobinuria, as in laser surgery. Scar is minimal, it's painless, healing is faster, cost effective. Like many centers can have it, whereas lasers, very few centers can have. Does not take up valuable space in operating room, no special gates, no interference with histopathology, and almost no chances of fire in the operating room. In conclusion, so coblation can be we can use the coblation along with laser and cold steel instruments. And my experience with coblation in selected airway cases and in cancer larynx has been promising, but it requires research on larger scale to prove its benefit. Thank you.
Greetings. This talk is about carbon dioxide laser in early cancer larynx. I am Dr. K.K. Handa. Now, this is where I work presently, Medanta, the Medicity, Gurgaon, and we have a laser program here. And the majority of the work is being done in larynx, and a very significant amount of work is being done for early cancer larynx. Now, I will start my talk by first saying a larynx laser surgeon has to be a good phonosurgeon. You must understand the layered structure of the cord. Without that, you will not understand the concept of laser cordectomies. And we'll come to that later, the European classification of laser cordectomies. We have to cut the vocal cord layer by layer with a laser. And since it's a functional organ, the voice goes if you cut more. So you have to understand the layered microstructure. The vocal cord consists of squamous epithelium. Then there is a basement membrane. There is superficial lamina propria, which is also called rinky space. Then there is intermediate layer of lamina propria and a deep layer of lamina propria. Vocal ligament is made by intermediate layer of lamina propria and deep layer of lamina propria. And finally, we have the vocalis muscle. To start a laser program, you obviously must have a good laser. We use a luminous laser with the robotic scanner and EchoPulse. Now, then you must have a compatible microscope. So those of you who plan to start a laser program, first check on that. Then this is the laser console from where we can control a lot of parameters. You can either work in the super pulse mode, CW mode, or you can work in repeat, single, continuous. You can control the wattage. Mostly laryngeal work we do around 5 to 10 watts. You can control the depth. You can control the aiming beam intensity. As you know, CO2 laser is in the invisible spectrum. The wavelength is 10,532 nanometers, which is beyond the visible spectrum. So we use an aiming beam called helium neon beam or any other aiming beam which can be seen. So here you see the layer, the microscope is coupled to the laser machine, and we are able to work there. The other important thing, especially for cancer, is you must have a good quality laryngoscope. Most of the work where exposure is adequate, we are able to work with the normal Klein-Sasser or similar laryngoscopes. However, where you need more exposure, the lesions are bigger, area involved is more, then you need a distending laryngoscope. Here you see this laryngoscope is a Steiner proximal and distal distending laryngoscope. Laser, cuts very well, but laser can only coagulate till a certain caliber of vessels. But as we'll see, you will have some vessels, bigger vessels for where a Bouvier cautery must always be there. Then anesthesia is very important. You must have a dedicated laser anesthetist. We use a laser protective tube, but in our center about 3 years back, we have switched on to doing most of the laser work with jet ventilation. The advantage is the whole airway is of the surgeon. We don't use nitrous oxide during laser surgery, and FiO2 should always be less than 31. And jet has really added a big flip to our laser program. Here we see we have the Accutronics jet machine, and when the patient is put under anesthesia, you can just have a catheter instead of the normal tube. You just have a small catheter going in, and you can work either with a subglottic or a supraglottic jet. Before coming into cancer proper, there are certain lesions of uncertain pathology, benign ones like hyperkeratosis, dyskeratosis, acanthosis, reactive atypia, and then mild, moderate, severe dysplasia, and then carcinoma in situ or microinvasive carcinoma. Here, the standard of treatment is a laser excision biopsy. You excise the whole lesion with a laser and send it for histopathology. Now, few of these lesions you can see on the right cord, you see this white keratotic lesion, maybe leukoplakia, maybe keratosis, similar smaller lesion. Then I'll show you a small video clip of subepithelial chordectomy, which is a type 2 chordectomy. You see the lesion on the left vocal cord, and we are using the laser with a scanner and the AccuPulse, and the lesion is being cut. The laser almost cuts to a precision of 100 microns. So you will never damage the vocal ligament in a type 2 chordectomy. And you see how nicely the whole lesion comes out. So the lesion is out. Don't miss the subglottic patty with the thread. Now, early cancer larynx, this is the type of lesions which are very amenable for laser resection. You see the lesion, you can define the distal and the proximal end, well exposed. Now, this classification is very important. The whole laser concept of laser surgery is based on this. Type 1 is subepithelial chordectomy, type 2 is subligamental chordectomy, type 3 is transmuscular chordectomy, type 4 is total chordectomy, type 5 is extended chordectomy, where 5A is where contralateral cord is involved, 5B is where arytenoid is involved, 5C is where ventricle is involved, and type C is if subglottis is involved up till 1 centimeter. This is called European Laryngological Society classification. You can also do laser resection by the stage of the tumor. So for T1 situ, you do the type 1, 2, 3, T1A type 3, T1A again type 4 may be done, T1B type 5A or may be done. Now I'll show you a typical another lesion. This is malignancy, and we are going to do a laser chordectomy. Exposure, very important. And we start posteriorly from the normal area. Remember, in laser surgery, the margins are not very big. It is not like oral cavity where you give 1 or 1.5 centimeters. We talk of 1 to 2 millimeters. So another thing which you learn with experience is the cutting. Once you cut with the laser, there is a certain feel of cutting normal tissues. There is a certain feel of cutting cancer tissues. So this is of real help. Though we do send for frozen on table, good for helping us out and also good for medical legal purposes. So you see, slowly we have defined the lesion. We are going all around the lesion, and the laser beam is All of these laryngoscopes have a smoke evacuator. Normally it's the laryngoscope which has a smoke evacuator. And you see, this is a type 3 cordectomy. And we're going anteriorly. Sometimes it's not a bad idea to mark the lesion initially with the laser beam, because once you cut one part of the lesion, you may tend to get lost towards the end. You can see here, if you see carefully, this is normal cord. So we are well beyond the confines of the lesion, and the whole lesion is nicely removed. So sometimes towards the end, there is a vessel which comes and you need a bovie. So here, after resecting the lesion, we had to use a bovie cautery to cauterize. That is fine. Now, another patient, if you can see, this appeared like a vocal cord polyp. But once we did a MLS, it came out to be squamous cell carcinoma. And then a type 3 laser cordectomy was done. And patient had a high demand he was a marketing executive, so he wanted his voice back. So we did a fat injection on table and reconstructed his cord. So you can see this is the peritive fat injection syringe and abdominal fat harvested, and then with human insulin prepared, washed, and then injected into the cord. And you can listen to its acceptable voice despite a type 3 cordectomy.
My surgery was done on the left vocal cord for cancer treatment in May this year.
This was 2010. I have followed him up till 6 months back, and he's doing well. There is no recurrence. There are certain borderline situations where your judgment is to be based on the type of lesion, the anterior extent, and important whether cartilage is involved. If you have a slightest doubt about cartilage involvement, then we must do a CT scan to rule out cartilage involvement. These sort of lesions is a no for laser. You see, it's a transglottic growth, anterior part involved, going to the supraglottis. We can't do a laser resection in this. CT, if it is type 4, if it is stage 4, then he goes for a total laryngectomy. If it is type 3, stage 3, he goes for a CTRT protocol. So another small video clip of showing laser resection. If you see the preglottic, preoperative picture of the vocal cord, growth involving the full cord, and once we have resected with laser, you see post laser, cord has been resected. It's a type 4 cordectomy, but notice he's phonating with his false cords, which suffices in a lot of patients. You don't have to reconstruct in every patient. So they are able to phonate fairly well with the false cord. Frozen section, preferably yes, for medico-legal purposes, and also for defining our extent on the table. Now, this is a work of one of our students' thesis, where the extent of laser damage, and if you see this picture, different wattages and different modes, 10 watt super pulse mode, the extent of damage and the depth, width of thermal damage zone and the depth of thermal damage zone was ascertained. And we found there is an appreciable difference if you use different power settings and the different modes. Now, why not radiotherapy? Why laser? Now, the side effects of radiotherapy are well known: mucositis, the swallowing issues, and the salvage surgery. If you have to operate, the field is bad, and the chances of fistula formation are as high as 50%. Now, a varicose lesion, you can see similar way you can excise with the laser. Varicose lesion, I'll go fast in this, and you can see the whole lesion has been excised. We'll send for histopathology and works same previously. Now, cord reconstruction, either you can do primary or you can do secondary after a couple of months, once you are sure disease is not recurred. Now, the big question is, why is better after radiotherapy? Not necessarily so. Till type 3 cordectomy, the literature consensus is the voice results are equal, if not better than by laser as compared with radiotherapy. And there are a lot of side effects of radiotherapy. Another patient where you can see the serial laser resection till the end. You follow the picture. Now, certain select cases of T2 cancer also, we can do laser resection, provided lesion is well exposed and the literature supports that the cure rates are equal radiotherapy versus laser for T2. Now, radiation also is longer treatment, 6 weeks, risk of chondronecrosis, cost is higher, and if your radiation fails, then only what is left is total laryngectomy. But if your laser fails, radiotherapy is always there as a reserve. So this we've already discussed. Literature to support laser vis-a-vis the radiotherapy. This is very important. After CO2 laser surgery, this paper says a larger number of larynges are preserved as compared to radiotherapy. And this is a big point in favor of laser if you compare it with radiotherapy. So recent work, now there is plenty of work on transoral laser surgery for early cancer. Cost is less, 1 day stay, and radiation left as a reserve. Now with Professor Steiner, he was with us in Medanta in 2010. He was the biggest proponent of laser microsurgery for early laryngeal cancer, and we have learned a lot from him, and he was there to do a surgical workshop. Thank you. This is our textbook on voice and laryngology, available on Amazon. Thank you very much.
Good afternoon. Thanks to all the speakers who have made the last couple of hours truly engrossing for all the delegates. The next series of talks that we have are on commonly encountered swallowing disorders and their management. So kindly post your questions in the chat box below for clarifications, and your questions will be addressed in a day or two in the website. As we are being short on time and we have many more presentations to go on, we can't come online and answer your queries. So kindly post your questions in your chat box for your clarifications, and you can check these answers. We'll send these questions through email to the respective doctors, and you'll get your answers in a day or two on the website. And all the videos of day 1 and day 2 session will be online or available for all the delegates to watch these for 2 months. Kindly note, for 2 months it will be available and all of you can watch it anytime. Okay, over to the swallowing disorders.
Hello all. Today my topic of discussion is the neurophysiology of oropharyngeal dysphagia. Before I begin, I'd like to thank the organizers of PHONOCON 2022 for inviting me on this virtual platform. Now, the phases of normal deglutition are the oral, pharyngeal, and esophageal. Oral phase can be divided into the oral preparatory phase and oral transition phase. This is a video fluoroscopy of normal swallow showing all the 3 phases. So many muscles working in sequence in such a short span of time. So there's a subconscious neurological programming of the complicated activity of the muscles. The oral and the pharyngeal phases are interrelated and can be called the oropharyngeal swallowing. The pattern response is the oral phase. Swallow initiation is voluntary and has a cortical control. Then is the pharyngeal phase, which is an involuntary brainstem reflex. Once the bolus crosses the posterior fossal pillars, the touch receptors are stimulated and reflex swallow starts. And there's a sequential muscle activation causing bolus movement from the pharynx to the esophagus. Again, this has an involuntary cortical modulation. Along with it, there is an airway protection, that is laryngeal closure and elevation. So in nutshell, the cortex, the brainstem centers, and the cranial nerves, they are responsible for this neurophysiological process. Mainly, there is a cortical control and a brainstem reflex. In the cortical control, the swallow initiation is voluntary. In fact, this is the only portion of swallowing which is voluntary. The other is the swallow coordination through the cortical control, that is involuntary. The various cortical clusters work in unison, causing activation and inhibition of the whole process. The sensory motor cortex receives afferents from the oral, pharyngeal, and laryngeal areas and modulates the brainstem response. So suppression of cortical inputs will cause prolongation of the oral phase and increase triggering time of reflexive swallow. Now the premotor cortex, the swallow muscle representation is bilateral but asymmetrical. This is a diagrammatic representation showing swallow activity. Importance is that this gives a scope of rehabilitation by training the non-involved sites. What is autonomic swallow? It is a swallow that occurs without any conscious effort on the patient's behalf. Example, saliva swallowing during sleep. Brainstem reflex, their involuntary phase. Brainstem acts as a relay station with bilateral representation and interconnections. It houses the sensory nuclei and the motor nuclei of the cranial nerves carrying afferent and efferent information. And there is a brainstem center which controls swallow, that is the central pattern generator or CPG. It has a dorsal group and a ventral group. So the sequence is CPG activation through peripheral afferent, supramedullary inputs and cortical inputs, leading to involuntary reflexes via the cranial nerves. And the whole thing occurs in close relation to the respiratory center in the brainstem. So this is the diagrammatic representation, the centers, the cranial nerves, and their interconnections. The brainstem reflex, once it starts, there are 5 neuromuscular actions occurring in sequence: soft palate closure, tongue-based retraction, pharyngeal contraction, laryngeal elevation and closure, and cricopharyngeal relaxation. The body preparation for swallowing occurs through various centers of hunger, thirst, taste, smell, flavor. They prepare the body for the coordinated swallow. These are located mainly in the area of the hypothalamus and adjoining areas. Importance: we can use taste and smell stimuli therapeutically to stimulate these cortical centers in patients. 5 cranial nerves responsible for swallowing: trigeminal, facial, glossopharyngeal, vagus, and hypoglossal. These are the positions of the cranial nerve nuclei in the brainstem. We need to know to have an idea of the swallow deficiency in different diseases. Now, this is the cranial nerve supply of the various nerves involved, and these are their functions. Now, the coordination and control of by the cranial nerves of the swallow. In the oral preparatory phase, bolus sensation via the trigeminal, saliva formation, chorda tympani, lesser petrosal nerve, mastication, trigeminal is responsible, tongue movement, hypoglossal, bolus containment, facial. In the transition phase, when the bolus is pushed backward, the tongue movements controlled by the hypoglossal, tongue elevation also by hypoglossal, and mylohyoid by the trigeminal. Now, once the bolus crosses the palatoglossal arch, pharyngeal phase is initiated. Proprioceptive receptors are scattered over the tongue-based palatoglossus and palatopharyngeal arches, tonsillar fossa, the posterior pharyngeal wall. Afferent limb is 9, efferent limb is the 9 and 10, pharyngeal plexus. In the pharyngeal phase, the nasopharyngeal closure is carried out by the trigeminal and pharyngeal plexus. Oropharyngeal closure by the pharyngeal plexus and hypoglossal. The pharyngeal action, the pharynx is pulled upward by the 9th and 10th cranial nerves. The pharyngeal phase, laryngeal closure occurs by the vagus, that is a 10th cranial nerve. The laryngeal elevation, 9th and 10th cranial nerve, along with the 5th and 7th. Bolus transit in the pharynx, that is the superior, middle, and the inferior constrictor muscle contraction in sequence, occurs via the pharyngeal plexus. Esophageal phase, which is not our topic of discussion, but the upper esophageal sphincter relaxes and the bolus is pushed downward by the action of the vagus nerve. Now, the neural regulation of respiration for swallowing. Deglutition apnea. A respiratory center of medulla is directly inhibited by swallowing center for the brief period of time it takes to swallow. This swallow apnea takes place at the middle of expiration. When expiration is occurring, deglutition apnea occurs, and then the food is swallowed, and then the rest of the air is expired, and this helps in clearing of the upper larynx from any bolus remnant. Clinical significance: patients with compromised lung function will develop respiratory distress as meal progresses. Also, swallow breathing incoordination in certain patients. Now, the clinical implications. This is a compilation of study of various neurogenic disorders along with their dysphagia prevalence. Like in stroke, in acute phases, 65% cases, they gradually improve over a period of 3 weeks of time. In late cases, we will find 23% cases with dysphagia. Traumatic brain injury, 25 to 61%, cervical spine injury, 50%, Alzheimer's, 32 to 84%, Parkinson's, 50 to 63%, progressive supranuclear palsy, 16 to 83%, multiple sclerosis, 34%. And it is seen that in amyotrophic lateral sclerosis, almost 100% patients may have dysphagia prevalence. This is another chart showing that cognitive impairment, when it occurs, affects the primitive oral reflexes and poor monitoring of bolus size. When there's a movement disorder, there is problem in self-feeding, poor bolus propulsion. When there is a reduction in strength, reduced bolus pressure and reduced airway protection occurs. When there is a reduced sensation, there may be a silent aspiration. And when there is incoordination, the oral and the pharyngeal phase may be disrupted along with aspiration. Now, in stroke patients, almost 43 to 58% patients have aspiration, of whom 40 to 70% have silent aspiration. Studying the neurophysiology, we now know how cortical and subcortical strokes cause more prolongation of the oral phase and prolonged triggering time of the reflexive swallow, whereas the brainstem strokes cause near normal oral control with difficulty in the pharyngeal phase, with deficits in bolus propulsion through the pharynx, reduction in high laryngeal excursion, pooling in pharynx, vocal fold movements may be affected, and there may be a swallow respiratory incoordination. In Parkinson's disease, there may be difficulty in bolus manipulation, delayed initiation of the pharyngeal swallow, silent aspiration. In Alzheimer's, there may be an oral apraxia, and there may be multiple swallows. In motor neuron disease, difficulty in saliva swallowing, pharyngeal residue, weak laryngeal elevation. In amyotrophic lateral sclerosis, the patient may even be unable to remove food from the spoon, chewing fatigue, poor bolus manipulation, swallow respiratory incoordination, and pharyngeal weakness. My mentors, to whom I'm forever thankful, and this is our swallow team at our clinic, and thank you all for your patient hearing. Thank you.
Hello, everyone. First of all, thank you to the organizers of PHONOCON 22 for allowing me to speak on this platform. I am Dr. Priyam Sharma, and I'm going to talk on the principles of swallowing these exercises and maneuvers. So let's get started. First of all, we are going to talk about the indirect swallowing therapy. So this is basically, we want to strengthen the voluntary muscles used in the phases of swallowing. And this is to be done when the patient is not exactly having the food. So first of all, we start with the most basic one of them all, that is the oral motor exercises. So what we are trying to do is to increase the patient's volitional control over the lips, tongues, and vocal fold. Also, most of these exercises are actually derived from the speech therapy. So if the patient is already having speech therapy for dysarthria, then this is also going to help with the swallowing of the patient as well. Also, we want to maximize the bolus transit into the oropharynx in this patient. Since this is a very exhaustive list, I'm limiting myself to the illustrations and figures now. Moving on, we have tongue and mandible exercises. So this is basically a range of motion exercises. As you can see, the tongue is made to go up and down and left and right. Sometimes use of resistance is required for giving it a more strong approach. We also have mandible opening exercise, jaw opening exercise. We can use resistance against opening to give it again a better approach. Very useful in patients who have limited mouth opening, whether it is due to disease per se, post-radiotherapy or post-surgery patients. We are now coming to the vocal fold closure and laryngeal elevation exercises. Now, the importance of proper vocal fold closure in swallowing cannot be overemphasized. And this is what makes the pharyngeal phase of swallowing so important among all the phases of swallowing, because we are dealing with the issue of airway safety. So the patient, again, this is mostly voice therapy. One is practicing coughing by the patient. The patient can increase loudness of the voice and produce sustained phonation at various pitches. Nowadays, a new treatment modality is coming up big time. That is Lee Silverman voice treatment. Most of our SLP friends will be very familiar with that. And this is basically, again, phonation practice at various pitches for a longer duration of time. Now we have thermal stimulation. So when do we give thermal stimulation? When the patient is having decreased pharyngeal sensations. Most of them are post-stroke, post-CVA patients. And because the pharyngeal sensation is reduced, it is obviously going to delay the onset of swallowing reflex. So what do? We use a cold probe. And in clinical practice, we most commonly use the laryngeal mirror. So what do? We dip the laryngeal mirror in ice, and we lightly stroke the anterior pillar, the fosses, with the laryngeal mirror to gradually increase the sensation of the pharynx in the days to come. Now we come to one of the most commonly employed exercises in the indirect swallowing therapy. That is the head raising exercise, the exercise shaker exercise. So what are we trying to do? In which patients we try to do? So the patients who are qualifying for this exercise are the patient with a diminished upper esophageal sphincter opening. Now, how do we diagnose it? Most commonly in the endoscopy or in video fluoroscopy, there is some amount of residue in the piriform sinuses. And this is happening because the hyolaryngeal elevation is not properly doing. The muscles which are responsible for hyolaryngeal elevation, like suprahyolaryngeal elevators, thyrohyoid, mylohyoid, the digastric muscles, these are the muscles that we want to strengthen using this exercise. So how do we do it? The patient lies down on a bed, asks to raise his head up for about 1 minute. If the patient is not able to do it for 1 minute, any length they can endure it for is good enough. Only important point is that the shoulder should not be off the bed, because then it becomes a crunch exercise and we don't want that. So that is the shaker exercise. Now we come to the next maneuver, that is the Masako maneuver. So first we'll see how this maneuver is done. So the patient is lightly biting the tongue between the two incisor teeth while performing dry swallows with the saliva. So why, in which patients we do it? In patients with very weak pharyngeal function, where the muscle contraction is not good enough to propel the bolus further down the pharynx. Now at rest, you can see the base of tongue is here and pharyngeal wall is here, and they have to meet at the peak of swallowing for the bolus can go downward. But while we are doing Masako maneuver, as you can see, the base of tongue goes a bit anteriorly. So now the pharyngeal constrictor muscle has to do more work to meet the base of tongue. And as a result, over time, their ability to contract becomes better. Now we come to the direct swallowing therapy. So what is direct swallowing therapy? Now the patient has to do the therapy while he or she is actually having food. So there are some maneuvers, there are some postures. Let's start this. First of all, again, supraglottic swallow is one of the most common maneuvers that we apply in this category of patient. So what do? We can see the video first. I'm taking a brief breath first. I'm holding the breath. I'm having water, sip of water, swallowing it. And at the end, I just gave a voluntary cough. So first, deep breath, holding breath, swallow the food, and voluntary cough. So what is the basis for doing this swallow? We want to put out any residue that might have gone into the laryngeal vestibule at the end of the swallow. So a voluntary cough at the end is a must. Another variation of this is supraglottic swallow. So what we do, while we are holding down the breath in the second part, we just ask the patient to bear down a bit, give force a bit. So what it helps us to do is to close the vocal fold even more strongly, and posterior glottic gap is also lessened in this maneuver. And now we are coming to a forkful swallow. So a forkful swallow is basically simply a pharyngeal squeeze, the normal swallow, but with an additional squeeze. So the patient has to swallow hard, the lips are tightly closed, and patient has to push the tongue against the hard palate nicely. And some amount of the effort that the patient is doing should be visible from the outer neck as well. The patients who have difficulty in following multiple understand and children, these are the ones where we want to give effort for swallow the most. Now we come to Mendelssohn maneuver. So again, when we do it in patients who have decreased upper esophageal sphincter opening, because laryngeal elevation is not good enough in this patient. So what we do, we'll come to the video. First, the patient is asked to do some amount of dry swallows and asked to feel the thyroid prominence going up and down during the swallow. And at the peak of swallow, when the thyroid prominence goes up, he is instructed to lift up the larynx for a few seconds, just for a few seconds when the peak of swallow is happening. So when you lift up the larynx for a few seconds, you are practically opening the upper esophageal sphincter for a bit. So that allows whatever residue of food is there in the pyriform sinus to go smoothly into the esophagus. Now we come to the swallow postures, one of the most commonly used, one of the most effective also when we come to swallowing therapy. So we start off with the first one, the chin tuck posture. So what the patient has to do is to touch the chin as much close to the sternum as possible, as you can see. And what this posture does for us, it pushes the anterior wall of pharynx backward and it narrows the laryngeal airway entrance. So whatever food it blows from the mouth, it has less chances of directly dropping into the larynx, causing penetration or aspiration. Head bag is used in patients who have very bad oral transit. The tongue is not working properly. So we want to use the gravity for pushing the bolus further into the oropharynx. And then we ask the patient to put the head back maneuver. This is head turned to one side. So this is done when one part of the larynx is not functioning. So whether it is vocal fold paralysis on one side or the other side. So the patient, if he is having a left vocal cord palsy, the left side of larynx is not functioning properly, we ask the patient to turn the head to one side and have the food. So this is how we do it. So what it does in the endoscopic findings, as you can see, this is the right pyriform sinus, this is the left pyriform sinus. And when the patient is turning the head to left, the left PFS is a bit obliterated, its caliber is less, and the right pyriform sinus is bigger. So what it does, it allows the food to go through the better PFS, the bigger PFS. Because if it goes through the smaller PFS, more amount of penetration is going to happen. We'll come to the next slide as well, where the head turn is to the right side. So if we want the bolus to go from the left side, we ask the patient to turn his right head to the right. So the food preferentially goes to the left PFS and the right PFS is bit spared. We'll come to a photographic comparison of head positions in different situations. The first one is at rest when both the PFS are of the same caliber head rotated to the right. So if the patient is having right vocal fold palsy, most of the food will now go to the left piriform sinus. And the right PFS is a bit obliterated. Again, if the patient is having left vocal fold palsy, we don't want the food to go through the left piriform sinus because the vocal fold is not acting very nicely during swallowing. We want the food to go through the right piriform sinus, which is bigger when you turn the head to the left. So head turn to the same side when you have a vocal fold palsy. We can also combine these two, chin down and head turn, to give it a better approach against penetration and aspiration. So my take home message is that for clinicians, our understanding of the exercises and maneuvers is a must so that we can give the correct combination to the patient. And most of the patients, they actually do require a combination of therapies. But we should also keep in mind that whether it is feasible for them to continue with the therapy for a few weeks or months, because most of the therapy techniques, they don't get improved in 1 day or two. Usually weeks or months are required. So proper patient and family counseling is a must. Also, regular follow-up should be done because we want to know whether our maneuvers and postures are actually working good for the patient. So thank you so much for having me here. I'll wind up a presentation. Thank you so much.
Good afternoon, everyone. First, let me thank the organizers for giving me this opportunity to speak this platform. My topic is challenges in diagnosis of pediatric dysphagia. Now, let me move on to the topic. Feeding is one of the primary functions necessary for survival. The children with pediatric dysphagia are one of the most challenging group of patients to diagnose and treat because of the variable manifestations and etiology. So based on the primary etiology, it may be divided into neurological causes, anatomical abnormalities, genetic conditions, suck-swallow breath incoordination, and others like gastroesophageal reflux and idiopathic cases. So neurological conditions may be an immaturity or a delay or a defect. Anatomical abnormalities include laryngotracheal cleft, vocal cord palsy, tracheoesophageal fistula, etc. Certain genetic conditions or syndromes cause dysphagia. For example, Dijot and Down syndrome. Suck-swallow breath incoordination is seen mostly in prematurity and disorders affecting the in cardiac conditions and the pulmonological disorders. So in 50% of cases, there are multiple comorbidities, and in 90% of them, at least there is at least one comorbidity. Dysphagia can manifest in patients with no comorbidities also. So there are several factors influencing the outcome in addition to the basic pathology. Those are the patient characteristics, like the severity of dysphagia, then age and timing of exposure to oral feeds, especially during critical periods for feeding skill development. Then environmental factors also play a major role, like nutritional and other interventions. So the final outcome is a combination of motor, sensory, and behavioral disorders. And the evaluation of sensory and behavioral disorders play a major role in pediatric dysphagia evaluation, unlike in adult patients. So the reasons for referral can be poor feeding or sucking and failure to thrive. So we are expected to provide answers. Is it due to dysphagia, or what's the severity? Is it safe to continue or start oral feeding? Is dysphagia the cause for recurrent chest infections or accountable for the present lung condition? Or is it dysphagia or reflux? These symptoms may not always be due to dysphagia. For example, poor feeding or sucking can be a manifestation of generalized hypotonia or an underlying neuromuscular disorder. So it's important to get a detailed history and evaluation. So history should be meticulous, includes birth history, the development, the feeding experience, the medical and surgical interventions, etc. Clinical feeding assessment includes a pre-feeding observation, for example, the assessment of the tone, the oral sensory motor skills, and then proceed to oral feeding evaluation. In indicated cases, proceed to instrumental evaluation. A multidisciplinary discussion plays a major role in getting to the core of the problem and tackling it more effectively. So this is a 1-month-old, primarily referred for evaluation of stridor with normal perinatal history. It was an oral feeds, but they reported a difficulty in sucking and failure to thrive, which they attributed to stridor. So on examination, there was inspiratory stridor, which was aggravated by feeding, but there was, we noticed dysfunctional sucking, which is an indicator for an underlying dysphagia. So instrumental assessment included airway endoscopy and FEES, as well as video fluoroscopy. So prolapse of arytenoids into the airway was noted, which is mainly responsible for the airway symptoms, in addition to the reduced tone. And there was a significant delay in swallow reflex with residue and aspiration. So video fluoroscopy confirmed the findings. There was significant oral and pharyngeal stage dysmotility. So this was primarily a case of oropharyngeal dysphagia rather than an airway problem. So should be aware that infants mostly present with respiratory symptoms when they are actually suffering from dysphagia. So these are two abnormal sucking patterns. One is a disorganized suck, which is commonly seen in immaturity, like preterm babies or children with cardiac or pulmonary conditions. So most often it is a feeble, ineffective sucking with interruptions for breathing. So this is a dysfunctional sucking pattern, which is commonly seen with neurological disorders. There are no clear guidelines for diagnosing aspiration or predicting the safety of oral feeding in children. The clinical evaluation has a low accuracy when compared to adults because of the high prevalence of silent aspiration. And there are no standard clinical evaluation protocols. Every institution follows its own based on their individual experience and teaching. Besides, instrumental evaluation is inaccessible to most centers due to lack of infrastructure or trained clinicians. So these are the investigations that can be used for aspiration. Some are direct tests for aspiration, while there are indirect tests for retrospective evidence of aspiration. So video fluoroscopy is the gold standard, like in adults, but fiber optic endoscopic evaluation has similar accuracy to video fluoroscopy in adults, but not in children because of the low sensitivity for aspiration. And radionuclide studies like salivagram also have low sensitivity. And it takes a long time for the study to complete. So the indirect tests include the chest X-ray, which has a low sensitivity and specificity. CT chest is sensitive for early lung damage, but has a low specificity for aspiration. Similarly, diagnosis of reflux is another controversial area. Most institutions diagnose and treat reflux on empirical evidence. The gold standard for diagnosis is the combined multi-channel impedance and pH metry. Unfortunately, it's not available in most of the centers. The other test for reflux are the barium swallow, which is very low sensitivity. So unless there is a severe reflux, it will not be seen in barium swallow. And then the radionuclear studies similarly has a low sensitivity. Then pH metry detects only acidic refluxates, and manometry only liquid refluxates are picked up, but not the gaseous reflux. Endoscopy is an indirect evidence, gives indirect evidence for aspiration and is a low sensitivity. Bronchoalveolar lavage is sensitive but has a low specificity for aspiration. This is another case, 1-month-old infant with feeding difficulty, cough and choking on feeding, nasal regurgitation and recurrent pneumonia, along with failure to thrive. There are no other comorbidities known. Clinical examination showed pool secretions, and on a feeding trial, there was coughing and choking on feeds. So the clinical diagnosis was a tracheoesophageal fistula or a laryngeal tracheal cleft or a vascular ring. But video fluoroscopy gave us an alternate rare diagnosis. There was significant dysfunction of the cricopharyngeal sphincter with pooling and nasopharyngeal reflux. So this was a case of congenital cricopharyngeal achalasia, which is a rare condition and often presents late because of the rarity. So unless a high index of suspicion is not there, or there is no awareness of this condition, it can be easily missed. So this is usually seen in association with other neurological conditions like Arnold-Chiari or cerebral palsy, but it may also be idiopathic. So to conclude, infants with dysphagia may present with respiratory symptoms. A lot of ambiguity remains in diagnosis of aspiration and reflux in children, and clinical feeding evaluation is not reliable for assessing the safety of oral feeds because of the prevalence of silent aspiration in children. Thank you.
Hello, everyone. At the onset, I should like to thank APSI, Dr. Sanjay Subaya, and all the organizing committee members for organizing a superb PHONOCON 2022. To feed or not to feed is basically a decision which can be taken with the help of certain predictors and pointers. So we are just going to see about it. Dysphagia can be oropharyngeal dysphagia or esophageal dysphagia. When you talk about oropharyngeal dysphagia, stroke, Parkinson's, motor neuron diseases form a part of it, which are a neurogenic dysphagia. So post-stroke dysphagia is mainly oropharyngeal. So today we won't be looking into the esophageal dysphagia. History taking and bedside assessment forms a very extremely important role in diagnosis. So oropharyngeal dysphagia starts from the oral cavity till the upper esophageal sphincter. So these are the things which you can see in bedside swab assessment. What are the causes typically of neurological dysphagia? Stroke, Parkinson's disease, myasthenia gravis, multiple sclerosis, amyotrophic lateral sclerosis, motor neuron disease, and dementia. Today, we are going to focus only on stroke because our topic is concerned with it. So let's go to the statistics when we are thinking about dysphagia and stroke. 50% of acute stroke patients suffer from dysphagia, out of which 11 to 13% remain dysphagic for 6 months. Mortality is higher in stroke survivors with dysphagia and affects the length of hospitalization. It also affects the quality of life because the person who is on feeding from Riles tube or with the help of PEG is not comfortable in socializing, and therefore it definitely affects, and the patient can go into depression or any psychological issue. 41% of patients suffer from anxiety attacks in spite of being treated and can eat orally. Decision making. Like I said, we need to reach to a diagnosis or a decision of feeding the patient orally only with the help of certain parameters and predictors. To make it simple, we have to create a protocol or a SOP and follow it to the T. Diagnosis, by which I mean that we should know what is a problem with the oropharyngeal part of swallowing. Depending on what the problem is, we reach to a treatment protocol and assess the results. The treatment protocol should include airway protection, which is the most important part, followed by nutrition, which the patient should get a complete balanced diet. Cognitive assessment is also a very important part of treating dysphagia, because it plays a very important role in predicting swallowing regeneration and survival in neurorehab. What are the predictors of aspiration? Dysphagia is an under-recognized complication of stroke. Bedside assessment is important, and these are the predictors which we use in bedside assessment. Gag, where the patient gags on the food, cough during oral feeding, history of pneumonia, change in voice, which is a gurgly, wet voice, velopharyngeal refluxes, impaired pharyngeal safety, and silent aspirations. This is a checklist for identifying the swallowing problems, which I have already explained, and that can be used while assessing the patient. After we do a bedside assessment, we have to we have a protocol to see where the patient fits in. If there are less than two clinical predictors of aspiration, oral feeding is started with the help of a swallowing therapist, and then it is reassessed again how the patient is doing, whether there are any complications which are happening. If there are more than two clinical predictors of aspiration, we do perform a VFSS or FEES. If there's no dysphagia or aspiration, we go ahead and start the patient on oral feeding and continue it till we find and assess it regularly. If there is aspiration or dysphagia on VFSS or FEES, we initiate a treatment. We form a treatment plan, and dysphagia diet recommendations are given, and the patient is again reassessed. So when we talk about diagnosis, we have been talking about diagnosis continuously. So diagnosis can be done with the help of functional endoscopic evaluation of swallowing, dynamic swallowing study, which is a form of part of VFSS, esophagram, which is again a part of VFSS, but we are not going to talk about it much because esophagus is not involved in post-stroke dysphagia, and pH manometry if required to check the pressure at the upper esophageal sphincter. If pH manometry is not available, it is not necessary that we need it to diagnose a cricopharyngeal spasm. When we talk about FEES has created a paradigm shift in the management of dysphagia for a laryngologist. The procedure can be performed in the clinic or by the bedside of the patient. And most of the studies have found that it is equivalent of VFS, if not better. So for me, FEES is a choice of evaluation because it is easy to use. It can be done in the clinic or by the bedside of the patient. It is economic and it is well tolerated. 4 exceedingly important pointers what we have to gather from a FEES is whether there is delay in swallowing initiation. So we observe whether there is spillage. If there is pharyngeal residue, which suggests that there is pharyngeal weakness, or if there is valvular residue, which suggests there is pharyngeal weakness, whether there is piriform residue, again, which can suggest of CP spasm or pharyngeal weakness, and laryngeal penetration, whether Food doesn't enter the larynx directly, but it can go up to the vocal folds. And aspiration, where there is direct entry of the food into the airway. There are distant consequences. Some are common, some are very uncommon. So the common one are discomfort, gagging, vomiting sometimes. The uncommon are vasovagal epistaxis and mucosal trauma. Fees is done with the help of an assistant. So the assistant mixes the food with a color which is contrast of the mucosa. It is of different consistency. So what food we use is a fruit puree, we use water, and we use Marie or glucose biscuits. The scope is at the level of the palate initially. After you pass through it, you see the movement of the base. You see the base of tongue, the palate, the vallecula, the epiglottis. Then you take it near to the laryngeal agitus. You see the movements of the vocal folds, and then you ask the assistant to feed the patient. And then you can see whether there is collection at the vallecular level, whether there is pharyngeal residue, whether there is piriform residue, whether there is spillage. And you can also do a sensory test by pushing air at the arytenoids, and then if the patient coughs or not. It can also be used to check the therapeutic maneuvers which can benefit the patient while swallowing. So this is a very important use of fees. This is a video of a patient who is a 60-year-old man who suffered from This is a video of a man who suffered from hemorrhagic stroke. And you can see that there is no evidence of swallowing effort, but there is spillage. This is a video of a 30-year-old male, only patient visiting me in the OPD with only RT. There are no other deficits with a medullary stroke. You can see that there is collection at the cricopharyngeal level and at the piriform fossa. This is a patient of cricopharyngeal spasm. Pharyngeal residue, this is a patient who had a lot of pharyngeal residue in spite complete pharyngeal weakness, in residue at the vallecular level as well. The vocal folds are moving, but there's no aspiration. There's a video of aspiration where you can see that there is trickle into the trachea, there is penetration. So this is clear cut, not a case to feed orally. Coming to VFS, it tells you the entire swallowing anatomy. Better delineation of the base of the tongue versus the pharyngeal constrictor muscle contraction. Then you can tell about the head elevation. You can say there's no white out face, so you're not blinded by anything. The function of the UVS can be seen, and the cervical esophageal phase of swallowing can be assessed. Aspiration, this is a video where you can see that there is a frank aspiration where the food is entering into the larynx. This is a case of valopharyngeal reflux where you can see that there is a nasopharyngeal regurg of the barium with the food. This VFS is to show you that there is collection at the level of the vallecula. There is pharyngeal residue. The patient is able to swallow, but he requires 2-3 swallows to happen. There's no aspiration. So the management strategies should depend on these pointers. First and foremost, airway protection is the most important thing. We see to it that there is no aspiration occurring. Even the swallowing therapist, while giving the therapy, should be careful and see to it that there is no aspiration or silent aspiration whatsoever. Dysphagia diet is a custom-made diet for the patient, depending on what they tolerate, and what is required for their nutrition. So nutritional monitoring comes with it. As we have spoken about cognition, so cognition is very important if we are going to feed the patient orally. These are the few incidences where you get dysphagia, you get aspiration because of the trauma or any other reason, which can be treated. So this was intubation trauma. There was a vocal fold palsy, and so the patient was aspirating. We injected and then followed by therapy, and the patient till date, this was in July 2021, and the patient is still completely fine. This again post laryngotracheal intubation where the patient has developed a palsy and aspiration. So we have injected, we've done an injection laryngoplasty for the same, followed by a therapy, and the patient has she was not improving with just swallowing therapy, and therefore we injected and she's completely fine with it. This is again an injection laryngoplasty through the bronchoscope channel. This is the same 30-year-old boy which we saw with cricopharyngeal spasm, and then we injected Botox, and you can see that he's able to swallow completely. If the Botox doesn't work, then we need to do cricopharyngeal myotomy, and this is basically endoscopic myotomy. So what are the negative predictors? Age above 52 years, bilateral stroke, aspiration on BFS, level of cognitive function on admission is very important. Lower functional independent measure on discharge. So if the functional, lower the score, bad is the prognosis. If the score is 1, that means the patient is totally dependent. If the score is 7, that means the patient is totally independent. Longer hospital stay is also a bad prognostic criteria, and frequent malnutrition. Development of screening protocols in dysphagia is a key step in early identification of the patient at high risk for aspiration and consequences of dysphagia like malnutrition. Early detection and treatment is very important. NG tube as soon as possible because it reduces the mortality, whereas if the patient goes on PEG, it increases the mortality. Bedside swallowing assessment followed by FEES and or VFS. Start feeding only if the airway protection is achieved. Swallowing therapy forms the most important part for dysphagia treatment. Intervention as and when required, and dysphagia diet, which is custom made for each patient. So it is very important to see your patient smile when they see the food, because food is an emotion and we must see to it that the patient smile. Thank you very much.
Good afternoon. I am Dr. Vidyadharan Sivakumar. I will be talking on surgical deglutology, the clinical implications and future perspective. There are a number of surgical procedures which can be used to improve swallowing in dysphagic patients. And most patients, the conservative swallowing therapy is usually sufficient. But some patients with intractable aspiration may require surgical intervention. And this talk will describe the various procedures in brief and the appropriate application to selected dysphagic patients. Oropharyngeal dysphagia affects any 3 phases of swallowing and results in dysphagia, aspiration, or both. The best way to help dysphagic patients is by a multidisciplinary team approach, which I'm sure many speakers have told this in the previous talks. The general indication for surgical management is failure of rehabilitation therapy, or concern for life-threatening aspiration, or long-term requirement for supplemental feeding or tube dependence. However, few disease state-specific surgical treatment exists, for example, with regards to pharyngeal pouch. One of the earliest described procedure to help with swallowing is depicted here. This is an extra thoracic rubber esophagus, which has replaced the normal one. And this is the way they were trying to manage and help out dysphagic patients in the past. Most of the pictures and videos that I'll be showing in this talk are from during the time that I worked in these two institutes. And this is a team I used to work with, and I'm still an adjunct faculty at Amrita Institute. I chose to classify surgical deglutology into two types, phagosurgery and oncophagosurgery. Phagosurgery is retrieving or augmenting swallowing function when therapy maneuvers and strategies fail. In general, surgical treatment of swallowing disorder may aim to improve the sphincteric mechanism of the velopalatine, glottic, or upper easophageal sphincter to improve propulsive force or to reduce intra or extraluminal obstruction. This term was coined by Professor Jacob Menon in 2016. Now, phagosurgery is a subspecialized field. Most causes of dysphagia do not require surgical intervention to accomplish the goals of safety and satisfactory quality of life. However, some entities warrant surgery to treat a specific problem or augment the therapeutic management. Hence, the concept of phagosurgery came to being, which is akin to phonosurgery. The objectives of phagosurgery is to protect the airway, relieve dysphagia, and provide alimentation by either correcting the anatomical problem or bypassing the affected steps in deglutition. I have included 17 procedures under this, and some of these procedures are office-based, while the others are more complex, requiring general anesthesia. What we want to do is to avoid posterior cricoarytenoid myelitis, which is mainly due to prolonged nasogastric tube dependence, and it also indirectly causes cricoarytenoid joint fixity and persistent aspiration. Here are some causes of dysphagia following treatment for head and neck cancer malignancy. It mainly ranges from structural loss, damage or motility and sphincter function, loss of swallowing coordination or loss of motor or sensory innervation, scar formation and fibrosis, or fistula formation and persisting lymphedema. Now, routine phagosurgical procedures work well for dysphagic patients affected by neurological dysfunction. However, head and neck cancer patients requiring surgical rehabilitation for their dysphagia would have undergone curative intent treatment in terms of ablative surgery, reconstruction, radiation, and chemotherapy. So the surgeon who's treating the dysphagia must deal with tissue within different subsites that has been previously violated either by surgery or radiation or by both. So this demands a careful interplay of knowledge and surgical expertise of the laryngologist, head and neck surgical oncologist, and head and neck reconstructive surgeon. So we can say that oncophagosurgery helps head and neck cancer patients to improve the ability for a safe swallow and thereby indirectly improve the quality of life. The decision to perform surgery must not be taken lightly because of morbidity associated with operating on this special group of patients. In general, surgical deglutology procedures can be performed as a prophylactic measure during head and neck surgery or for correction of dysphagia due to structural abnormalities or for dysphagia, correcting dysphagia of neurological origin and as a prospect of surgical deglutology in terms of neurostimulator, reinnervation, and pacing. I will discuss some of the procedures that we do under each heading. Starting with prophylactic measures during surgical treatment for disease of head and neck, one of the common procedures we do is hyolaryngeal suspension. The hyolaryngeal suspension to the mandible is commonly done when the suprahyoid muscles have been resected in oral cancer malignancies, and which is a very common malignancy in India. So post resection of the floor of mouth or suprahyoid muscles, there's a huge defect and there's a high chance of patient to aspirate or have severe dysphagia because the patient does not have a normal hyolaryngeal elevation. To help with this, sutures are usually put and to make the hyolaryngeal suspension. And you can see the sutures depicted here from the mandible to the hyoid bone to the thyroid cartilage. And this is an example of a patient who's undergone a floor of mouth and also a mandibulectomy procedure and reconstructed with a bone flap and had a hyolaryngeal suspended suture. And you can see the very good laryngeal elevation with no chance of aspiration. Another situation is a circumferential defect following total laryngopharyngectomy. In such patients, flap is usually tend to be tubed to reconstruct the defect, circumferential defect. And usually a free flap is used. And in this situation, a salivary bypass tube can be used to reduce the chances of salivary fistula or leak. And this helps in reducing the stricture formation. You can see that once a flap is inset, the salivary bypass tube is within the flap to reduce the chance of fistula. Now, correcting dysphagia due to structural abnormalities. One of the commonest causes of structural abnormalities among head and neck cancer patients is the radiation-associated dysphagia, which can cause edema, fibrosis and scarring, and also denervation. And this chronic fibrosis and scarring can lead to strictures of the hypopharyngeal region, namely postcricoid, and also oropharyngeal and nasopharyngeal areas. Patients usually present with difficulty in swallowing, which is very progressive, more to solid foods, and they have secondary aspiration, associated weight loss and dehydration, and they also have regurgitation of foods and liquids and sensation of something stuck in the chest after eating. In such situations, when the stricture it can be identified through the endoscope, a flexural endoscope, patient can be subjected to endoscopic balloon dilatation. And here are the pre-procedure and post-procedure pictures to show that great improvement in the luminal narrowing. The patient can eat afterwards. This is a picture of endoscopic dilatation of the postcricoid stricture. In case of complete pharyngeal stenosis, esophagoscopy can usually be performed, and patient can also, the stricture could also be localized endoscopically in a retrograde fashion if there's a PEG tube orifice. Once a stenotic or a segment of the severe stricture segment is located, that could be resected out, and that area could be enlarged or resurfaced with a skin-lined muscle flap. Most commonly, we use a pectoralis major myocutaneous flap. And this stenotectomy, you can see the inset and the pharyngeal closure creating the neopharynx. This is a patient who's had a total laryngopharyngectomy and reconstructed with a flap, but still had severe dysphagia due to a stricture within the flap. And you can see the patient really struggling to swallow the food bolus. In such cases, then the only other option is a gastric pull-up, where the stenotic segment is resected and the stomach is pulled into the pharynx, and the anastomosed, and you can see the gastropharyngeal anastomosis being performed. And once that is done, the patient had very good swallowing function, no issues with any food holding up or any residue anywhere else in the neck. If the stomach is not available, then a colonic transposition can be performed. This involves dissecting and mobilizing the left colon and tunneling it into the proximal esophageal remnant or the proximal part of the pharynx. And 3 anastomoses are performed in this procedure: the esophagic colic anastomosis, the enterocolic anastomosis, and then the pharyngocolic anastomosis. And then the transverse colons rejoined to the remaining descending colon. Here's a patient with a stricture due to caustic ingestion, and for a duration of 1 year. You could see the endoscopic picture of the scarred larynx and hypopharynx, with the stricture extending all the way down to the duodenum. And the patient will be in tracheostomy tube and jejunostomy tube dependent for almost a period of years, 1 year. You can see the scarred larynx and the hypopharynx. In this situation, a patient underwent a colopharyngoplasty, where the colon was transposed retrosternally and pulled up into the neck. And you can see the colonic the segment and also the pharyngeal part at the level of the oropharynx. And here the colopharyngoplasty was done. This is, of course, usually done with the help of the surgical gastroenterology team. This is the endoscopic video in the 4th postoperative week, where you can see the reconstructed postcricoid region. It is you can see that the stricture is very high up to the level of the epiglottis. Great pains was taken to preserve both the recurrent nerve and the suprarenal nerve so that the patient doesn't aspirate. And this is the luminal view of the neoesophagus or the colonic conduit in the postcricoid area. You can see the barium swallow, modified barium swallow picture of the whole colonic conduit. You can see the liquid barium traversing down, and this is the barium where there's no aspiration. And over here, you can see the ostrations of the colon with the barium beautifully going down. For correcting dysphagia of neurological origin, there are many neurological conditions associated with oral or pharyngeal and motor dysfunction and dysphagia. And the most common neurological problem is a cricopharyngeal dysfunction, which occurs due to many mechanisms, ranging from issues in the central nervous system all the way down to the cricopharyngeal spasm due to gastroesophageal reflux. And if the patient is refractory to regular swallowing therapy, then the Botox to the cricopharyngeus is tried. And here is a video of the Botox being injected under the EMG guidance. Once the muscle is isolated, Botox is injected. And this is a pre-Botox and the post-Botox modified barium swallow findings, where you can see the patient has high chance of secondary aspiration. And after the Botox injection, the patient is able to swallow freely. If a patient is refractory to Botox, then endoscopic cricopharyngeal myotomy can be performed. In such situations, you can see the barium swallow, you can see the cricopharyngeal bar here. In the postcricoid area, the cricopharyngeal muscle is localized, the mucosa is cut, and myotomy is performed. And myotomy can also be done endoscopically with the help of a laser and also with the robot. And one advantage of doing endoscopic myotomy with the robot is you can also do a myomectomy, where a piece of the muscle is also taken out. External cricopharyngeal myotomy can also be performed by a transcervical approach, where through the neck, the muscle is identified and the muscle is cut. In case of pharyngeal or pulsant diverticulum or the Zenker's diverticulum, same endoscopic procedures can be performed. For a large pouch, transcervically, the pouch could be excised out and the defect can be closed. For glottic insufficiency or vocal cord palsy, or for various different causes, if compensatory maneuvers are ineffective, then either injection laryngoplasty or medialization thyroidplasty with or without arytenoid adduction can be performed. This injection laryngoplasty can also be performed in a transcutaneous method as an office laryngeal procedure, as you can see here in the slide. Here's a video of pre-injection laryngoplasty. On the left-hand side, you can see the large glottic chink, and this is the post-injection. You can see the glottic flap has been corrected. Medialization thyroidplasty, if you want a permanent solution, then is through the celastic block and with or without arytenoid adduction to correct the posterior glottic gap. When you compare all three techniques of thyroplasty, injection, and arytenoid adduction, there's very good resolution of aspiration. For management of intractable aspiration, the treatment of chronic aspiration can be categorized by voice sparing and voice sacrificing techniques depending on reversibility. And tracheostomy is the most commonly performed procedure, and it can allow phonation. And the other procedure is a narrow field laryngectomy, where the larynx is taken out. And you can see here the patient is aspirating a pre-laryngectomy and post-laryngectomy. Because of the separation, there's no chance of aspiration. There are diversion procedures such as laryngotracheal separation and tracheoesophageal diversion can be performed, but these are performed quite rare, and it's usually for patients with aspiration of neurological origin. Epiglottic flap and laryngeal closure is also performed. This is a reversal procedure which can be reverted back once the patient is getting his dysphagia is slowly getting better. Glottic closure is also done for chronic aspiration. Reinnervation and implantable nerve stimulators, these are prospects in surgical deglutology, and laryngeal reinnervation has been associated to improve E10 scores. That is, the dysphagia tends to improve laryngeal innervation for unilateral vocal cord paralysis. And also, neural implants are being under trial for severe and chronic pharyngeal dysphagia among stroke patients and for prevention of dysphagia in head and neck cancer patients undergoing radiation treatment. The neuro process is under patient control and provides intramuscular stimulation to as many as 8 hyolaryngeal muscles. In conclusion, surgical options for swallowing are attempted when non-surgical measures and conservative measures fail. The phagosurgeon can be an important member of the dysphagia rehabilitation team. The role of surgery is well defined for some causes of dysphagia and less well defined for others. The phagosurgery and oncophagosurgery can augment swallowing rehabilitation in swallowing therapy, refractory, neurological, and head and neck cancer patients. But patients also need to continue swallowing rehabilitation after the surgical intervention. And surgical therapy, when indicated, is safe and effective for many causes of dysphagia. Thank you so much.
Before I start my session, I would like to thank APS organizers for giving me an opportunity. My talk is on laryngopharyngeal reflex disorder. It's LPRD in short form. So it was first described by Kaufman in 1991. So it has become a common diagnosis in last 2 decades. And around 10% of the patients in our clinical practices and 50% of patients with voice disorders are found to have LPR. So coming to the definition, it is an extra esophageal variant of a GERD, and it is believed to be caused by retrograde flow of gastric content, especially the pepsin and the acid that affects pharyngeal and laryngeal mucosa, either by direct contact or by secondary mechanism. And LPR and GERD is both are a separate entity in terms of its pathophysiological symptoms wise and manifestation wise. So coming to the pathophysiological differences, GRD, it is mainly the dysfunctions of the lower esophageal sphincter, whereas in LPRD it is both lower esophageal and upper esophageal dysfunctions. And most of the LPRD patients are upright and daytime reflexes, whereas in GRD it is supine and nocturnal. Usually in the night time it will be more. So the other predisposing factors which can contribute to with the above pathophysiological findings, mainly the diet and the NSAIDs, which contribute to the pathophysiology and resulting in severe LPR. So it is a mechanism. If you come to the mechanism, it is mainly the direct contact of the pepsin. So, and here, which I want to highlight here is usually the reflex episode in LPR, it is a gaseous with a small fine aerosol of gastric contents, which contains pepsin, which is a proteolytic enzyme which distracts the laryngeal epithelium. And of course, this slide I skip. And why the laryngeal mucosa is more susceptible to the gastric content is because it is not designated. The mucosa is not designated to withstand the acid, and it has the bicarbonate level is very poor and no peristalsis. That is the reason why the laryngeal mucosa is more susceptible. Whereas the esophagus has esophageal epithelium has got a mucus and aqueous layer with a high bicarbonate contents. And effective peristalsis, which is there in the esophagus, can withstand 50 reflex of episodes per day. Symptoms mainly the laryngopharyngeal, very rarely the pulmonary manifestation. So researchers and clinicians have developed an objective and subjective tool in diagnosis of LPR and to measure the outcome of the treatment. So reflex symptoms index is one such tool which is developed by Kaufman. And these are the symptoms, around the 9 symptoms. This we prepare like a questionnaire and give it to the patient, and the grading is 0 to 5, wherein 0 is a mild and 5 is a severe, and reflex score findings for more than 10 is suspected of LPR. This is one such tool where it will help in severity of the symptoms. And second such tool is the RFI, reflex finding score. For that, laryngeal examination is a must, either by direct, rigid or flexible scopy. Even stroboscopy is also can be used in examination. So another investigation tool which is a gold standard in diagnosis of LPR is the ambulatory 24-hour double probe pH and esophagoscopy. In case if it is associated GRD is also there, you can subject the patient for esophagoscopy. Pepsin test, finding a pepsin, a pharyngeal secretion is definitive of reflex, which is a very cheap and less invasive test. And a reflex finding score, I was telling, another tool which can be used to diagnose the LPR. And for this, laryngoscopic endoscopy, laryngoscopy is very important. And usually these are the findings you usually will find it in LPR patients. To start with pseudosulcus vocalis, and the grading is there, and the ventricular obliteration, erythema, hyperemia. If it is confined only to the arytenoid, it is 2, and if it is entire larynx, then you give a score of 4. Vocal fold edema, similarly vocal fold edema, diffuse laryngeal edema, posterior commissure hypertrophy, the grading is 1 to 4. And tiger striping, this is I will show you that this is a typical finding which you will see in LPR patients. It is nothing but a post-cricoid mucosal edema appearance and a thick endolaryngeal mucus in some patients you find, and the granuloma or granulation, either one-sided or both-sided of the posterior larynx. So before getting into the videos which I have, these are the normal anatomical appearance of the larynx, and of course most of you know the anatomical terms, and I will play you the normal video of how usually it looks. And you can see here the vocal cords, normal vocal cords, and the ventricles clearly seen on both the side, and the posterior glottis, the arytenoids, and the post-cricoid mucosa, which appears almost normal. This is the normal video, how usually it looks in a laryngoscopic examination. And I have some videos of laryngoscopic findings of patients. And all these patients with the treatment have improved after the treatment. And a 70 years female. This is the reflex, reflex symptoms score of a 13. And these patients presented with hoarseness and constant clearing of throat, and some you can see here the pseudosulcus and the diffuse edema, mild of the entire larynx, and the vocal cord is also mild edema, you can see. And erythema, vocal fold edema, you can see here. And tiger striping, I was telling you the tiger striping here. See, this is the retro post-cricoid mucosa. I will play once again. You can see the tiger striping here. So rest of the thing, posterior commissure hypertrophy is also there. And this is the video you can see. And this is the tiger stripe appearing of the post-cricoid mucosa. And this is the score. Ventricular obliteration was there, 4. You can see the ventricle is completely obliterated. Vocal fold edema was there. Pseudosulcus vocalis, a score of 2. And a tiger striping, which I told this is that was the total reflex finding score of 16. So this is one such patient. And the second patient, 48 years male, present with the symptoms of hoarseness, grading 3 with constant clearing of throat, and occasionally choking episode was there. Rest of the things, of course, are free of the same symptoms of previous patient, but RSI score of 15 here. And this is the video, and these are the reflex finding score. Pseudosulcus was there, ventricular obliteration, it was partial. Arytenoid, the erythemas, the edema is confined only to the arytenoids here. Vocal fold edema is also mild to moderate, it was there. And posterior commissure hypertrophy was there. Let us see the video. This is the stroboscopy of the patient. Here you can see the again pseudosulcus, vocal fold edema, obliteration of the ventricles. See the ventricles obliterated, and this is the posterior commissure hypertrophy. Next patient. This is the video. Next is 52 years of patient with hoarseness of voice. Again, these patients had vocal obliteration, ventricular obliteration, and a pseudosulcus was there present in this patient, mild vocal fold edema, and a posterior commissure hypertrophy you can see here, and a thick endolaryngeal mucosa. I will show you in the video, and this is the video. You can see here, posterior commissure hypertrophy, obliteration of the ventricle. See the thick mucosa here, or the endolaryngeal mucus, thick mucus you can see here. So the reflex finding score of 11. Here you can give a, and here this is one of the video, and this is one of the patient with this is the reflex finding score of 11. There was vocal fold edema, complete obliteration. This video, especially which I want to show here, is the complete obliteration of the ventricle. You can see the ventricles not at all visible. So it is complete obliteration of the ventricle. And another typical findings is the thick endolaryngeal mucosa. You can see the posterior here. This is the thick endolaryngeal mucosa. It is almost like a laryngitis sicca, we call it as. So this is finding of one of the patient. And lastly, this one more patient, 39 years of patient. The typical findings, apart from other laryngeal symptoms, it was the pain in the throat in this patient. And of course, cough and change in voice. And this is the reflex finding score of 13. And of course, the ventricular obliteration, I will show you the video, you can see clearly. This is the granuloma in the left posterior glottis. And here, I just wanted to tell you the tiger striping appearance also in this patient. So, you can see here the tiger striping appearing in the post-cricoid mucosa, granuloma, posterior commissure hypertrophy, mild vocal fold edema, and the obliteration of the ventricle. Partial obliteration of the ventricle was also there in this patient. So it is again here reflex finding score of 30. And these are the some of the videos which I would like to show. And coming to the management, so treatment is, it is not only the pharmacotherapy, it involves mainly treatment is a combination. It's a combination of all this lifestyle modification, dietary modification, and a pharmacotherapy. Very rarely surgical indication is required. And when you come to the behavioral modification, which is a most essential part in your treatment. So simple elevation of the head end of the bed, and small frequent meals. Avoid meals 3 hours before bedtime. Last meal should be taken 3 hours before bedtime, and these are the dietary modification, which is very, very essential, which decreases the gastric irritant. These are the gastric irritants, especially the acidic foods and the fatty foods. Coming to the medical, I think most of you are aware of about the PPI. The most PPI is the most effective drug, which usually helpful in LPR. And of course, the H2 antagonist only if the those who cannot tolerate PPI, and the antacids, particularly the preparation, the alginate preparation, which has been found to be very effective, especially in the LPR. And to conclude, LPR and the GR both are different. Please use a questionnaire for the reflex symptom index, and a laryngoscopic examination is a mark for RFS score. Endoscopic examination is must, and the treatment, 50% of your treatment is mainly the lifestyle changes and behavioral modification and the diet. So with this concludatory note, I will conclude my session. Thank you.
Thank you, sir. We come to the conclusion of the session on swallowing with talks that have truly been eye-openers for the young and budding ENT practitioners out there. We wholeheartedly thank all the speakers for taking time off from their busy schedule to instill us with knowledge that they have honed over years of experience. We will now have the second and final set of presentations for the Rising Star Award, followed by the valedictory function, where results of the paper and poster presentations will be announced by the President of APSI, Dr. Amitabh Roy Chaudhary, sir.
Hello, I'm Dr. Sai Belsare, and I'll be presenting my study, which I have done with our speech pathologist on the topic, conservative management of vocal cord nodules, our experience. Hoarseness of voice is one of the common symptoms amongst patients visiting the ENT outpatient department. Vocal nodule is a benign laryngeal lesion mainly caused by vocal abuse, which accounts for 12% of the patients presenting with hoarseness of voice. If vocal nodules are diagnosed early, conservative management in form of voice rest, vocal hygiene, and medical treatment can lead to complete regression of nodules and complete relief from the symptoms. Conservative management still has a role in patients where diagnosis is done late and fibrosis has set in to form hard nodules. In these patients, conservative management helps to give some symptomatic relief, gain confidence of the patient, and avoids recurrence after microlaryngeal surgery. 18 such patients presenting to ENT OPD diagnosed with vocal nodules were included in this study to find the benefit of conservative treatment, which showed us satisfactory results. The aim of the study was to evaluate the role of conservative management in patients with vocal nodules. The objectives were to evaluate patients with vocal nodules by perceptual, acoustic, and instrumental assessment, to identify the role of conservative management in patients with vocal nodules, and to identify the optimum time for conservative management before surgical intervention in some of these patients. The study was conducted at our center from January 2021 to January 2022. All the patients complaining of hoarseness of voice for more than 15 days were subjected to a detailed history, thorough ENT checkup, followed by a video stroboscopic examination. As we can see in this, there are early vocal cord nodules bilaterally. A total of 18 patients diagnosed with vocal cord nodules were included in the study after a written and informed consent. Perceptual voice assessment was done using GRABA scale, and acoustic assessment was done using the Pratt software. Patients between 9 years to 65 years diagnosed with nodules who were willing for scopy and evaluation on day 0, 1 month, and 3 months were included. Patients with vocal nodules along with other laryngeal lesions, those whose professions were not permitting voice rest, and patients not cooperative for repeated evaluation were excluded. Conservative management in form of voice rest, vocal retraining, and vocal hygiene and medication was started. Medication in form of proton pump inhibitors as anti-reflux treatment was given for a minimum of 3 to 4 weeks. Antihistaminic medication for patients with allergic complaints along with a short course of systemic steroids was started for some patients. In our study, 14 patients were female and 4 were male amongst 18. A maximum age group was between 41 to 50 years of age, with the youngest being 9 years and the oldest being 56 years. Vocal abuse is closely associated with certain professions. Surprisingly, in our study, housewives and hawkers outnumbered the singers and teachers. Majority of the patients who presented with vocal nodules had symptoms for 2 to 3 months only. However, we had few patients with symptoms longer than 1 year. As we can see in this video stroboscopy, at day 0, bilateral early vocal nodules are seen. At 1 month after starting conservative therapy, there is regression of these nodules. And at 3 months, absolutely normal vocal folds are seen. 10 out of the 18 patients showed significant improvement at the end of 1 month, and complete regression was seen at 3 months. In 3 patients, the vocal nodules reduced in size at the end of 3 months, however, did not completely regress. In 5 patients, there was no significant change in the size of nodules, even at the end of 3 months of conservative management. Now coming to Graba scale, the grade of hoarseness and roughness dropped from 3 to 0 in 7 of 18 patients within 3 months of conservative treatment. Breathiness, which was seen only in 1 patient, reduced to 0 within a month. Asthenia, along with strain, dropped to 0 from 3 in 10 out of the 18 patients that were evaluated. The results were analyzed using the ANOVA test, which revealed statistically significant improvement in 13 out of the 18 patients. Acoustic evaluation was done using the Pratt software. At the end of 3 months of conservative management, harmonic to noise ratio increased to 20 decibels and above, which is within the normal range in 10 patients. Jitter, shimmer, and the mean fundamental frequency improved to normal range in 10 patients out of 18. Partial improvement was seen in 3 patients, and no change was seen in 5 patients at the end of 3 months of therapy. The statistical evaluation of these values was done using the Friedman's test, and it was statistically significant in 13 patients. Vocal nodule is a benign laryngeal lesion caused by degeneration of lamina propria with fibrosis and edema. Along with it, there is also myxoid, fibrinoid, angiomatous, and hyaline degeneration. A study by Arnold has distinguished between acute and chronic nodules. The former have normal squamous epithelium along with edematostroma, thin-walled blood vessels, loose fibrous tissue, and lymphocyte. The chronic nodules show a thickened epithelium along with acanthosis, keratosis, parakeratosis, compact fibrosis, and minimal edema. Vocal nodules can be treated either by conservative technique or by surgery. As per previous studies, if exacerbating factors such as infection, allergy, and reflux are treated by medical intervention, a study by Murray et al. Has shown that conservative management is effective in 60 to 71% of the cases. Vocal hygiene measures, abuse reduction, and vocal retraining, along with lifestyle modification, has a significant role in conservative management. Our study has shown complete resolution of vocal nodules on video stroboscopy in 55% of the patients. Partial resolution was seen in 16% of the cases, which is comparable to a similar study by Benninger et al., which has shown resolution of vocal nodules in 69 to 84% of the cases. In our study, statistically significant improvement was seen on Graba scale in 72% of the cases at the end of 3 months, which is comparable to a study by Johnson. The acoustic assessment has improved in 66% of the cases, which is also comparable with a study by Boschier. Conservative management in form of vocal hygiene, medical treatment, and speech therapy is effective in early nodules. Improvement in all three parameters, that is perceptual, instrumental, acoustic assessment at the end of 1 month, usually reflects complete regression of the nodules at the end of 3 months. And surgical intervention is usually required if diagnosis is made after 6 months of onset of symptoms. Thank you.
Hello everyone, I'm Dr. Sanchaya Dhawde. My presentation number is RS14 and topic of my presentation is rigid stroboscopy versus microlaryngoscopy for evaluation of benign glottic lesion. So let's see what is stroboscopy. Stroboscopy is a diagnostic office examination. It allows real-time assessment of glottal closure and mucosal pliability during phonation, whereas microlaryngoscopy is performed in operation theatre under general anesthesia. But microlaryngoscopy provides superior imaging through stereoscopic magnification, and it also allows palpation of glottic tissue. These are various benign vocal fold lesions such as sulcus, cyst, hemorrhagic cyst, polyp, and granulation tissue. Aims and objective. Aims and objective of my study is to study and compare the rigid stroboscopic finding and microlaryngoscopic findings of benign glottic lesion. My study was performed in tertiary care teaching hospital. It was retrospective type of study. It included 30 patients and the duration of my study was 36 months, that is from 2019 to 2021. And methodology. When the patient came with the complaint of hoarseness of voice and vocal fatigue, we did stroboscopy of this patient in OPD under local anesthesia. And then after diagnosis, the patient was posted for microlaryngoscopy under general anesthesia in OT. Then inclusion criteria of my study is benign glottic lesions. And exclusion criteria of my study is glottic malignancy and recurrent respiratory papillomas. These are few cases which I want to discuss in my study. First is, in this case, when stroboscopy was done, it showed that there was a vocal fold cyst on left vocal fold and contact lesion on right. But when the patient was posted for microlaryngoscopy, it showed that there was a cyst on left vocal fold, but hypertrophic lesion on right vocal fold. So it needed additional management. And in second case, we can see that the stroboscopic finding shows there is a sulcus on right vocal fold. But when the microlaryngoscopy was done, it was seen that there was a fit on right vocal fold. In next case, we can see that the stroboscopic finding shows sulcus on left vocal fold. But when the patient was posted for microlaryngoscopy, it shows that there was sulcus on bilateral vocal fold and we needed additional surgery for this patient. In this case, in next case, we can see stroboscopy finding shows that there is a hemorrhagic cyst, which seems to be arising from left vocal fold and also involving anterior commissure. But when the microlaryngoscopy was done, it was and when the hemorrhagic cyst was retracted, it was seen that it was arising only from the left vocal fold, and the anterior commissure was completely free. In the next case, we can see that stroboscopy finding shows that there is a sulcus on right vocal fold, which is very shallow. But when microlaryngoscopy was done, we could see that the sulcus was very deep. It was so deep that it was reaching up to the muscle. In this case, we can see that granulation tissue is arising from anterior commissure, but microlaryngoscopy findings showed that the granulation tissue was arising from petiole of epidermis, whereas anterior commissure and bilateral vocal folds were free of the lesion. So my observation and results are as follows. There were 16 males and 14 females who had this benign glottic lesions, and maximum number of patients were in 30 to 39 years of age group. And this is the statistical analysis which was done using Mann-Whitney U test, which showed that 5 out of 30 patients findings were different in microlaryngoscopy. So our observation is that sulcus is most likely to be missed out on stroboscopy, and the sulcus on the medial wall of vocal fold are better seen on microlaryngoscopy after retracting the vocal fold. And the next is the depth of the sulcus is better evaluated on microlaryngoscopy. And next is that exact site of lesion is best evaluated on microlaryngoscopy. And in one patient out of 3 patients with contact lesions seen on stroboscopy, it was seen to be cyst on microlaryngoscopy. So my conclusion is that stroboscopy and microlaryngoscopy findings were similar in 84% of cases. And whereas in 16% of cases, additional glottic lesions were found, which required additional management. And surgical consent must be specially addressed for the hidden lesions, some of which may influence the extent of surgery. And proper evaluation and atraumatic palpation of the vocal fold is always recommended during microlaryngoscopy. So the take-home message of my study is that stroboscopy as well as microlaryngoscopy both are diagnostic criteria for the vocal fold lesions. But proper evaluation and atraumatic palpation of vocal fold is always recommended during microlaryngoscopy. So these are my references, and thank you.
Good morning, everyone. My respected judges, my dear colleagues. I am Dr. Shivam Sharma, and I'll be presenting my paper on coblation-assisted resection of tracheal stenosis, our experience. So, to begin with, tracheal stenosis has been a troubling problem for all our surgeons since time immemorial. Its etiology can be due to a variety of reasons, including prolonged intubation, tracheostomies, neoplasms, traumatic injuries, and idiopathic causes. With no gold standard management option to handle such cases, the surgeon is always in a dilemma, trying out a variety of techniques from the complete armamentarium. Various TRIDEV techniques include open and endoscopic approaches with various kinds of tools like laser, coblation, bougie or balloon dilatations, and the age-old cold steel instruments. In all, the treatment is aimed at relieving the airway obstruction, but re-stenosis remains the major issue post-intervention, hindering good outcomes and leading to multiple revision surgeries. Coblation is one such tool which is increasingly being used to treat various head and neck pathologies, both benign and malignant. We use this instrument to resect tracheal stenosis and documented our findings to evaluate the efficacy of this technique to deal with this difficult situation which has no definitive treatment. So our study consisted of 8 patients over a period of 4 years, starting from January to December 2013 to 16. It was a prospective study conducted at Savai Mansingh Medical College and Hospital in Rajasthan, India. All the patients underwent coblation-assisted resection of the stenotic segment of trachea. The stenotic segment was excised using laryngeal wand at an ablate setting of 5 and coagulation setting of 3. Care was taken to prevent any injury to the trachealis muscle posteriorly and avoiding exposure of the anterior tracheal cartilage. Details of all patients, including age, gender, presenting complaints, etiology, severity, diagnostic, imaging modality, and grading of the stenosis were recorded and evaluated. Our results concluded that there were 2 patients who were female and the rest 6 were males. All the patients presented with difficulty in breathing. 5 of these had prolonged intubation as the cause of tracheal stenosis. Of these 8 patients who underwent coblation, only 1 required just 1 surgery and has been asymptomatic since the last 15 months, the last follow-up we had, and is doing very well. 7 other patients have been operated more than once with the same modality, and 2 of these 7 had to be converted to open resection and anastomosis after 3 attempts with coblation. Mean follow-up was 8 months, 1 patient was lost to follow-up. Mean operating time for coblation assisted excision was 37 minutes, and the mean duration between multiple coblation procedures was 76 days. The patients who underwent resection and anastomosis had a mean duration of surgery 2.5 hours, and a minimum of 3 tracheal rings were resected. Montgomery tube was used in both the cases who are being followed up in our department, and these developed stridor after a short span of symptom-free interval. So these are the cases. You can see this is the 1 patient who is doing very well and required just 1 surgery, and these 2 are these patients who had to be converted to resection and anastomosis. So this is a video of what we were doing, the surgeries we are doing. So these are the vocal cords. The coblation wand is being taken inside. This is the site of tracheal stenosis. The stenosis is being ablated little by little. Our goal is to achieve patency and then achieve maximum lumen as possible without injuring the surrounding structures. Here we can see we have achieved patency. You can see the tracheal tube, tracheostomy tube lower down. And this is the final picture. You can see the tracheal rings down below. Yes. So coming to the discussion part, the incidence of laryngotracheal stenosis has been increasing significantly, but its management is yet a challenging task for the surgeon. A patient often presents to the surgeon with breathing difficulty, which she has manifested after being treating for a prolonged illness in an ICU setting. The patient has already undergone the trauma of hospitalization and expects from the doctor to solve the problem as early as possible. The surgeon finds himself amidst a worrying and distressed patient, a daunting task to deal with, and with no gold standard or proven therapeutic option to offer. With a lack of literature on the treatment of laryngotracheal stenosis, the surgeon tries different modalities of treatment which he has at his disposal. After any modality, restenosis remains a major problem. And one of the such studies, Andrew et al. In a study quoted the recurrence rates as ranging from 20 to 40% following open procedures and from 40 to 70% following endoscopic technique. Harrington et al. In a study involving 127 patients gave good results with open approaches, but they concluded that patients undergoing dilation for laryngotracheal stenosis might require multiple procedures. Serpahar et al. Reported the success rate of open procedures at 93%. Another historical modality reported was that of Wuji dilation by Jatho et al. In 1955. Lee reported 30-month symptom-free interval in patients treated with balloon dilation. With the advent of endoscopic surgery, Strong and Jacob were the first who described endoscopic carbon dioxide laser for managing tracheal stenosis. It has an increasing risk of airway fire, post-operative scarring, and thermal injury of underlying tissue. Recently, coblation as a technique has gained popularity among surgeons of various disciplines. Coblation is a unique method of delivering radiofrequency energy to soft tissue for application in ENT. Using radiofrequency in bipolar mode with a conductive solution such as saline, coblation energizes the ions to form a localized plasma near the target tissue. The overall effect results in tissue ablation and localized removal without much elevation in temperature, and the temperature rises only till 45 to 85 degrees centigrade, which is significantly lower than the traditional radiofrequency techniques. Chan et al., in a study of 10 cases of subglottic and tracheal stenosis, concluded that efficacy of coblation is comparable to that of other contemporary techniques. It is less risk of airway fire and local thermal tissue damage and improves surgery time compared with conventional techniques. On the basis of our study, we drew some points which needed to be kept in mind while planning a patient for coblation excision of laryngotracheal stenosis. Firstly, we must perform the preoperative assessment properly and document it so that it can be used in the primary treatment as well as subsequently if the patient requires further treatment. Because once a patient has been subjected to excision by coblation, the primary excision extent of stenosis is difficult to ascertain. If the patient is planned for a resection and anastomosis post-coblation, the results in our hands have not been very good. We speculate 2 reasons for the same. Firstly, restenosis starts affecting the central part of the patent trachea first, and then the peripheral part starts getting stenosed. So during resection, the surgeon may not excise a suitable segment length of the trachea, as the peripheral trachea has not stenosed till then. After surgery, however, the trachea gets stenosed and therefore surgery fails. Secondly, due to the cause of stenosis and coagulation, the blood supply and microvasculature of the tracheal wall may be affected, leading to hampered healing. Second finding we found was, during coagulation, care is taken neither to damage the posteriorly based trachealis muscle nor to expose the tracheal cartilage, as it may lead to scar formation, which in our experience constitutes a hard stenosis compared to soft granulations, which are more difficult to treat. So to conclude, coagulation is not a panacea for all ills, but it does provide us with a tool which can be used in a select group of patients. It offers a viable alternative to the surgeon who finds himself poised between the agony of excessive tissue injury and expertise with using laser and a slurry of complications associated with open tracheal resection and anastomosis. A large multi-centered randomized control trial is needed to reach to a conclusion regarding various techniques, weighing the pros and cons of each. These are my references, and thank you.
Greetings to one and all. My study topic for today is a demographical analysis of spasmodic dysphonia, a 10-year retrospective review. The study was done in Bombay Hospital and Medical Research Center, Mumbai. Now, spasmodic dysphonia is a focal laryngeal dystonia. It is an action-induced laryngeal movement disorder that affects laryngeal motor control. It is more prevalent in the female population, approximately 80% of the times. Spasmodic dysphonia presents as adductor type, which is most common, abductor dysphonia, and mixed dysphonia. Laryngoscopy and electromyography can help to establish a diagnosis of spasmodic dysphonia. Now, the laryngoscopic findings of vocal fold movement in adductor spasmodic dysphonia ranges from normal in very early spasmodic dysphonia to obvious bursts of hyperadduction during speech. In patients with abductor spasmodic dysphonia, a sudden abduction is observed corresponding with the breathy spasms on phonation. One main hurdle to find a cure for spasmodic dysphonia is the fact that the cause and pathophysiology remain unclear. The gold standard of treatment for adductor spasmodic dysphonia is botulinum toxin injection in the affected muscle, which causes chemodenervation with resultant weakening of the muscle spasms. Now, the aim and objective of the study was to evaluate the demographics of spasmodic dysphonia over a 10-year period at a voice clinic and to study the outcome in these patients following botulinum toxin injection. Now, it was a retrospective analysis of all the patients with spasmodic dysphonia who took botulinum toxin injection and visited our voice clinic over a 10-year period from January 2012 to December 2021. All the patients were diagnosed by the same laryngologist using flexible laryngostroboscopy and vocal exercises. The age, the gender, the geographical distribution of types of spasmodic dysphonia with or without tremors or other neurological conditions was also noted. Average duration of action of the botulinum toxin and average dose per vocal fold was also noted. So the total number of non-responders, that is, the duration of action of the botulinum toxin when it lasted for less than 2 months, despite of adequate duration of breathiness in the voice, was noted. The standard dose of 2.5 units botulinum toxin was injected bilaterally in adductor spasmodic dysphonia, and dose of 3.75 unit was injected unilaterally in abductor spasmodic dysphonia cases who came for the first time to a voice clinic. Following this initial dose, titration was performed depending upon the vocal response. The average dose was calculated using the most recent botulinum dose used for the patient. The data collected was represented as percentages for various parameters. Now, the results were as follows. Of the total sample size of 109 patients who took botulinum toxin injection, 61% of the patients were males, whereas 39% were females. The average age was 49 years. In 101 patients were diagnosed with adductor spasmodic dysphonia, out of which 12 patients were associated with tremors and 2 were associated with other neurological conditions. 5% of the patients were diagnosed with abductor spasmodic dysphonia and 3% were diagnosed with mixed dysphonia. In our study, 6.8% of the patients were non-responders. That is, the duration of the botulinum toxin lasted for less than 2 months. The average duration of action of botulinum toxin was 153 days. The average total therapeutic dose required for adductor spasmodic dysphonia per vocal fold was 3.8 units, and for abductor spasmodic dysphonia was 5.5 units. Now, our study revealed that spasmodic dysphonia in India is predominant in the male population, unlike the female predominance seen internationally as studied by Adler et al. But this may reflect social factors of males being the primary earning members and may not be a true representation of the general distribution as stated previously by Nerurkar et al. Geographically, 60% of the patients who came for the injection belong to the western parts of India, as our voice clinic is located in Mumbai, so most likely we are training patients from these parts of the country. Now, the standard dose of 2.5 units in botulinum toxin was injected bilaterally in adductor spasmodic dysphonia cases, whereas a dose of 3.75 unit was injected unilaterally in abductor spasmodic dysphonia cases who came for the first time to a voice clinic. Following this initial dose, titration was performed depending upon the vocal response. The average dose calculated in our study was the most recent botulinum dose used. The average total dose injected in adductor spasmodic dysphonia per vocal fold was 3.8 units, whereas for abductor spasmodic dysphonia was 5.5 units. Out of the 209 patients, aspiration was seen in 10 patients, which lasted for 5 days, and patients were taught safe swallow techniques. Blitzer et al. Studied over 900 patients injected with botulinum toxin, showed that the aspiration affected 15 to 60% of the patients, and this resolved in 1 to 2 weeks. We conclude by saying that the spasmodic dysphonia is common in males among the Indian population. However, this may be due to a social bias. The average dose titration per vocal fold for adductor spasmodic dysphonia required was 3.8 units administered bilaterally, and for abductor spasmodic dysphonia was 5.5 units administered unilaterally in our study. Thank you so much.
Good evening all. Today I am presenting my paper on identifying the association between reflux symptom index and reflux finding score in patients presenting with symptoms suggestive of laryngopharyngeal reflux. Brief introduction. LPN is defined as retrograde movement of gastric content into upper aerodigestive tract, was named in 1994 by Kaufman-Cummins. Approx 10% of the ENT clinic patients and 50% patients with voice complaints have been diagnosed with LPR. Basically, two main theories responsible for pathogenesis: the microaspiration theory, esophagobronchial reflex theory. Studies have also shown co-importance of acid pepsin and bile acids. Diagnosis: multi-channel interluminal impedance with 24-hour pH monitoring are considered to be the gold standard diagnostic investigations, but these being invasive, expensive, and time-consuming, recent studies focus on identifying diagnostic tools which are non-invasive and prompt. For example, RSI-RF is introduced by Peter C. Balfiski in 2002 and 2001 respectively. This is the RSI table, has 9 variables with a maximum score of 45. This is the RFS table, has 8 variables with a maximum score of 26. Management, basically 4 treatment modalities: lifestyle, diet, behavior modification, pharmacotherapy, and surgery. Aims of our study to identify the association between RSI-RFS in patients presenting with the symptoms suggestive of LPR, determine efficacy of 3 weeks PPI challenge test, and if 3-week PPI challenge test can be used as an OPD-based diagnostic tool for LPRD. Materials and methodology. This is the prospective observational study conducted in Department of ENT in Medanta Medicity, Gurugram after obtaining IRB's approval. The study was conducted over a period of 14 months from Feb 2017 to April 18 with a sample size of 135 patients. Inclusion criteria includes patient within the age group of 18 to 75 years with throat symptoms suggestive of LPR as per RSI questionnaire for at least last 1 month, with RSI equal to or greater than 13 and willing to be a part of study. These were the exclusion criteria. After making necessary exclusion, informed written consent of enrolled patients were taken. Patients were asked to fill up RSI form. Detailed history was taken. General basic examination, thorough ENT examination were performed. The guide cohort of the study conducted laryngoscopy examination of participants with 70-degree 4 mm rigid Karlsruhe telescope under topical anesthesia in outpatient clinic. Total RFS score was calculated. Participants were then prescribed 20 mg of ribiprazole twice a day for 3 weeks. Along with medication, participants were also instructed to make some lifestyle, diet, behavioral modifications as per pamphlets provided to them. Patients were followed up after 3 weeks plus minus 5 days of initiating PPI PPI therapy and again asked to fill RSI questionnaire. Investigators again performed 70-degree laryngoscopy in a standard manner. The findings were recorded in RFS form. The improvement in symptoms and signs were recorded. Mean of each group pre and post-treatment RSI, pre and post-treatment RFS were calculated. Statistical analysis were performed using students' t-test and paired t-test. Pearson's correlation was applied to test the relationship between the real valued variables. Those who responded were asked to continue the treatment for next 3 months and then gradual tapering of PPI was advised. Those who did not respond or worsen were evaluated for other pathologies and necessary referrals were made. Results: total 135 patients meeting the inclusion criteria were enrolled with the study. Youngest patient being 23-year-old, oldest being 73-year, with 60% of the patients belonging to age group of 41 to 60 year with mean age was 47.7 years. 47% patients were male, 53% were female, 20% of the patients were self-employed, 40% were working on salary basis, the remaining 40% belong to others, which include students, retired personnel, housewives, etc. There was history of smoking 24, tobacco chewing 17%, alcohol intake in 10% of the patients. Following diagram shows the prevalence of individual symptoms and sign at first visit. Clearly evident from the bar diagram. The most common symptom at presentation was parosis dyspepsia, with dyspnea being the least common symptom. The most commonly noticed laryngoscopic finding at presentation was posterior commissure hypertrophy, with granulation being the less commonly noticed sign. 90% of the study population had RFS greater than 7 at presentation. After 3 weeks of PPI therapy, patient had 91% of the patient had symptomatic improvement, 7% didn't show any response, whereas 2% of the patient showed worsening of symptoms. The symptoms which failed to improve, in fact, worsened were excess throat mucus, PND, and recurrent throat clearing. Laryngoscopic findings improved in 82% of the study population. No improvement was seen in 12% and worsening seen in 6%. Mean RSI pre 3-week PPI therapy was 16.74, which reduced to 7.12 post therapy. The mean RFS before therapy was 11.26, which reduced to 8.75 post therapy. Out of 135, for 24% patient failed to adopt dietary lifestyle behavior modification due to several reasons. The pre-post therapy RSI RFS were 16.5, 6.5, and 10.7, 8.8 respectively. The above figure shows that these patients did have symptomatic improvement, but they failed to show significant finding resolution on laryngoscopy. Discussion of purpose to carry out this prospective studies to determine if RSI RFS correlate. Many clinicians consider empiric medical trial as a reasonable approach to diagnose LPR. However, recommendation is a PPI twice daily for at least 3 months. But prolonged PPI therapy is not free of side effect and has proven to cause side effects like abdominal joint muscle pain, atrophic gastritis, B12 deficiency, osteoporosis, infections like cholera, etc. Hence, we conducted this study including shorter duration of PPI. Our study also tried to evaluate the efficacy of 3 weeks PPI therapy, thereby concluding if it can be used as a OPD-based diagnostic test for LPRD. Majority of the study populations were female. This correlates with the study by Peter Belfiski, Pokril, Lam et al. It is unclear whether this finding represents gender-specific reaction of laryngopharyngeal mucosa through reflux or if females have low sensitivity threshold for LPR symptoms. Maximum subjects belong to age group of 30 to 50 years. Possible reason may be that they are most economically active under stress, erratic lifestyle, therefore seek medical care early. Our findings imply that irrespective of job profile, working or non-working, people suffer from LPR. A significant proportion of the study population had addiction history. This is in concordance with the studies by Talley, Watanabe, and Karilas et al., which described relationship between cigarette smoking and prolonged acid exposure, decreased alliostone and salivation. Alcohol too worsens heartburn, as described in a study by Pahel et al. The most common symptom in pre-PPI therapy patients as per our study were heartburn, chest pain, dyspepsia. This is in contrast to studies by Anuja Bhargava, Sushil Gaur, Belfiski, as per whom LPR patients lack classic GERD symptoms. Studies have proven the symptoms such as dysphagia globus, PND, hoarseness are not necessarily caused by primary ENT disorder. Instead, may be predictors of systemic or gastroesophageal disorders like hiatus hernia, H. pylori, positive ventral gastritis, allergies. Similar to studies by Peter Belfiski, Carlos de Silva, the most commonly noticed laryngoscopy finding in our study were posterior commissure hypertrophy. The PPI of choice in our study was rabeprazole, owing to its fastest onset of action, as concluded in a study by Dadabhai, it being the most potent PPI, as concluded in the randomized control trial by Lam et al. We noticed a significant decrease in symptoms, signs of LPR post-PPI therapy in concordance to studies by Weber and Camel. On detailed statistical analysis of our data, we found a positive correlation between RSI RFS in contrast to studies by Tamiri Musallam, Silva et al. This study has a few limitations. For the study lacked the placebo group to serve as a control. Second, RSI RFS suffer from a lack of specificity for LPR. Several signs of posterolaryngal irritation, which are considered classic for LPR, were present in high percentage of asymptomatic individual as well, and vice versa. The inter-intra-observer variability in identifying the Langian findings and the severity. Conclusion: from this prospective study, we conclude that there is a positive correlation between RSI and RFS at both instances at the presentation, and after 3 weeks of PPI therapy, there was a considerable resolution of symptom and signs of LPR post-therapy. Hence, 3 weeks PPI challenge test can be used as an OPD-based non-invasive diagnostic test, reserving invasive gold standard investigations for the refractory cases. These were the references used for my study. Thank you.
Greetings to judges and audience. I am Dr. Vijay. The topic of presentation is diagnosing vocal cord paralysis. How to crack the tough nut in the right way. Vocal cord paralysis is characterized by partial denervation of the vocal cord, resulting in compromise of the glottis function to variable degrees. The diagnosis of this condition is more challenging to make than vocal cord paralysis. There is no single sign that can conclusively prove vocal cord paralysis. It is the subtle signs noted in multiple parameters of endoscopic examination that helps to clinch the diagnosis. High index of medical suspicion should be borne in mind. It can have a significant impact on the quality of life of the patient. The true incidence of this condition is difficult to estimate. It is a clinical spectrum characterized by breathy voice, increased effort on phonation, difficulty speaking in the presence of background noise, speech problems, and odynophonia. There may be an upper respiratory tract infection preceding the onset of paralysis. But the associated swallowing problems, like in case of vocal cord paralysis, are rare. If the sensory nerve involvement is there, it can result in pain, cough, globus sensation, and laryngospasm. In the new era of COVID-19 pandemic, more and more cases of vocal cord paralysis as well as paralysis are being reported. So a otolaryngologist should be competent enough to identify and pick up these cases. Moving to the aims of the study. Number one, to identify the endoscopic signs that are most helpful in diagnosing vocal cord paralysis accurately. And number two, to assess the magnitude of underdiagnosis of this condition. We designed the study in two parts. The first part was done by analyzing 67 flexible laryngostroboscopic video files of vocal cord paralysis patients in a study period of 5 years. Parameters that were assessed: demographic details, site, presence of phonatory gap, deep ventricle, atrophy of vocal cord, and bowing of vocal cord. We noted two kinds of movement: arytenoid adduction asymmetry. This is a case of left-sided paralysis with right over-adducting arytenoid. Now, this is a case of right paralysis with left ventricular hyperadduction. All the cases which were having structural lesions and cases of incomplete mobility were excluded from our study. The second part of the study was done by adding 33 normal videos to this 67 videos. We made it into 100 videos. We de-identified them, blinded them, and given to 3 ENT surgeons, here referred as R1, R2, and R3, and they were asked to identify the presence and the site of paralysis. Statistical tools that were employed were Fisher's exact test and kappa statistics. Kappa statistics was used to identify the intra-rater and overall inter-rater agreement. In our study, we noted a higher male incidence, that is 70% of the population were male and 30% were female. And when the site of vocal cord paralysis were considered, left was predominant than right. Left was 64% and right was 32% and bilateral 3%. When we closely scrutinized the location of the phonatory gap, the most common finding was the gap at the level of anterior as well as vocal process level, followed by gap at the anterior level only, and followed a gap at the process level, and only one patient had gap in the interarytenoid region. We assessed for deep ventricles, atrophy, and bowing of vocal cord. However, the most number of patients had arytenoid adduction asymmetry, that is 72% of the patients. The association between the site of the paralysis and Arachnoid adduction asymmetry is highly significant with a p-value of less than 0.001%. Almost always happens on the healthy side. When we consider for a ventricular hyperadduction, it was seen in 49% of our patients. And it was also statistically significant with a p-value less than 0.001. And it can happen to affected side, healthy side, or even both sides. Out of the 3 reviewers, 2 had only moderate agreement, and third one was having substantial agreement. And when the inter-rater agreement was calculated, there was only a moderate agreement. Focal fold paralysis is a diagnostic development. The clinical course is presumed to be similar to focal fold paralysis. Focal fold motion anomalies carry the most clinical significance in the study by Christine et al. So what are the diagnostic tools in the armamentarium of the laryngologist? First one is flexible laryngoscopy, permitting physiological phonatory dynamics and wide variety of laryngeal gestures. Rigid laryngoscopy has a slight edge over flexible laryngoscopy in that it is having a superior optics. Stroboscopy is an excellent tool that facilitates frame analysis. Laryngeal EMG is the new advantage here, but it is highly dependent on clinician expertise for needle placement and interpretation. Sensitivity is less in case of paresis. So the practicing otorhinolaryngologist should be trained in identifying the exciting things that are happening in the posterior cortex. This is arachnoid adduction asymmetry. There are 3 types of movement: rocking movement, sliding movement, and rotating movement. What happens in a vocal cord paresis is that the corniculate cartilage of the healthy side come forward and reaches to the cuneiform cartilage of the opposite side, or just go beyond that. So that can be used as to identify the sidedness of paresis. You can see in this picture the right corniculate cartilage coming up and meeting the cuneiform on the left side. So we have to differentiate between innocent adduction arachnoid asymmetry as well as versus pathological. So in our case, it was pathological arachnoid adduction asymmetry because there was always a phonatory gap. Contralateral ventricular hyperadduction was noted in 80% of vocal fold paresis in the series by Nupur et al. Our study also had similar finding. Sadly, this condition is both misdiagnosed as well as underdiagnosed. Misdiagnosis was reported from studies by Sulika et al. And Kieseker et al. And Heman et al. Found that 46% was underdiagnosed by referring otolaryngologists. The percentage of correct diagnosis by the 3 raters in our study was 47%, 55%, and 67% respectively. So in summary, arachnoid adduction asymmetry is the most reliable sign of vocal fold paresis in our study. Vocal fold paresis is frequently underdiagnosed by a novice otorhinolaryngologist. We suggest a laryngology training for them to identify the presence and the side of paresis accurately. These are my references. So I would like to end this presentation by quoting the famous words of Francis Attenborough. It is the attention to detail that makes difference between average and stunning. Thank you for your patient attention.
Good morning. Today I would like to talk about the surgical approach for the management of tracheoesophageal fistula. Acquired tracheoesophageal fistula are abnormal communication that develop between the trachea and the esophagus later in life. It is an uncommon condition and is challenging to deal with. Etiological factors apart from malignancies include traumatic causes or due to granulomatous condition. Traumatic causes could be a blunt trauma resulting from a crush injury to the trachea and the esophagus, penetrating trauma, chemical trauma, iatrogenic trauma from surgical procedures or endoscopy such as bronchoscopy, esophagoscopy, or prolonged ventilations as a result of high pressure cuffs for long durations. Evaluation. Any patient coming with a clinical suspicion of tracheoesophageal fistula, we can do an endoscopy such as an esophagoscopy or a bronchoscopy to localize and identify the fistula. Radiological investigations such as the CT neck or the CT chest can be done. CT neck can be done for the location to know the extent of the fistula and for the presence of any esophageal dilatation. In cases of trauma neck, it also gives details about the laryngotracheal status as well. CT chest can be done to look for signs of aspiration. Contrast studies using water-soluble contrast materials can also be used for the diagnosis. This is our experience in successfully managing about 10 cases of tracheoesophageal fistula that were as a result of various non-malignant pathologies. 4 cases were from blunt trauma and 6 as a result of iatrogenic trauma. The blunt trauma cases as a result of road traffic accidents, and they have sustained multiple injuries and have been managed with ventilation and nasogastric feeds for long durations. Once they have been extubated and are started on oral feeds, they have developed features of aspiration and were referred to us. Iatrogenic causes, 2 were as a result of percutaneous tracheostomy, 2 after a prolonged ventilation, 1 after an upper GI scopy, and 1 after a tracheal stenosis repair. The prolonged ventilation cases here did not give any prior history of trauma and have been ventilated for other causes such as the opal poisoning. These are some of the cases that we have encountered. This is the case of a blunt trauma neck. This is the initial CT that we have got showing a cricoid fracture. And this is the endoscopy showing the fracture of the cricoid. This patient was managed with a laryngotracheal reconstruction along with stenting. 6 weeks later, on removal of the stent, the patient developed features of aspiration. This is another case that has developed a fistula as a result of complication of the T-tube. This is the endoscopy that is being done to the tracheostomy stoma. And this is the fistula seen at the posterior wall of the trachea. This is another patient, CT scan, showing a large communication between the trachea and the esophagus. This CT scan was taken when asking the patient to perform a Valsalva maneuver, and you can see the ballooning of the esophagus clearly. Coming to the surgical technique, all the cases were managed with a lateral cervical approach. A vertical skin incision is given along the anterior border of the sternocleidomastoid. The plane between the sternocleidomastoid and the strap muscles is dissected, and the sternocleidomastoid is retracted laterally. The omohyoid muscle, as you can see here, is dissected and harvested to be used as a flap for closure of the esophageal defect. The space between the trachea and the esophagus is entered, and this is the fistula tract seen in one of the cases. This is another case, the esophagus that is mobilized all around and pulled laterally, and this is the fistula's communicating tract. This is a case of a concomitant tracheal stenosis along with the fistula. And once the fistula is identified and dissected, this is the defect seen in the trachea. You can see the cuff of the endotracheal tube through the defect, and this is the defect in the esophagus. These are some of the videos showing the esophageal defect after the division of the tracheoesophageal fistula's communication. This is the defect in the esophagus, and this is the defect in the esophagus in another case. This is at the level of the pyriform fossa. Another case showing a very large fistula's communication. This fistula has been divided, and following the division, the defect area can be seen within the esophagus. This is a fistula that is being dissected, and this is the defect within the esophagus. This is the picture of the same case showing the large defect in the esophagus. Once the defect is identified, it is closed in 3 layers. Following the defect closure, interpositioning is done using a pedicled omohyoid flap. In larger defects, additional buttressing is done with the use of fascia. Here, the fascia lata from the anterolateral aspect of the thigh is being used. It is being wrapped around the esophagus and is sutured over the pedicled flap. All the patients were started on nasogastric feeds and were on the feeds for 10 days. And on the 10th day, all of them underwent gastrograph and swallow study. And once the confirmation of the absence of the leak was done, the patients were started on oral feeds. 2 patients had a transient recurrent laryngeal nerve palsy that has later recovered. Apart from that, all the patients were doing absolutely normal. None of them had any complaints or any recurrences and are on regular follow-up even now. Coming to the discussion, there are several approaches that have been described for the management of tracheoesophageal fistula, none proven to be the best. One of these is the lateral cervical approach. It is well-known procedure that we do for CP myotomies, foreign body esophagus retrieval, pharyngeal pouch excision, esophageal resections, for retropharyngeal abscess drainage and all. Its use in tracheoesophageal fistula has been limited in the repair of small defects. However, in our case, we were able to achieve good results even for larger fistulas. The anterior or the transtracheal is one of the other approaches. Its use can be justified in cases where there is an associated tracheal stenosis along with the fistula. But however, in an isolated tracheoesophageal fistula, it causes an unnecessary handling of the trachea, increasing the chances of trauma and stenosis. Coming to the decision on the closure depends on the size of the defect. Those that are less than 4 mm, we have done a 3-layer closure along with an omohyoid flap. And those that are more than 4 mm, along with these, we have also used a fascia for reinforcement. The key features that we have followed are: 1, we have approached from the left side of the neck, as the recurrent laryngeal nerve on the left side has a predictable course and there is a less chance of damage. And we have done the dissection staying close to the esophagus to prevent any injury to the recurrent laryngeal nerve and the major vessels. We have placed a nasogastric tube prior to the procedure so as to facilitate for better dissection and for the repair of the esophagus. And we have used, for the repair, we have used the buttressing technique to help us in better outcomes. I would like to conclude by saying the lateral cervical approach can be used for successful repair of the cervical tracheoesophageal fistulas of any size with good exposure of the entire esophagus from the cricoid to the level of the second thoracic vertebra with minimal tissue dissection. 3-layer closure of the defect using interpositioning with pedicle muscle flaps and fascia prevent the chances of failure and recurrences. These are the references supporting my presentation. Thank you.
Good morning. Today I'm going to speak on long-term assessment of voice outcome after surgical pitch alteration in transgender subjects. Gender as an identity of an individual is usually perceived in terms of voice, gait, hairstyle, mannerism, and to an extent clothing. This is a voice sample of a patient who has undergone sexual reassignment surgery, but in spite of attaining a beautiful physique, she is not able to identify herself because of this voice.
7, 8, 9, 10. And we haven't gone to my gym because I have to come over here, but my driver was ready. I don't know, miserable. His phone was.
So in order to identify themselves, these individuals have to undergo a lot of changes in their body, out of which voice feminization surgery contributes greatest to social acceptance of these patients. Distinguishing characteristics of voice which assign a gender to any individuals are these, out of which pitch is the most important factor. For a voice to be assigned as a female, it should lie between, the fundamental frequency should lie between 196 to 224 Hertz. Surgery to modify pitch are usually directed on increasing the tension of the cord, reducing the mass of the cord, increasing the length of the cord. Numerous number of voice feminization surgery have been described in literature. In 1983, it started with Ishiki, who popularized tensioning thyroplasty or type 4 thyroplasty, to modification of length, which was popularized by Donnell, where he created an anterior web with the help of cold steel instruments. Femolar is also a very famous surgery focusing on modification of the length. Aim of our study is to assess long-term outcome of tensioning laryngoplasty, to analyze the shift in habitual pitch after surgical procedure, and to evaluation long-term patient satisfaction with regarding to newly attained voice. It was a prospective study conducted on 8 individuals. Duration was 3 years. All individuals who were included should have voice therapy, a preoperative voice therapy, and hormone therapy. In addition, individuals who were undergoing additional voice feminizing surgery were not included in the study. Subjective outcome were measured on the basis of this questionnaire-based interview conducted at the end of 3 years. Objective outcome were studied on the basis of fundamental speech frequency and harmonic to noise ratio. Questionnaire was based on the perception of their newly acquired voice. How is the voice after surgery? Has it improved after the surgery? Speech therapy has speech therapy helped in improving their voice? Are they comfortable with their voice or not? Based on these factors, subjective scoring were given. This questionnaire is adapted from Matai V, a study conducted by Matai V in 2003. Now, this is a surgical video which is showing the procedure of cricothyroid approximation through a horizontal incision, where after exposure of the thyroid and cricoid cartilage, sutures were taken through the lower border of the cricoid cartilage. 3 sutures were taken. Tightening of the sutures dependent on the feedback after phonating, making the patient phonate, and attainment of the required or the targeted pitch. Now, this is a bar diagram which is showing the fundamental frequencies at different point of time interval. Preoperatively, the mean fundamental frequency was 150, which increased postoperatively to 243, an impressive figure. Then decreasing again at the end of 3 months to 219 and stabilizing at the end of 3 years to 203. This is a bar diagram which is showing the harmonic to noise ratio, where the preoperative value was 15.85, reducing to 12.14 immediately post-op due to the strained character of the voice, which is again increasing to 21.11 at the end of 3 months and stabilizing at 19.91 at the end of 3 years. This is a bar diagram which is showing the subjective outcome, where only one patient had this view that his or her voice is not better after the surgery, and only one patient had this fear of unmasking of their previous voice. Otherwise, all patients were comfortable with their voice now. Overall satisfaction was 100% in all the subjects. All the subjects were ready to recommend the surgery to their peer group, their family, their friends. Only 2 individuals were not identified as a female speaker in a social platform, and 1 individual was not satisfied with the scar after the surgery. This is a table which is depicting the results of cricothyroid approximation in studies in the past, where the longest follow-up was in our study and also in another study by Nicholas. In all these studies, the mean fundamental frequency specifically increases after the surgery, remains stable up to 6 months, but after that there is a fall in pitch, which is well corroborating with the data of our surgery also, where the mean frequency was 150 Hertz, which increased to 253, reducing to 219, and stabilizing at 203 Hertz at the end of 3 years. Subjective scoring done by using VHI-10 or other subjective scoring like decrease in the speech effort or improved sound in the voice and decrease in the interference, all these subjective scores were seen to be improving post-operatively, well corroborating and concurring with our study, where 75% of the subjects were well accepted as a female speaker and all have comfortable voice. Shimmer, jitter, or signal to noise ratio, these factors which qualify the quality of voice were also said to seem to be improved post-operatively, which is mirroring the effect of which we have seen in our study, where the values of HNR have increased from 15.85 to 19.11 at the end of 3 years. To conclude, this is a study of longest follow-up on this subject in Indian subcontinent. Cricothyroid approximation definitely increases the fundamental speech and also maintaining the increased pitch up to 3 years at least. Speech therapy is an integral part of the treatment packages for these subjects to be offered pre-operatively also and post-operatively also. There is a fall of fundamental pitch, which is a documented factor. But in spite of that fall, these clients remain to be very, very comfortable in projecting their voice in social platform after this surgery, even during their emotional behavior, during reflexive behavior, while crying, while laughing. So, which is the ultimate goal of our surgery? That is to help these individuals to attain the identity, what they want. This is an image of a happy patient of ours, and this is a voice sample of a patient pre-operatively. And this is a voice sample of the same patient post-operatively at the end of 3 years.
তাই বারবার ডুয়ার্সে এলেও কখনো ক্লান্তি আসে না, প্রত্যেকবারই মনে হয় পরের বার।
Thanks.
A very good morning to respected teachers and dear colleagues. Today I'm going to talk about voice practice in COVID era. Now, in the context of recent times, this quote holds a special significance as we will realize later. COVID-19 began in China in the end of 2019. As the virus spread globally, the WHO declared it a pandemic in March. Aerosol and droplets were the harbinger for infection, posing significant hazards for doctors and staff of the voice clinic. Sudden shutdown, the lockdown, and cessation of non-emergency healthcare services with abrupt change in the lifestyle of doctors, spending their time in COVID ward, wearing PPE suits, and redistribution of staff in the COVID ward from the non-emergency services led to cessation of voice clinic in the initial part of the pandemic. But we adapted to the change. The voice clinic was revamped and added safety measures of patients and doctors installed in the practice using vent masks for the procedures. Implementation of the virtual voice therapy in which the therapist and the patient were at their home interacting on a virtual platform and so that the footfall at the hospitals are reduced. And this phase was a transition for doctors and patients alike. The objectives of my study are to highlight the effect of pandemic on voice practice and look into accessibility and delay in treatment through a questionnaire-based survey. It was a retrospective observational study, and the group A consists of the COVID era voice clinic patients from April 20 to March 21, while the group B was the pre-pandemic era. In the same time period, patients were evaluated. The patients with benign vocal fold lesions were included in the study. Follow-up patients of voice therapy were excluded. A questionnaire was developed for the group A. It was adapted from the Likert scale. Emphasis was given on the age, gender, distance from the clinic, and the diagnosis. Informed consent was duly taken, and a telephonic survey was done. This was the pattern of the questionnaire, and the reasons of delay of consultation was categorized into external factors, COVID-19 related, and voice problems related. The delay in laryngoscopy, the factors were also listed so that the patient could analyze which was the factor most suited to them. And satisfaction to the virtual voice therapy was also documented in the questionnaire. The frequency and percentage were calculated, and Mann-Whitney chi-square tests were used to compare the demographics. Level of statistical significance set at 0.05. As the results showed, they showed a pattern that the initial 3 months that there was sudden healthcare collapse in which there was no patient in the voice clinic, and gradually the non-emergent healthcare services resumed. And over a period of 1 year, we adapted to the new normal in which the increased cost and increased safety and virtual therapy was accepted into the normal routine. The results showed 60% reduction in the footfall compared to the pre-pandemic level. 30 out of 47 patients delayed the first consultation as it was not hampering their daily activities, while half of the patients listed limited slots of stroboscopy for delay. As we can see, we saw 118 patients prior to the pandemic, while we saw only 47 patients in the pandemic era. And the number of females drastically reduced into the pandemic. And as we can see, compare the age, the patients aged more than 40 years were very less in number in the pandemic era. They were they had a fear of contracting the infection while visiting the clinic, supposedly. Now, distance from the clinic also played a vital role. As we can see, the patients from outside the city were significantly less in the number in the COVID era. But urban people utilized the healthcare system in the pandemic in a better way. Now, the frequency of the different diagnoses did not change significantly during the prior pandemic era as compared to the previous year. 47% of the patients did not have access to the transport during the pandemic, and 77% patients had a fear of COVID infection at the clinic. Added cost of infection was a cause of concern in 53 patients, while a whopping 91% patients were satisfied with the virtual voice therapy. So, coming to the discussion, the delay in the voice clinic services was expected because, and uh, and as the non-emergency services gradually resumed, we and we analyzed that a questionnaire provided valuable input in assessing the COVID impact. We came to realize that the females prioritized, uh, but the females did not access the voice services in the pandemic era. The patients older than 40 years did not come for visits in the pandemic era, and patients outside the city could not access the services. Now, there was a similar study published in the European Archives of Rhinolaryngology in 2021, in which they had debated whether the virtual voice clinics are helpful or not. They came to a conclusion that the patient have high satisfaction with virtual consultations, but face-to-face clinics are superior to the virtual clinics. In our study also, we came to the fact that face-to-face voice therapy is not replaceable because the endoscopic evaluation, palpation, and breath support assessment is very crucial for the success of the voice therapy. So, coming to the conclusion, we have all come to realize the distinct and profound effect of the pandemic over everybody. The new normal is now an accepted thing in which increased safety measures and usage of virtual platforms for voice therapy is here to stay. Our survey gives an idea for handling any unprecedented healthcare crisis in the future, and be it recurring waves or a new pandemic. These are my references, and thank you for the patient listening.
It was indeed an exuberant bundle of paper presentations. Thank you all. The presenters can download the certificates from the platform. Now, may I request Dr. Amitabha sir to start off with the valedictory function.
Thank you, the entire team of PHONOCON. This brings us almost actually to the end of this wonderful academic feast that we have had in last couple of days. So coming to our valedictory function, first of all, I would like to congratulate the team PHONOCON, the organizing team of PHONOCON, for having organized, especially we can see Dr. Jagannath, the organizing chairman, Dr. Sanjay Subaya, they are here. You can see them on the screen. They have had extreme hard work for last 2 years, as Dr. Sanjay Subaya said, that this was planned to be in 2021. And instead of 2021, COVID has pushed this, but these organizing team had the determination to conduct this event, and they have conducted in one of the best probably digital events that we have had in COVID era is this PHONOCON. So on behalf of the Association of Phonosurgeons of India, I would like to congratulate and we express our heartfelt gratitude to this team for having organized such a wonderful thing. I would also like to thank our FC orator, Dr. Steven Zeitels, our keynote speaker, Andreas Muller, and our guest speakers, Dr. Shigeru Hirano and Dr. Tanya Mayer, for sparing their valuable time and contributing so much to the academic content of this conference. We have also had a great pleasure of having a galaxy of national faculty who are, I mean, all experts in their own field, and they have contributed so much to the program. Not to mention the 100+ interested speakers who have volunteered to present their work in this forum in the various award categories. All credit again goes to the organizing team for having such a good number, but also I congratulate the entire 100+ participants who have who have enlightened the conference by presenting their original work. And it is extraordinarily good standard of the award sessions that we have had. In addition, I would also like to thank, we can see Dr. Smita, the joint organizing secretary. I forgot to mention her name. She has been looking at the entire academic and the award paper section, in addition to all other things. Last but not the least, the IT team, Avyaya Medicon. I'm sure, ladies and gentlemen, you have seen how flawlessly the conference has been conducted. And this is just a wonderful academic feast, which there was no glitch almost in the entire organization of the event, and the entire credit goes to the team, Avyaya Medicon. I congratulate them as well. And last but not the least, all the delegates who have joined us in this conference. In addition, I would like to also say that please join Association of Phonosurgeons of India, all the delegates who have joined this conference. As we said, we are now a rich group, 6 people, and please enrich us. And please also, so much of academic work has come out from the country, from all corners of the country. Please send your publication please send your work for publication to our journal, which is the International Journal of Phonosurgery and Laryngology, again to enrich our academic content of this association. I would now like to invite Dr. Gautam Khaun, our Vice President, to say a few words.
Thank you, Dr. Amitabh. First of all, again, I'd like to congratulate the entire organizing team, the chairman, the organizing secretary, the joint organizing secretary, and all others who are involved in the success of this PHONOCON 2022. It has been success not only in maintenance of time, in the variety of speakers, in the variety of topics that have been covered, from voice, airway, and swallowing. And also to note is that we have had a buffet of new speakers, very new speakers who have spoken very well in this conference. And I should credit Dr. Sanjay Subaya for actually picking up people from various corners of the country. And these are our future gems. These are the people who are going to make APSI stronger in the long run. The only thing missing in this conference is probably the bonhomie, the cup of coffee, and sharing a joke in the corridor while you change halls. That is the only part that is missing. Otherwise, it's absolutely flawless.
Beer in the pubs of Bangalore.
Thank you very much for taking all the effort and conducting the conference at such a high level. Thank you very much.
Thank you, Dr. Gautam, our Vice President. Now, may I request Dr. Unnikrishnan Menon, our Honorary Secretary of APSI, to share his thoughts.
Please unmute.
You need to unmute yourself, Dr. Menon. Thank you.
Yeah. So thanks, Amitabh. When you asked me, I thought, I'll just say one or two sentences. But President, Vice Presidents have said everything that has possibly to be said about the fantastic 2 days of academics that we have had. So just recall Dr. Sanjay in his vote of thanks saying about how it had begun and how there's a lot of confusion online, then hybrid, and we also part of all those discussions. Now, looking back, I think in one way it was very good that it was online because we've sort of set a benchmark how smoothly and efficiently and successfully a pure online conference, inclusive of all components, international faculty, surgical videos, and award papers. All of these have been included in a conference in 2 days. And as Amita pointed out, glitch free. So I've been in touch quite frequently with Mr. Anil over the last 1 week. So special hats off to him also. And of course, and all the other people, but as personally, very much in touch with Mr. Anil quite frequently. So yeah, Sanjay, great job to you and all the team. Let's hope that the good work of APC and PHONOCON continues.
Thank you,
Sanjay.
Thank you, Uni. Before we hear from, in case the President, Organizing Chairman and Secretary wants to speak, we have not heard from Dr. Smita all these 2 days. She has been working just from backstage. So we can request her to share her thoughts of how she has enjoyed and how she felt. Dr. Smita.
Sir, thank you, sir. Thanks for giving us an opportunity. On behalf of our organizing committee, I thank you all and the delegates and the speakers for making PHONOCON 2022 a success. And this is for the delegates. Whoever have registered, they can view the recorded version on the platform, which will be there for another 2 more months. So thanks to all of you all from our committee.
So any other comments from any organizing team members here?
No, the certificates are there on the platform. All delegates can download the certificates. They can type their email address and download it.
Thank you. Dr. Jagannath, anything else to add? Otherwise, we'll... Thank you.
Thank you, sir. No, nothing.
So now another most awaited event comes, which is the declaration of our award paper results. I have the privilege to declare the results, and I must admit to everyone and all the delegates who are attending that we have got the feedback from the judges of all sections that this was a wonderful quality paper. And if I may start announcing, the first is senior consultant. The award goes to Dr. Mukundan Subramanian, who presented on standardized endoscopic swallowing evaluation for tracheostomy decannulation in patients with severe acquired brain injury and disorders of consciousness. Congratulations, Dr. Mukundan, for this wonder paper. And next we go to our PG sections, which is actually, I would, if you could zoom it a little bit, I can read from here. That's brilliant. Okay. So yeah, next is Rising Stars, which is the most prestigious award session of the FC conference. And the best paper award goes to Dr. Asitama Sarkar. Congratulations, Dr. Asitama. She presented on correlation of narrowband imaging findings using NI and European Laryngeal Society, that is ELS classification during office flexible laryngoscopy with histopathology. Real eye-opener kind of a presentation it was. The second best paper award goes to Dr. Deepa Shivnani. She presented again on a very new new point of care ultrasound, which is POCUS, an alternative to rescue laryngoscopy in evaluation of pediatric airway. Again, I think this is going to come in a long way in the future, probably. And the third position, or the best paper 3, goes to Dr. Raghavi Vishnu Prasanna, which is a paper on false vocal cord adduction, the harsh truth. Again, congratulations, Dr. Prasanna. Coming to PG award, the best paper award goes to Dr. Surabhi VR, who presented on stride into stridor, cyst in the larynx causing acute airway obstruction. Congratulations, Dr. Surabhi, for securing the best position. The best paper 2 position goes to Dr. Ramaya B. Again, she presented on assessment of swallowing in patients with stroke using flexible endoscopic evaluation of swallowing, a very upcoming and very popularized method at the moment. Interestingly, the best paper 3 position for PG categories was tied, and 2 people have secured the same position, which is Dr. Himani Bhatt, who presented on external laryngotracheal trauma presentation and management. This position is also shared by Dr. Raiza S., who presented on a comparative study on the outcomes of early and delayed type 1 thyroplasty following unilateral vocal cord palsy. Both, again, very nice paper. Congratulations to all the position holders in the PG category. Then there was quite a few papers for SLPs, that is speech and language pathologist oral presentation. And the best paper award goes to Ms. Sandra Santosh, and she presented on development and validation of xerostomia inventory for glossectomy, a preliminary study for speech language pathologists. Again, a very prudent subject, which there's going to be more development in this paper. Coming to e-poster for doctors, the best position goes to Dr. Baisakhi Bakat, who presented on efficacy of Kashima surgery with CO2 laser versus coblation for bilateral vocal cord paralysis. This topic was discussed in the conference as well, and video shows. So this is a very upcoming and a very prudent topic at the moment. Congratulations, Dr. Baisakhi Bakat. The second best position goes to Dr. Meena Vishwanath Kale, who presented on necessity is the mother of invention, a novel customized Joshi laryngeal stent for airway reconstruction surgery. Again, very useful. It's going to be in Indian context if this stent is popularized and patented. Third position, or the best paper 3, goes to Dr. Sai Balsare Kaluskar, who presented on prevalence of voice disorders in COVID-19 era of universal masking in healthcare workers and others. I think there are more papers. In fact, this conference has a lot of papers on COVID-related issues, and that shows that we've had a lot of work on COVID. And the finally, e-poster for speech and language pathologist. The award goes to Ms. Priya Kapoor, who presented a journey from no food to more food, a single case study on dysphagia rehabilitation. So heartiest congratulations from the organizing team, from Association of Phonosurgeons of India, to all the award winners. You will receive your e-certificate for this award in your registered email from the organizing committee, and the best position securing person in each category will also receive a medallion from the Association of Phonosurgeons of India, which will take some time, and it should reach you by post. Thank you, everyone, and congratulations to all of you again. I would now conclude. Hopefully, we have come to the complete end of this program, and we would conclude PHONOCON 2022, bidding goodbye to all the delegates, all the organizing team, all the IT members of the team, hoping to see you all physically in Thiruvananthapuram in PHONOCON 2023. Goodbye. Long live Association of Phonosurgeons of India. Namaskar.
Doctor, can we end the meeting, Sanjay sir? Venu, stop the live stream in the both halls. Hello?
Okay, sir. Hello, sir, in Zoom call on both YouTube and Zoom call.
Venu?
Yes, sir.
Stream has been ended, right? In both halls?
Okay, YouTube and Zoom. Okay.
Yeah, both. You end the meeting in the Zoom and end the stream in the YouTube.
Yeah. Okay. Sure.
Thank you, Venu.
Yeah. Thank you, sir.
Thank you.
Thanks a lot, Venu.
Thank you.